And interestingly, patients whose RET mutation status was unknown tended to do better with with cabozantinib compared to placebo. And my suspicion is that many of them had a RET mutation, simply was not detected. More recently, there have been specific RET inhibitors that have been approved. And the first one was selpercatinib, which was studied in the phase 1-2 study, 162 patients, either previously treated with vandetanib or cabozantinib or both. Another cohort had untreated patients, and a third cohort had RET mutation, previously treated thyroid cancer, which is not medullary. The main side effects of selpercatinib included dry mouth, hypertension, diarrhea, and fatigue. And the response rates of previously treated patients was about 70%. Untreated patients was similar. And of the 19 patients with other thyroid cancer, the response rate was about 80%. And you can see here, both in the previously treated group, the untreated group, and the thyroid cancer group, you can see that the vast majority of patients responded. And the duration of response was quite good. The duration of response and the median progression-free survival was not reached at 2.5 years. So based on this, selpercatinib is one of the favored drugs for treatment of medullary thyroid cancer. Pralsetinib is another similar RET inhibitor. Similar study, 95 patients, 61 were treated with either vandetanib or cabozantinib, 23 were naive, and 11 patients with thyroid cancer. Side effects here too were dry mouth, hypertension, diarrhea, and fatigue. And response rates were 60% in the previously treated group, 71% in the treatment naive group, and almost 90% in the thyroid cancer group. And so in this study, again, you can see the waterfall plot here. Almost everyone had a shrinkage in the lesions, regardless of whether they had treated, untreated, or thyroid cancer. And again, in this study here as well, the median progression-free survival and the duration of response were not reached. So this is another option for patients with medullary thyroid cancer today. Switching gears to adrenocortical carcinoma, these are a very small fraction of adrenal neoplasms with a peak in childhood and a plateau between 40 and 50 years of age. Unfortunately, median survival is only 3 to 4 years. And if it is localized to the adrenal cortex, the 5-year survival is about 80%. For locally advanced disease, it's about 35 to 50%. And once you have distant metastasis, the 5-year survival is less than 25%. These are the various pathways that have been thought to be important in the pathogenesis of adrenocortical carcinoma: ZNRF3 inhibition, beta-catenin inhibition, PRKR1A inhibition, CCNE1 inhibition, TP53 inhibition, and TERF2 inhibition. And each of these activates a different pathway. The ZNRF3 activates the Wnt signaling pathway, beta-catenin stimulates the Wnt and the MAP kinase ERK positive pathway, PRKR1A stimulates the MAP kinase ERK pathway, CCNE1 stimulates the retinoblastoma 1 pathway, TP53 stimulates the P53 and the beta-catenin pathway, and then TERF2 stimulates the AKT pathway. All of this leads to tumorigenesis and final development of cancer. None of these are targetable today, but there are potential options that could become treatments in the future. And you can see here, there are multiple different pathways with multiple different drugs that are available here in orange that could potentially be used. And while none of them is currently approved for adrenocortical carcinoma, many of them are currently being studied. So in summary, molecular testing can help guide management of thyroid nodules. Lenvatinib and other multikinase inhibitors are effective in radioiodine refractory thyroid cancer. Vemurafenib is a possible option in BRAF V600E mutated radioiodine refractory papillary thyroid carcinoma. Selpercatinib and pralsetinib are the treatments of choice in medullary thyroid cancer. And while there are multiple pathways that seem to be involved in adrenocortical carcinoma, they are all under investigation, and hopefully we will have some targeted agents for these cancers soon. With this, I'd like to thank you all for your attention.
Thank you, Dr. Appar. That was quite a comprehensive review on relatively unknown or lesser studied endocrine cancers. And since we are having a mixed gathering of oncologists and endocrinologists, I thought this was a very important and a very relevant discussion. If there are any questions for Dr. Dr. Apar is not live. He is because of the time zone difference. So in case there are any questions for the speaker, please mail them or please send them through the chat box. I will pass them on to Dr. Apar and then we can have answers for it. Can we now move on to the next one? Yeah. So the next speaker is Dr. Nilesh Lokeshwar, another old friend of mine who's actually had the best of two institutes. Dr. Nilesh worked in Tata Memorial Hospital with us and then moved on to All India Institute of Medical Sciences to pursue his DM in medical oncology. So he's had best of the two great institutes in the country. And he's now practicing currently in Mumbai in the Lilavati Hospital and at a place and his own chemotherapy center at Dadar, and he's attached as a teaching faculty at the MGM Hospital, New Mumbai. Dr. Nilesh is not here, but he's sent his recorded video. So can we have Dr. Nilesh's presentation, please?
Good morning, and at the outset, I'd like to thank Dr. Chetan Deshmukh and Dr. Vaishali Deshmukh for having invited me to this year's Synapse 2023 meeting. I'll be speaking about menopause and the cancer link. So menopause is the normal natural event that is defined as the final menstrual period confirmed after 1 year of no bleeding. No menstrual bleeding. It represents the permanent cessation of menses that results from a loss of ovarian function, which is typically due to aging. The average age, which is international figures, this is age is 51 years. In India, we see it a few years earlier. The average age for menopause in Indian women is about 46.2 years. It can also occur due to a medical intervention, for example, a surgery involving bilateral salpingo-oophorectomy, also chemotherapy. Although the effect of chemotherapy on menopause is not always reliable and not always permanent. It can also occur due to an impaired ovarian function. At menopause, there are several hormonal changes that occur. The most important is a decrease in the circulating estrogen, which leads to a decrease in the ratio of the estrogen to androgen. There is also an increase in the peripheral aromatizations of the DHEA to estrone, and therefore there's a reversal in the estradiol to estrone ratio. The testosterone levels, however, there are no changes. And the results of these hormone changes are what we see as clinical features during menopause, and this affects almost 2/3 of all women. The common ones are menstrual irregularity in the perimenopausal period, vasomotor disturbances, musculoskeletal effects, psychological effects, urogenital effects, for example, vaginal dryness and incontinence, and the long-term effects of cardiovascular health and osteoporosis. Breast disease is commonly seen in this group. However, the occurrence of a lump in the breast in a postmenopausal woman should always be evaluated for cancer, because benign breast disease is generally uncommon in this age group. So these effects occur over a varying period of time. There are short-term symptoms. For example, the hot flushes, the mood, sleep, and the cognitive changes usually come early in the perimenopausal period. The urogenital symptoms also come around that time, but persist for a longer period of time. There are symptoms, there is often subclinical evidence of cardiovascular disease and osteoporosis, which again increase with time. And over a longer follow-up, after a few decades, the cognitive decline is seen in patients, which includes dementia and Alzheimer's disease. To offset these symptoms and to prevent some of the consequences of menopause, menopausal hormonal therapy, also known as hormone replacement therapy, has been commonly used. But there has been a lot of controversy regarding the use of replacement therapy and the increased incidence of breast and ovarian cancer. However, there is some recent evidence that says that it's probable that this risk has been overestimated. In fact, a recent publication in Lancet showed that in patients who use predominantly estrogen-related hormone menopausal post hormone replacement therapy, there is no increased risk of breast cancer. In fact, the breast cancer risk actually decreases. There have been several epidemiological studies. I'll be mentioning one of the important ones, which is the Women's Health Initiative. This was a prospective study in which almost 27,000 women were followed up over several years. And this included two groups of women. Those who had an intact uterus were given estrogen along with medroxyprogesterone acetate. And those patients who had undergone a hysterectomy had received only estrogen. These patients were followed up for several years, and they were compared with patients who were on placebos. And this graph shows us the effect on the risk of getting breast cancer. Figure A shows the risk of patients who received only conjugated equine estrogen in the trial. And as you can see, for the increased risk of breast cancer, the hazard ratio was 0.76, indicating that there was a decrease in the risk of breast cancer. Whereas those patients who received a combination of estrogen along with medroxyprogesterone acetate, the hazard ratio was 1.32, indicating an increase in the risk of breast cancer. These were all the different parameters evaluated on the trial. In figure A are patients who received the combination, that is estrogen along with progesterone. And you can see there's an increase in coronary heart disease, stroke, DVT, breast cancer. At the same time, there is a decrease in certain other cancers and colorectal cancers, and the all-cause mortality also was less. In figure B are the patients who received only estrogen, and in these patients, breast cancer, colorectal cancer, and other cancers, all of them showed a decreased risk. What is also important is the timing and the type of estrogen or progesterone. As you can see in this slide, the shorter the duration of progesterone or a combination of the shorter the duration of estrogen or a combination of estrogen and progesterone, the lesser is the risk. Those patients who received this combination for less than a year, the relative risk was 1.08 to 1.2, indicating that in these patients, there was not much increase in the risk of developing breast cancer. And this was similar whether you were evaluating patients who are current users of hormone replacement therapy or those who had used this in the past. Another important risk factor is the method of using the drug. So, for example, whether you used oral or transdermal, there was an increase in the risk of breast cancer. If you compared patients who received daily versus intermittent, in both of these, there was an increase in the risk of developing breast cancer. The only modality where there was a decrease in the risk of breast cancer or where the breast cancer risk was not affected was with the use of vaginal estrogens. Therefore, this study concluded that among postmenopausal women, prior use of estrogen was associated with a lower risk of breast cancer incidence and a lower risk of breast cancer mortality. Whereas prior use of a combination of estrogen with medroxyprogesterone was associated with a higher risk of breast cancer incidence without any increase in breast cancer mortality. What about the risk of endometrial cancer? Now, we understand that estrogen plays an important role in the growth and the maintenance of the endometrium. And it is thought that the prolonged exposure to estrogen without the balancing effect of progesterone increases the risk to endometrial cancer. And there has been a meta-analysis which has shown that combined hormone replacement therapy using a combination of both estrogen as well as progesterone had a decreased risk of endometrial cancer. However, the longer the use or the longer the duration of use of HRT was associated with a higher risk. So it seems that with regards to endometrial cancer, it is always preferable to use a combination as opposed to only estrogen. However, at the same time, the duration of use should be as short as possible. Is there also an association with postmenopausal hormone therapy and the risk of ovarian cancer? Yes, there is. There are three important studies. The Women's Health Initiative, which we just discussed, the Billion Women Study, as well as the Nurse Health Study. All three of these have shown that there's an increased risk of ovarian cancer among women who used menopausal hormone therapy as compared to those who did not. And this was also seen in a recent meta-analysis which said that especially for patients who have been receiving estrogen-based therapies, there's an increase in the risk of developing serous and endometrioid tumors. What about the risk of developing colorectal cancer? We have seen in the earlier studies also that there is an opposite relationship. In fact, it has been shown that those patients who received estrogen-only therapy had a reduced risk of colon cancer, and this has been seen consistently among 3 or 4 important studies. So why is there a decrease in the risk of colorectal cancer? It's not fully understood, but there are certain hypotheses. Estrogen may have a protective role effect on the colon by reducing the inflammation and promoting cell differentiation and apoptosis. Hormone replacement therapy, in fact, improves the health of the gut microbiome, which itself can decrease the risk of colorectal cancer. HRT can also reduce the amount of bile acids in the colon. It may reduce insulin resistance and improve glucose metabolism, which again reduces the risk of colon cancer. And HRT can also reduce the amount of visceral fat, which we know has been associated with an increased risk of colorectal cancer. So what do we know about menopausal hormone therapy and the risks with breast and endometrial cancer? Menopausal hormone therapy results in about 6 extra cancers per 1,000 women with 5 years use, and the figure increases to 15 to 19 extra cancers per 1,000 women in a 10-year use. These are predominantly endometrial cancers when estrogen alone is used, and exclusively breast cancers with estrogen and progesterone combination preparations. The formulation, the route of administration, the timing of the initiation, and the duration of use are all important in producing this effect. Estrogen-only therapy was not associated with an increased risk of breast cancer, and therefore may be considered as it has for a longer period of use as it carries a lower risk of breast cancer. However, estrogen-only hormone replacement therapy is associated with an increased risk of endometrial cancer, and this risk is reduced when progesterone is added to it. Long-term use of HRT, especially when estrogen-only therapy is used, has shown to have a decreased risk in the incidence of colon cancer. So you need to identify a woman's priorities and the different risk factors prior to initiating hormone therapy. Is there a direct linkage between menopause occurrence and a risk of cancer? So menarche and menopause, we know, are the markers of onset and the cessation, respectively, of ovarian function. And we know that early menarche and a late menopause have been known risk factors for breast cancer. So does menopause really impact a woman's risk of developing certain types of cancers? And has age something to do with it? Because age is always a confounding factor in many of these studies. As these women are postmenopausal, as they are followed up over 10 to 15 years, they also age. Breast cancer is the most common cancer worldwide, as well as in India among women, and it also is the cancer that carries the highest mortality in women. What we do know is that as the woman ages, the breast cancer incidence also increases. If you see in this table, almost 75% of the breast cancers in this table are in women beyond the age of 50 years. And in this group of women, most common are the ER-PR positive or the hormone positive tumors. So 75% of these patients have ER-PR positive tumors. And as the age increases, so does the incidence of ER and PR positive tumors. So what is the relationship between menopause and cancer? So we know that one of the important reasons are the hormones, that is the estrogen and the progesterone levels. Estrogen plays an important role in proliferation and survival of breast epithelial cells, and prolonged exposure to estrogen has been linked to an increased risk of cancer, of breast cancer. Similarly, prolonged exposure to estrogen without the opposing effect of progesterone can lead to an increased risk of endometrial cancer. The second important factor is inflammation. Menopause is associated with an increase in several inflammatory cytokines, which play an important role in the promotion and growth and survival of cancer cells. Inflammation can also promote the development of certain comorbidities, such as metabolic syndromes, which are seen in this age group of patients and are associated with an increased risk of cancer. Obesity itself is a very important risk factor for breast cancer as well as endometrial cancer. Menopause is associated with an increased risk of obesity, And as a result of which, we know that the adipose tissue, which is seen in obesity, produces estrogen. And in fact, in postmenopausal women, this is the most important source of estrogen in postmenopausal women. In addition, obesity can cause chronic low-grade inflammation, and it is therefore a combination of these factors which puts an increased risk for postmenopausal women. Now, the direct association of menopause and the cancer link has not been exclusively studied. There has been a lot of work on post-menopause hormonal replacement, but not so much so on only menopause and breast cancer. But there have been some takeaways from certain pivotal studies. So the collaborative group of hormonal factors in breast cancer had this large meta-analysis, including 117 studies, where about a lakh of women were the cases. These were the patients with breast cancer, and about 3 lakh women were the controls, and these were the patients without breast cancer. And this study came up with some important findings. The median age at menarche was 13.1 years, and the early menarche was associated with parity, the age at first birth, and the BMI, all three important factors which increase the risk of breast cancer. The younger the women were at menarche, the greater was their subsequent risk of breast cancer. And this risk, the relative risk, increasing by a factor of 1.05 for each younger. The median age at menopause in the study was 49.3 years, and the relative risk of breast cancer increased by a factor of 1.029 for every year older at menopause. What this study showed that while early menarche and a late menopause are important risk factors, but the risk factor effect is not equivalent, and early menarche predisposes to a higher risk of developing breast cancer as compared to a later menopause. So what exactly happens at the time of menopause? At menopause, there is a sudden drop in the level of estradiol. And in the short-term effect of menopause is actually quite surprisingly, there is a significant decrease after menopause. So the breast cancer risk was 40% higher in the premenopausal period as compared to the postmenopausal women of the same age. And this was in the group of women between 45 to 50 years. So this rapid decline of breast cancer risk in women of identical age immediately after menopause has been known and seen in several age incidence curve studies. This happens around at 50 years of age and is known as the Clemenson's hook. Now, the increased BMI is a very important factor. For patients who are lean and who have menopause, there is a significant decrease in the risk of developing breast cancer. On the other hand, patients who have a higher BMI, the risk does not vary much in the premenopausal and in the postmenopausal period. As we discussed earlier, in older women, in women who achieve a menopause at a higher age, there are more commonly associated with ER-positive tumors as compared to ER-negative tumors, and lobular cancers as compared to ductal cancers. So while breast cancer has a higher incidence in postmenopausal women, it's important to note that menopause itself is not a direct cause of breast cancer. Other important factors like the family history, the hereditary predisposition syndromes, reproductive factors, prior history of breast disease, the adiposity, and a woman's age also increase the woman's risk of developing the disease. So can we use menopause as a therapeutic target in endocrine therapy of breast cancer? So in front of you are the several risk factors for increased breast cancer. So you have non-modifiable and you have modifiable risk factors. And the ones that are highlighted are the ones that are linked to estrogen exposure. And this concept of achieving a menopause as a part of treating breast cancer is an old concept, more than 100 years old. We knew that removal of the ovaries can cause rapid tumor regression in breast cancer patients. So there are two important group of drugs. We know that tamoxifen has been an age-old endocrine therapy for breast cancer. Tamoxifen works at the receptor level and can be used in both women who are premenopausal as well as postmenopausal. The aromatase inhibitors, which are letrozole, anastrozole, and exemestane, work at the peripheral level. They work by preventing the conversion of testosterone to estradiol, and this is primarily in the adipose tissue for women. And aromatase inhibitors cannot be used in premenopausal women. It can only be used in postmenopausal women. So for the last 20 years, we have known that adjuvant tamoxifen in pre as well as post-menopausal women saves lives. However, till a few years ago, we were not very sure about what the role of ovarian suppression in premenopausal women were. We were aware that when chemotherapy induced amenorrhea, these patients had a reduced risk of relapse. However, the effect of amenorrhea that is caused by chemotherapy is not long lasting and is often short lasting. And there is no data of use of aromatase inhibitors in premenopausal women. In fact, it is contraindicated. So can we add ovarian function suppression as a part of endocrine therapy? So over the last few years, there have been two pivotal trials, the SOFT and the TEX trial. I'll just discuss one of them. In the SOFT trial, patients who were premenopausal and had undergone surgery for breast cancer and chemotherapy were randomized to one of three arms, either tamoxifen or tamoxifen with ovarian suppression, or one of the aromatase inhibitors, that is exemestane with ovarian suppression. And what this study showed was there's an improvement, a significant improvement at the 8-year follow-up with regards to the disease-free survival for both the arms of ovarian suppression, irrespective of whether tamoxifen was used or whether exemestane was used, indicating that in premenopausal women, there is a definite survival benefit and disease control benefit with the addition of ovarian suppression. And this benefit is not just restricted to the adjuvant setting. Even in metastatic breast cancer, in the management, we have several new drugs. You have the newer CDK4/6 inhibitors like palbociclib, ribociclib, and abemaciclib. All these three drugs have been evaluated in the premenopausal cohort of patients also. And when these drugs are given along with ovarian suppression, it has shown a survival advantage. I must say that currently, ribociclib is the only CDK4 inhibitor which has been approved for the first-line use in pre or perimenopausal women, along with ovarian suppression. So therefore, among premenopausal women with breast cancer, the addition of ovarian suppression significantly improves the 8-year DFS and the overall survival. The use of exemestane plus ovarian suppression results in even higher rates of disease control. And therefore, now standard guidelines include the use of ovarian suppression plus aromatase inhibitors as adjuvant options for premenopausal women who have a high risk of recurrence, like, for example, young age, higher tumor grade, and nodal involvement. Similarly, in patients with metastatic breast cancer, CDK4/6 inhibitors, along with endocrine therapy and ovarian suppression, improves the disease-free survival and the overall survival. It's important to note that in premenopausal women, especially those who are undergoing treatment with the GnRH analogs, it is important to do biochemical monitoring to ensure that they are in the postmenopausal status. So to conclude, in early menarche and in late menopause and postmenopausal hormonal therapy are known risk factors for breast cancer. Several factors that increase the risk of breast cancer, including hereditary factors, childbearing patterns, and the BMI, are associated with both the age at menarche and menopause. And these effects are not merely by lengthening the duration of reproductive years. We know that menarche probably is a higher risk factor than menopause. And the woman's average age at menarche has been declining over the past few decades in successful birth cohorts. And this is probably contributing to the relative increase in the breast cancer that we are seeing these days. Suppression of ovarian function in premenopausal women with early and advanced breast cancer is a major therapeutic advance, which results in better disease control and overall survival benefits. Thank you so much.
Thank you, Dr. Nilesh. That was indeed a very comprehensive review of menopause and its physiology. It's rather important because in Indian women, the age of menopause is about 46, 47, as you mentioned in your presentation. And the average life expectancy is more than 70 years. So there is a considerable amount of time when a lady is going to be, she has a big chunk of life to be lived after menopause, and hence menopausal health has to be looked into very seriously. A lot of women actually just give up their healthy habits or whatever vigilance they have been following in their premenopausal state, And probably menopausal depression is also one of the reasons why it has been that has been the case. But a lot of women who have been otherwise diligently following up cancer screening till menopause, after menopause they just let go, they start putting on weight, they lose their health, and actually that is worrisome because increased BMI is another risk factor for breast cancer. So a very important review. Thank you very much. For the next talk, we have Dr. Ashish Bakshi, another old friend of mine. Ashish and I were the first batch of DM Medical Oncology from Tata Memorial Hospital, and Ashish also continued his tenure in Tata Memorial Hospital a little while longer. He was a faculty there for a fair amount of time. He's done his basic training in MBBS and internal medicine from Nagpur, and then he moved to Mumbai for his super specialty training. After completion of his tenure at Tata Memorial Hospital, he joined the Hiranandani Hospital, Powai, Mumbai. He also practices at Borivali and at Thane. Over to you, Ashish, for another interesting talk. Ashish has always been presenting interesting cases, and his discussion is usually very, very rewarding. Go ahead, Ashish.
So thank you, Chetan. Can I start my screen sharing now? So can all of you see my screen?
Yes, sir.
Yeah. Okay. So thank you, Chetan, for this opportunity. Today, I'm going to talk about some of the endocrine problems that we face in management of cancer. I am unable to move my slides. Okay. Fine.
Sir, we are not able to see your slides, sir. We can see your desktop screen. Can you please just stop share and screen share again?
Okay. Can you see now?
No, sir.
No.
Actually, it's showing me here that I am sharing the screen.
Yes, sir. We can see your screen, but it's your desktop, sir.
Can we share the screen at our end? Can we show the presentation at our end?
You can't see my slides still?
No, sir.
Okay.
Dr. Ashish has already shared his PPT. So can we start screening it from
Sir,
our
it's
side?
there on iCloud, sir. We are not able to download that.
Oh.
Okay, one second. Can somebody from technical person guide me on how to do this? Because
Okay, sir. But till that time, Chetan, sir, can we go ahead and I'll just connect with Dr. Ashish.
can you see the screen now?
Yes, sir. We can see your screen, but not the presentation.
Not the slides.
Yes, sir.
Okay.
I'm trying to download it here. Let me.
Okay, sir.
I am unable to download it too because it's just not downloaded.
Yes, sir. The same issue we face. Ashish, sir, can you send this file via WeTransfer or something?
Mhm. Just 1 second. Let me try again.
For graciously allowing, graciously participating and fill in fill in for Dr. Jaita. Dr. Sonali Sao is my colleague at Dinanath Mangeshkar Hospital. She's done her MBBS and a diploma in hospital administration. She's also a certified palliative care specialist and has a diploma in geriatric medicine. She's been trained for palliative care medicine at Cardiff, UK. Another noteworthy fact is she's worked as a medical officer in the Army Medical Corps for 5 years, from 10th December 97 to 10 December 2002. She was posted in the field area for 2.5 years during Operation Vijay at Kargil. She's worked as a medical officer in charge Satseva home care of terminally ill cancer patients, and she headed the home care team at Sipla Palliative Care Center. For the past 15 years or so, she's joined as the head of palliative care medicine at Dinanath Mangeshkar Hospital, Pune. Over to you, Dr. Sonali.
Thank you, Dr. Deshmukh, for this kind introduction. Can someone take over on my slides? And considering me to take over as to be a part of the symposium, I'm here on behalf of Dr. Joyita, and I hope I'm able to convey the point she wants me to emphasize through this presentation. Next slide, please. So, a 34-year-old lady walks into the onco OPD with a history of painful defecation, passing blood in the stools for last 4 to 5 months. She's a mother of a 5-year-old girl and breastfeeding her 3-month-old son. She's also carrying her PET CT, which shows a locally advanced malignancy with sigmoid colon as the primary. Now, when there's a sudden change in the patient's health status, the patient and the family members may find themselves in this turbulent environment of a cancer hospital, be it in the ICU or in the emergency department. So when the diagnosis is under, when the investigations are ongoing, the treatment part would be either with a curative intent or with a palliative intent. There may be a lot of the family also will like to discuss about the available information about the disease. They also might need to also might have to shed light on the patient's prognosis. The family and the patient may be going through a lot of chaos and confusion and stress, which is often accompanying a cancer diagnosis. And so, meeting with patients and families frequently and communicating clearly the expected decision points and to develop a timely care plan is very important. It's also important to reassess the goals of care, the plan, and goals of care regularly, especially when the prognosis becomes clearer. When the patient, next please, next slide. Even when patients, when the treatment is of the curative intent, the patient may experience a lot of anxiety, grief, and they may have phases of depression after hearing the bad news. Next slide. When assessing any patient, we need to consider the risk factors that are related to the illness, treatment, or they may be pre-existing risk factors. 50% of the patients may cope well or may have normal responses to cancer diagnosis. 30% patients may have adjustment disorders which may be present with symptoms of anxiety and depression. Only 20% may have symptoms of clinical depression, delirium, personality disorder, anxiety disorder. Next slide, please. Most of the patients with serious illnesses may experience periods of intense sadness and anxiety accompanied by depression symptoms. These feelings are usually present for a relatively short period of days or weeks and they resolve. But these phases of sadness may be experienced anytime during the disease trajectory, right from the time of diagnosis to the end of life. Next. And these need to be assessed. Unfortunately, our society considers our society often considers depression as something which you need to be ashamed or as a sign of weakness. Degoretis, in one of the studies conducted in 1983, showed that 13% of the patients had major depression, 68% patients had adjustment disorders. Next slide. In oncology setting, 16 to 42% cancer patients have adjustment disorders. 21% may develop major depression within the time frame of 5 years, and the treatment includes relaxation sessions. They have to individualize therapies as per their need, and when required, can take help of medications. Next slide. Depression, as per the studies by Corso et al. In 2017, depression is 2 to 3 times higher in cancer patients or in patients with serious medical illnesses as that of the general population. As per the meta-analysis by Kreber et al. 2015 study, the pooled mean prevalence of depression is 8 to 24%. And this depression or the psychological concern issues may have a negative impact on the treatment adherence, quality of life, and subjective severity of physical symptoms the patient may present with. The cancers most commonly associated with depression are oropharyngeal cancers, pancreatic cancers, lung and breast cancer, and also the time of diagnosis when the patient presents to the oncologist. Next slide, please. So we need to understand the risk factors for depression. It could be individual, it could be social, it could be biological. The patient's personal and family history is important. You also need to understand his personality, the coping methods he's been using to deal with these serious illnesses. Lack of social support, low socioeconomic status may also be one of the cause for depression. Next slide. So basically, the treatment of depression is most importantly considered in a step care approach. Uh, Next slide, please. Next slide, please. Thank you. So in step one, all known and suspected presentations may present with all known and suspected presentations of depression, and this patient may require support, psychoeducation, active monitoring, and may also require referral for further assessment and intervention. If the patient presents with persistent threshold of depression symptoms, depressive symptoms with mild to moderate major depression, they may need low intensity psychological intervention. Medications also will be needed. In step 3, there's persistent subthreshold depressive symptoms, or they may have mild to moderate major depression with inadequate response to the initial intervention step 1 and 2. And here now we may have to consider medication, high intensity psychological intervention, and collaborative care. In step 4, where there's clinical depression or complex depression with suicidal ideation or suicidal attempts, self-neglect or psychosis, psychiatric admission, combined treatment, and electrotherapy may be should be considered. Next slide. So the treatment of depression classically involves antidepressants, SSRIs, SNRIs. SSRIs like fluoxetine and paroxetine usually begins to act within 2 to 4 weeks. Low doses may be sufficient in advanced illness and in elderly patients. Choice of SSRIs will be based on whether the patient had it in the past, and if yes, he had it, was it really helping him, and what was the side effect profile of each SSRIs. For example, fluoxetine is generally a more activating antidepressant, while paroxetine is a more sedating antidepressant. Also, we should remember both should be avoided concurrently with use of tamoxifen. The atypical antidepressants like metrazapine is also useful is also helpful as a sedating antidepressant, and it has got very few side effects. Tricyclic antidepressants like amitriptyline can be used in low doses for neuropathic pain in palliative care. In general, SSRIs can cause less constipation, less sedation, less dryness of mouth as compared to tricyclic antidepressant. But yes, nausea is worse with SSRIs, and we always have to balance the side effects, which varies between the SSRIs and between the patients. Psychostimulants like modafinil should be given early during the day. We also consider psychostimulants can be considered alone or can be used in combination with other antidepressants. Next slide. Coming to anxiety, yes, anxiety could be due to the physiological psychiatric causes like agitation. Already patient may be going through a phase of depression, or it could be organic, which could be due to cardiac causes, metabolic imbalances due to hypoxia, pain, sepsis, or it could be due to the fear of death, fear of because of the disfigurement during the course of treatment. Also, it could be iatrogenic, that is due to the side effects of drugs. Next slide. So, anxiety is often comorbid with depression. Treatment includes benzodiazepines and anxiolytics. Most commonly used drugs are lorazepam and clonazepam. Whichever medication is chosen, we need to remember that we need to start it in low doses and titrate it as per the effect and tolerability. Also need to remember benzodiazepines may worsen memory, particularly in the elderly patient, or cause confusion in patients with pre-existing cognitive impairment. They also need to be tapered slowly and need uh, close monitoring for the side effects or adverse effects. Next slide. Delirium. 25 to 85% of patients in palliative medicines may experience delirium, and this is usually higher towards patients at the end of life, and usually it is irreversible in end of life care. Next slide. The other concerns the patients diagnosed with cancer may have is about the body image. They may have fear of the cancer recurrence. They may be also cancer recurrence, and also because they are on long-term treatments, there may be fear of dependency or addiction towards the medication in case they are on medications like morphine or antipsychotics or any medicines. They may come up with different fears at times. Next slide. So psychological intervention, non-pharmacological psychological interventions include cognitive behavioral therapy, uh, stress reduction therapies, problem solving sessions with the clinical psychologist, specialized psychotherapies which are proving useful and are meaning-centered therapy and behavioral therapies which are on the research right now. Next slide. Next slide. So next slide. Yeah. So this patient which I mentioned could have had a curative disease-free interval, or she may land up to be oncology OPD after years after completing her treatment, and she may require palliative care. Next slide, please. So psychological support is needed right from the time of diagnosis. Uh, Probably it is required at the time of screening because there are a lot of fear the patient may go through. It is during the curative phase and during the palliative care. During the curative phase, the active disease-directed treatment is ongoing, and during the palliative care, there's minimal disease-directed treatment. During the end of life care, there's no disease-directed treatment, and also the family would go through a lot of distress. They may go through a lot of guilt feeling, anticipatory grief, and they may require the families may require help and support even during uh, the bereavement period, that is after the patient's death. Next slide. So the universal concept is influenced by the cultures, like how our coping mechanism, how we culturally deal with our difficult situations and our day-to-day life, and very much influenced by the spiritual inclination of the patient and families. Yes, the most important part is the resilience. We do have a trauma, and then we come out of it with, uh, with great resilience, and that's important. Next slide. So screening these patients for anxiety and depression, even much before they land up with a sudden illness, is very important. And having the screening programs in place, assessing their health behaviors, tobacco and alcohol use, and genetic counseling is also very important. Next slide. While dealing with cancer patients, the physicians and other healthcare professions have their own responses to these sudden illnesses in the patients they are caring for. If these responses are not recognized, they may lead to occupational stress and burnout, particularly when the outcome is not what was initially hoped for. The treating physician may experience unrealistic feeling of guilt, may have fear of rejection, which could be from the patient, the family, or from his own colleagues, and in this situation he may project his or her feeling in an unhealthy way. So self-care is very important when you're working in the field of oncology or when you're dealing with severe life-threatening diseases. So our role as a palliative care physicians would be to have a more tailored, made or patient-centric, person-centered approach towards care. We need to consider the total person rather than just concentrating on the disease. Next slide, please. So yes, definitely progress has been made in the recent years for integrating psycho-oncology care in routine cancer care, but more work needs to be done, and we have miles to go. Thank you. Next slide. That's it. Thank you.
Thank you, Dr. Sonali. That was very kind of you to fill in at the last moment, and you've done a wonderful job. I just had a question, if I'm permitted to ask, that some of our patients who have been treated with a curative intent, sometimes they do relapse, and then they have to be shifted on a palliative intent. So how does this switching of intent, how do you manage that in the OPD? Because we do that. We have been treating a patient, say, with ovarian cancer with a fairly aggressive intent. And then after multiple lines of therapy have stopped working for her, we then refer her to you for palliative care or palliative treatment. So how do you handle that change in approach? 2 months ago, she was being treated with an aggressive intent with chemotherapy, and now we are planning only symptomatic treatment. How do you handle that in the OPD?
Yeah, so when the patient was previously being treated by the oncologist with an aggressive intent, the goals of care were very clear that it was curative. But then suddenly the disease has progressed. So now understanding what the patient knows about the disease, what were their hopes, what were their expectations, and what would they expect from the treatment as such. Understanding their information needs, trying to address those information needs, and then giving them the clear picture about what the situation is right now, and what now that the goals of care have changed, we need to be honestly conveying the information to them and assuring them about the support that would be extended during the care to take care of their symptoms.
I think that's very helpful, because we face this kind of a problem quite often, especially in a heavily pre-treated patient. When we have to shift gears, it should be this point about understanding their need, understanding their information, I think is very vital. Are there any more questions for Dr. Sonali, or can we move on to the next one?
No questions, sir.
Okay, fine. So thank you, Dr. Sonali, once again. And we now go back to Dr. Ashish Bakshi. Ashish, I have managed to download the presentation at my end, so I will share my screen.
So Chetan,
Darshan, am I right?
Let me give it a try here one more time.
Okay. Oh, it's working. Excellent.
You are able to see now?
Yes.
Okay,
Perfect. Great. Perfect.
So
Please go ahead.
So sorry for the technical glitch. So I will be talking on the challenging endocrine problems that we face in patients with cancer. So there is a complex interplay between patients with cancer and the endocrine system at multiple levels. It is right from shared etiologies between the cancer and the endocrine system, the endocrine therapies that can cause cancer, endocrine treatment of cancer, paraneoplastic syndromes that can happen as manifestations of cancer, and so on. So the primary focus of today's talk will be the complications, endocrine complications that we face while dealing with cancer patients. So a variety of cancer treatments are used for management of cancer, which traditionally include the surgery, chemotherapy, radiotherapy, and hormone therapy. And increasingly now, as with the increased molecular understanding, we are using more and more targeted therapies. And the last kid on the block is immunotherapy. And all of these treatments have, of course, helped us in improving the outcomes of patients, but also have resulted in several new challenging situations which can lead to complications. So we are going to focus on the endocrine aspects of this part. Now, the spectrum of endocrine problems faced by the medical oncologists are ranging from the entire endocrine system, right from the hypothalamic pituitary axis to the thyroid, parathyroid gland, pancreas, adrenal, and the gonads while dealing with patients with cancer. Now, the spectrum of problems depends on a lot of factors, right from the primary diagnosis, the comorbidities that the patient has, age of the patient, the type of therapy the patient is receiving, dose of therapy, and duration of therapy. So, the one of the most common problem faced is thyroid dysfunction. Hypothyroidism, as I said, is something that is most commonly encountered, and often the symptoms are subtle. So, the symptoms of hypothyroidism may be incorrectly attributed to the primary disease or to the antineoplastic agent. So, however, the bigger problem is that underdiagnosis of thyroid dysfunction can have important consequences. It can adversely affect the patient's quality of life. It can lead to dose reductions of potentially life-saving therapies, and also hypothyroidism can result in altered kinetics and clearance of the medications, so which can lead to undesirable side effects. In some cases, hypothyroidism is also known to be associated with a better response to therapy also. Now, apart from surgery and radiation, which typically cause a direct impact on the thyroid, several other drugs can lead to hypothyroidism. The common ones nowadays that we see are the drugs like interferon alpha, immunotherapy like ipilimumab, pembrolizumab, nivolumab, drugs like alemtuzumab, which can cause immune dysregulation, whereas destructive thyroiditis is noted with drugs like sunitinib and sorafenib, and also the checkpoint inhibitors. Uh, Thyrotoxicosis is also can be seen paradoxically with all these drugs. So the amount of thyroid dysfunction that can happen will vary between patients. Apart from that, some of the drugs can cause abnormal thyroid function test without actually causing thyroid dysfunction, like low serum thyroxine binding globulin or high serum thyroxine binding globulin can be seen as a result of these drugs. Tyrosine kinase induced hypothyroidism is increasingly seen as a major problem. We have heard Dr. Apar Danti on talking about the use of TKIs in the management of thyroid cancer. So, as you can see, most of these drugs which are used for the treatment of thyroid cancer, they can lead to a very varying degree of hypothyroidism, depending upon what is the definition used in trials. But it can range from up to 30 to 50% of the patients. Similarly, multi-kinase inhibitors like axitinib, cabozantinib, lenvatinib, regorafenib, which are used for the treatment of renal cell carcinoma, hepatocellular carcinoma, GIST, and so on. In them also, you can see a range of hypothyroidism seen in patients, right from 5 to 20% of the patients. Now, it is important that patients should be closely monitored with free T4 and TSH levels. Those patients who have TSH levels more than 10 or with low free T4 levels, they should be started on levothoraxine. Initially, the starting dose is 1.6 microgram per kg, but those patients who have a coronary artery disease, you can start with a lower dose. Important is to note that in those patients who have a central hypothyroidism, you cannot use TSH for monitoring treatment. So in those patients, free T4 should be used for monitoring. Sometimes you see a immune, as I said, destructive thyroiditis due to the immunotherapy. In some patients with severe hypothyroidism, one may have to add steroids in case if the inflammation is too much. Usually, grade 1 and grade 2 hypothyroidism, you can continue the checkpoint inhibitor therapy. But if the side effects are grade 3 or grade 4, then one may have to stop the immunotherapy in that situation. Another common thyroid is the hormonal dysfunction that we encounter is the hypothalamic pituitary dysfunction. This is often seen as a result of radiation, most oftenly, less commonly due to surgery or chemotherapy. Now, the degree of hypothalamic pituitary dysfunction depends on the dose of radiation given. The doses like 10 to 15 gray, which are used for total body radiation in patients receiving BMT, in them the time to development of growth hormone deficiency is less. But however, those TSH deficiency is less in those patients. But as the dose of radiation increases from 10 to 15 gray to 60 gray, which is often used in patients with brain tumors, the degree of suppression of all the hormones increases. So in those, the higher the dose, you will see all the systems getting affected with the effect of the radiation. Now, another common side effect that is encountered is adrenal dysfunction. As you can see from this graph, there is an increasing incidence of adrenal dysfunction in patients with cancer. This is primarily due to the introduction of monoclonal antibodies and protein kinase inhibitors, which have been introduced in the treatment of cancer. So, host of monoclonal antibodies and protein kinase inhibitors are known to be associated with adrenal insufficiency, and therefore patients should be monitored for this function. A very commonly used drug is magistrol acetate, which we commonly used in patients with cancer as a appetite stimulant or as a hormone therapy. And this drug also has been known to be associated with adrenal insufficiency, which is often overlooked. Similarly, drugs like ketoconazole, drugs like abiraterone, which are commonly used for treatment of cancer, can also lead to primary adrenal insufficiency, and these should be monitored in these patients. Pancreatic dysfunction is again a very common problem that we see increasingly. Elevated HbA1c is known to be associated with aggressive tumors, particularly in colon cancer, prostate cancer, and endometrial cancer. And increased glycemic control is known to be associated with reduced risk of infection and cancer-specific mortality. Now, studies have shown that those patients who have diabetes, their outcomes are inferior as compared to those patients who have no diabetes and cancer. Now, hyperglycemia during chemotherapy occurs in roughly 10 to 30% of patients. The common causes are glucocorticoids and asparginase, but increasingly mTOR inhibitors like everolimus and PIK3 inhibitors like the drugs that we use nowadays, they are known to be associated with hyperglycemia in 13 to 50% of the patient. Similarly, the PD1 and PDL1 inhibitors are not very commonly, but in about less than 1% of the patients can cause autoimmune insulitis, and which can lead to secondary diabetes. So patients should be screened for blood sugar while the patients are, say, for example, they are on everolimus or other drugs which can cause hyperglycemia. HbA1c should be monitored. And in patients who are on immunotherapy, they should be you should check for anti-GAD antibodies and anti-isolate cell antibodies. The treatment of hyperglycemia remains standard within the form of either insulin or sulfonylurea. If the diabetes is not coming under control, then in some cases one may have to withdraw the anti-cancer treatment. Metformin is one drug that is used for commonly for treatment of cancer. It has been shown to reduce the incidence of cancer and mortality from cancer. It has also been shown to reduce the likelihood of relapse, and therefore it is being explored currently as an adjunct therapy in several cancers. Recently, one trial unfortunately failed to show any benefit of metformin for cancer prevention. Now, bone health is again commonly affected in patients with cancer. Patients often present with osteopenia or osteoporosis, and which can lead to several complications like fractures, spinal cord compression, hypercalcemia, and so on, which can impact the quality of life and survival of these patients. Particularly, therapy-associated bone loss is known in patients with aromatase inhibitors in postmenopausal women, those patients who undergo bone marrow transplant, patients with prostate cancer who are receiving androgen deprivation therapy, and those patients who develop ovarian failure secondary to chemotherapy. So that's where bone mineral density should be closely monitored in patients who are receiving such kind of therapies. And the degree of osteopenia or osteoporosis is directly proportional to the duration of therapy. The longer the duration of therapy, the greater is the likelihood of bone loss. Another challenging problem that is faced in oncology is the late endocrine side effects of cancer treatment, which again can have a range of hypothalamic pituitary manifestations, thyroid manifestations like hypo or hyperthyroidism, metabolic syndrome, obesity, diabetes mellitus, and gonadal failure as a result of the therapy. And in children who are treated since childhood for short stature, growth failure, low bone mineral density, and so on. So, a spectrum of manifestations involving the growth hormone, FSH, LSH, central hypothyroidism, AVP deficiency, similarly, thyroid gland dysfunction, gonadal dysfunction, skeletal damage, all of these are seen, and patients should be periodically monitored for these manifestations throughout the course of their life. Now, briefly, for 5 minutes, I would like to emphasize on immunotherapy-related toxicities because this is something of a very evolving topic in the last maybe 5 to 10 years, as we are increasingly using more and more immunotherapy. Immunotherapy related toxicity, usually the onsets are very early, maybe within a couple of months of starting immunotherapy. One can see these manifestations. Dysfunctions like thyroid dysfunction, they can be prolonged and probably can remain lifetime. Uh, those patients who have primary adrenal insufficiency, in case if it is severe, then often they require discontinuation of the treatment. The spectrum of manifestation depends on the type of immune checkpoint inhibitor therapy. Patients who are given anti-CTLA4 therapy, often they are more likely to have hypophysitis. As against that, patients treated with anti-PD1 or PD-L1 inhibitor, they are more likely to develop hypothyroidism. And the side effects are more when the two drugs are combined. Immune checkpoint inhibitor induced hypophysitis can affect adrenal, thyroid, and gonadal function. Most often, as you can see here, 3 hormones are affected, but ranging from 1 hormone to 5 hormones. Multiple series of hormones can be affected as a result of hypophysitis. So monitoring for these hormones should be closely done when the patients are on this therapy. Usually most often the grades of side effects are grade 1, grade 2, grade 3, grade 5 side effects resulting in discontinuation of therapy or resulting in death are very, very rare, usually less than 1%. Whenever you are giving a combination of PD1 and CTLA4, the onset of therapies is side effects is earlier, and the duration of side effects is also for a more prolonged period of time. Rates of discontinuation by and large in trials are very, very less. Hardly less than 5% of the patients are actually required to discontinue therapy, and the side effects can be manageable. While giving therapy, patients should be monitored at baseline for thyroid and ACTH and cortisol levels. And typically while the patients are on therapy, we monitor these hormones every 4 to 6 weeks. And similarly for adrenal and pituitary, we monitor every 2 to 3 weeks during therapy. Then a lot of antibodies have been detected in patients who are developing adrenal dysfunction as a result of the immune checkpoint inhibitors. So anti-pituitary antibodies are noted in patients with pituitary dysfunction. 21 hydroxylase antibodies are detected in patients with primary adrenal insufficiency. Those patients who have thyroid dysfunction, in them we can see thyroglobulin antibody or anti-TPO antibodies. So these antibodies can be tested while the patients are on therapy in case if you're suspecting hypothyroidism or other adrenal dysfunction. So while managing the patients, if they are grade 1 or grade 2 side effects, then patient should be continued with therapy by and large. If the side effects are grade 3 or grade 4, then the immunotherapy should be stopped and the patient should be treated appropriately first. Usually, rechallenge can be done in the event that a rechallenge can be done in the event that the immunotherapy side effects has reduced to grade 1 or grade 2. However, one has to permanently discontinue immunotherapy in the event that the treatment-related toxicity does not resolve to grade less than grade 1 within 3 months of the last dose of immunotherapy. So I think with this, I would like to conclude my talk. There is a complex interplay of endocrine system and cancer. Endocrinologists and oncologists should be aware of the spectrum of disorders that we see involving the endocrine system in patients with cancer. Most importantly, for oncologists, timely referral is important one should keep a high index of suspicion and refer the patients early to endocrinologists so that the side effects can be picked up when they are grade 1, grade 2. And teamwork is essential to mitigate the adverse effects of endocrine dysfunction in patients with cancer. So I think with this, I will conclude my talk. Thank you so much.
Thank you, Ashish. That was an excellent overview. And as usual, you made academically, the content was really very rewarding. Are there any questions for Dr. Ashish?
No, sir.
Okay. So since we are reaching the end of this session, we were allowed time till 10:30. It's already 10:30 now. So I'll conclude the session with just a couple of comments. The idea of having this onco-endocrinology session was to give people a preview, sort of a teaser as to how complicated this situation is. And Ashish's last slide is correctly displayed here. There is indeed a complex interplay of endocrine system and cancer, and we are probably going to see more and more of it. Right now, immune checkpoint inhibitors are probably not within the reach of a common man because of their sheer cost. But as these drugs become generic and as they go off patent, there are several other targeted therapies and immune checkpoint inhibitors which will be used rampantly. And that is a time when we are probably going to be facing a big tsunami of endocrine side effects about which we need to be prepared beforehand. So I have a thought in mind that we'll probably conduct a day's symposium on oncoendocrinology together. There are a lot of complicated things like menopausal health, especially after menopause. The risk of certain cancers starts increasing, how menopausal health and hormonal health should be balanced. Ladies who are on, who have been treated for breast cancer, they have a lot of questions regarding hormones. So all these questions will probably be answered during that symposium. So that this session was just a way to get an idea as to how we are going to do that session and whether it's worthwhile and fruitful to conduct such a day's symposium. So this session gives me a lot of insights about it, and I'm really happy and thankful to Dr. Apar, Dr. Nilesh, Dr. Ashish. All of them have made excellent PowerPoint presentations, which will of course be available for all of us to see. And Dr. Sonali, who filled in at the last moment at such a short notice, but did a fantastic job. Thank you very much. We now can move on to the next session. Thank you.
Thank you.
Great. So we had an exciting and very, very interesting session on oncoendocrinology. And now we now move on to the next session, which will be, give me a minute, please. Yeah. So now we are going to start the next session, which will have a lot of neurology involved and neuropsychiatry involved. And we again have a good team of speakers. To start the session and moderate the session, I request Dr. Vani Kulali, an old friend from BJ Medical College. She did her MBBS from BJ Medical College and completed her MD in psychiatry from the prestigious Nimans Institute. She is primarily a private practitioner at Mumbai, and has a rich experience like a general hospital psychiatry, workplace psychiatry, mental health, pediatric psychiatry. She also has a great experience of working in the Jumbo COVID Center during the recent COVID pandemic. So it will be a great thing to hear Vani's thoughts as well. Over to you, Dr. Vani.
Good morning, everybody. Thanks, Dr. Chetan, for introducing me. And the current set that we're going to have is about the most important organ in our body, that is the brain. And it's my often we see that while we are dealing with main medical disorders, a lot of cognitive dysfunction or those kind of disorders, sometimes the diagnosis gets delayed. So without much further ado, I would like to introduce our first speaker. Can I have the introduction slide, please? So joining us this morning is Dr. Sonal Chitnis from Pune. Sonal has been my co-fellow in the Mind-Body Medicine Fellowship that we did last year. She is presently a faculty at Bharatiya Vidyapeeth's Medical College as an associate professor of speech and language pathology. And her areas of interest are mainly ephesiology, cognitive neuroscience, neurorehabilitation. And she works a lot, not only in the treatment, but also in the preventive and rehabilitative aspects of cognitive dysfunction. So, Sonal, over to you to make your presentation.
Thank you so much for that great words and the introduction, ma'am. I would like to thank Team Synapse, especially Dr. Vaishali ma'am and the team for inviting me here and allowing me to share my thoughts, my advocacy points on importantly cognitive decline, prevention, promoting and preserving cognition in type 2 DM. So I hereby share my presentation. I would be talking from a perspective about a neurorehabilitation professional and not as a from a medical professional. So it's more of a rehabilitation in terms of how do we work on advocacy, preventing, promoting in terms of diabetes, a very important systemic disease and which has got many adverse disease. So I hereby give my disclaimers that this talk is part of my advocacy as a part of ISHA, Indian Federation of Neurorehabilitation. I recently got into WHO World Rehabilitation Alliance as a task force from IFNR in primary healthcare work. And cognitive health is one of the important point I'm trying to work on. So hereby aspire to cover a huge important message in terms of how we can prevent, promote cognitive health in type 2 DM. So as you have listened to all the wonderful speakers since yesterday about how the diabetes mellitus, then different systemic diseases, mind-body medicine in endocrinology and different disorders, we need to take a perspective of the holistic health, talking about neurophysiology, sleep, diet, stressors, and I'm sure my job is made a lot easy from yesterday's great talks what we had heard from. So I also would like to thank importantly Dr. Leena Phadke and Dr. Sanjay Phadke sir, from whom I am trying to get trained in mind-body medicine perspective. So it's important that we all try to understand brain, cognition, and type 2 diabetes mellitus. So we all know that it is a complex disease. It has got many potential complications, intra and individual factors for your verbal cognitive health, social cognitive health, and spatial cognitive health. Importantly, early cognitive decline in terms of type 2 diabetes. We see verbal memory impairment. There is a huge literature available which talks about how individual with type 2 DM importantly get affected by their hypoglycemic, hyperglycemic episodes, delirious episodes, and uncontrolled sugar precipitated other systemic comorbidities. And the sweet culprit, if we can call it, it has hazardous effect on your cognition in terms of hypoperfused attentive brain, the brain responsible for memory, brain responsible for your complex executive function, and brain integrity. So as we know, that's important need to understand how this DM affects the multiple functions in the brain and the Papez circuit, importantly for your attention, memory, and how DM can be importantly adding up to the cerebrovascular or cardiovascular cognitive morbidities. It's a vicious cycle. And there are literature coming up from the Western scenario that there's a 60% increased risk of dementia in person with more than 5 years of uncontrolled type 2 DM. In Indian scenario, we have very poor literature available. A majority of literature available is a single-centered or the dual-centered studies, and we do not have the values research findings from the rural population, urban population, from different socioeconomic status, people who have been multilingual or bilingual, or who are still well active in their social life, still having uncontrolled diabetes mellitus. And we do not have the findings about their how long is the my cognitive impairment is mild only, or it is precipitating, and when is the conversion for the MCI to the Alzheimer's disease or vascular dementia. So we all know the pathophysiology of DM, and importantly, what affects and adds up to cognitive decline in terms of the metabolic aspects of cognition in the brain. So poor attention, poor executive function, poor mediation, poor awareness, poor self-correction and feedback, visual-motor skills would be important factors which are part of pathophysiology of DM, which could be long-standing. And later, this is very important to address. And are we addressing this early? Are we having the adequate biomarkers to tap this? Are we really trying to understand the greater risk of neurocognitive disorders, dementia's root cause? And there are several promising therapies in terms of FDA-approved trials also abroad, but there are few and not many are available in terms of amyloidosis, and the people who are working in cognitive neurology in tapping the early MCI with cardiovascular, cerebrovascular risk with type 2 diabetes, they are studies and they are trying to get the patients for long-term profile. However, there are so many factors. Our population is very heterogeneous. The lifestyle is very different, and with their different neural reserve, cognitive resilience, it is very important that we investigate right. So it's important that we understand what are the changes in the brain morphology and what are the important changes to the structures of brain adding to the cognitive decline, so that we understand and adequately address this in the person who is identified right. And if he or she is at risk of developing it, cognitive decline, and how we can prevent at the further stages. However, there are very few reports that having the cognitive cosmetic neurological aspects where we tap them early. There are more studies where they identified early and they are given domain-specific rehabilitation. Again, in terms of Indian scenario, we have very less memory clinics with a well-equipped, well-trained full-time neuro-rehabilitation specialists like neuropsychologist, neuro-speech pathologist, neuro-occupational therapist, neurophysiotherapist, social workers, dietitian, nutritional specialist. Lot importantly, a teamwork along with general physicians, endocrinologist, diabetologist, neurologist, neurosurgeon. So it's important to understand that how the systemic diseases like type 2 DM affect the positive health, and are they predictors? So why should I test cognition? It's an important outcome measurement in terms of holistic health. From the young adults who are at risk of DM, middle age, we see a greater risk of having the DM and they are not identified. And the insulin resistance can cause really haywire experiences. Older persons at risk of cardiovascular and cerebrovascular diseases and at risk of dementia with the susceptibility post-COVID, more chances of having the disease susceptibility, and advanced aging patients. So is there any efficient way of treating cognition in type 2 DM? Can we really preserve, promote, or prevent cognitive health in DM? So I am a proponent on mind-body medicine integrated informed interdisciplinary team approach, and I would really feel that it's yielding. But is it yielding? Are there any supporting evidences? We need to really understand, investigate, and work on that. So in the hyperperfuse brain, it's important that we understand cognitive impairment, and we need to have predictive tools in terms of catching, identifying the cognitive circuitries at biomarker level, at neurobehavioral level, and then correlating it right. So majority of cognition is screened by using MMSE, mini mental states examination, and many times early or even mid or uncontrolled type 2 DM do not have significant cognitive impairment in your MMSE if they are having a good cognitive reserve in terms of their education, if they have everyday reading newspaper, solving some puzzles which have been there, or some use of apps, use of the gadgets. And if they score more than 26 to 28 out of 30, do we just label them that they're worried well or having no significant cognitive impairment? No, the MMS is not a correct tool, a sensitive tool, a robust predictive tool. So MOCA, yes, Montreal Cognitive Evaluation Assessment tools in different languages are available. So MOCA has been reported to be a sensitive tool to identify early mild cognitive impairment. It could be of amnestic or non-amnestic origin. So one should understand, is the person who has is having time to behave. So is he reported or she reporting that she is forgetting, she's of late not performing as much, possibly better on her own pre-morbid status, or is a general physician has referred for the serial cognitive test, which one should actually ask for, so that you know what is doing from the baseline and how he or she is progressing, deteriorating, or improving. And that could be really helpful in understanding cognition and type 2 diabetes, which can be very important because your assessment becomes therapeutics. So to understand pathophysiology of cognitive impairment in DM, one is to understand the multifactorial interconnectivity. I'm sure Dr. Pujari sir would be dealing in detail about the intervention on that. But as a neurorehabilitation specialist, I would put forward here that it's important that we tap the cognitive impairment with right tools, with the cognitive neuropsychological batteries, assessing verbal cognition, spatial cognition, and importantly, everyday cognition. For a farmer is different, and then occupational needs are different. For a teacher who's retired could be different. For a middle-aged CEO of a company and his long-standing diabetes, adding hypertension, stress still would be a lot different. So we need to have the good, specific, sensitive cognitive neuropsychological batteries to tap the cognition. And it's literature have given very different literature has given very different results, that there is no significant difference in cognitive impairment in patients with type 2 DS more than 10 years ago, those who are diagnosed less than 10 years. And I think there could be so many things to look into, that how we can really understand the gender, the years of type 2 DM, the controlled, uncontrolled, the stress, the diet, their habits, and lot is important in order to understand that how we can prevent, how we can promote the cognitive abilities, holistic brain health. So I already dealt with the testing cognition. So to get bird's eye view, importantly, what I could try to put forward here is that we need to really tap the cognition abilities, cognitive impairment, multifaceted way in terms of verbal, non-verbal domains, everyday memory, then the person's long-term memories versus the short-term memories, then person's executive functions of everyday routine versus a skilled task. If they are forgetting and losing, or actually they are trying to not utilizing the same reserve what they might be having, are they really engaged in mindful social cognition than what they were early doing it? Are there significant precursors with their added jobs? Many middle-aged and the elderly population is having their own caregiver's role to care their advanced elderlies, and that caregiver's burden with type 2 DM could be really devastating on the cognitive health. So it is important that we tap the person as a whole in terms of clinical assessment and further giving the preventive workup, promoting workup to the person with cognitive abilities impaired, reported by him or her, or reported and not accepted, not aware that he or she is forgetting, not able to do as much as possible what he or she could earlier do it. So if the person is not accepting the cognitive decline, they may not even work on the specific correcting the metabolic diet and the cognitive specific routine lifestyle changes, improving the sleep cycle, their diet cycle, their importantly the habits and the exercise routine. So it is important that we catch them, we screen them, we serially address and assess them. So what do we test in cognition? Importantly, receptive and expressive language. So tip of tongue phenomenon is observed. So many persons with type 2 DM early find that I don't have any difficulty in memory. I'm fine. I feel so. But they might say, yes, occasionally I don't get correct words. I sometimes don't get correct name of the person. They could be somewhere they say that, okay, of late I'm getting excessively fatigue on reading paper, novel. I'm not able to recollect what I read earlier, what I did earlier. So that could be importantly to be tapped in terms of verbal cognition, the spatial cognition, in terms of how agile, how active, how skillful their brains are still on spatial functions. And social cognition, importantly, in terms of their social inference, their affect, their thinking abilities, their reasoning abilities. So it's a teamwork, and I'm a speech language pathologist. I play an important role from the beginning to the person who is from the type 2 DM with morbidities or without morbidities heading towards cardiovascular or cerebrovascular, MCI, or other NCDs, or movement disorders or autoimmune disorders. We need to really understand that post-pandemic era. So my role is to identify, to assess cognitive abilities, to collaborate with different professionals, to work on prevention of cognitive behavior decline in senior citizens. And I also want it to be inculcated from the childhood so that the children, adolescents also are going to be helpful to the elderlies they're caring, to themselves, they are also aging. So I feel that should be helpful in terms of inculcating right cognitive health habits. So promoting the right education, advocacy, research, and playing a role as a case manager. Also, I would like to stress on the holistic health of hearing because of auditory processing disorders in person with type 2 DM, where the hyperperfused inner ears and the auditory pathways would lead to sensory neural hearing loss and poor communication ahead. Also, the taste, pleasure meals, thirst and hunger deficits in person with type 2 DM lead to poor swallowing and deglutition, importantly, of cognitive behavior, because they cannot relish their favorite food. They don't find satiated. Sometimes there's a xerostomia. There is either excess or a drying of saliva with the medication effect. Sometimes there's the uncontrolled or unidentified thyroid profile, impaired profile, which could be also importantly to be dealt with while understanding your therapeutics in type 2 DM. Again, I'm not digressing from the preventive workup, but yes, to identify this right is very important, that how can we prevent? I would say rather promote a brain health in terms of at clinician level, at general physician family health level. We need to really make them aware, identify it early. Lot of general physicians are still not aware about need of cognitive precursors and scales in a early type 2 DM, because unless the patient reports, they are not even referred. Even patient do not come to the psychologist. Speech pathologists are very poorly involved in cognitive health. So we need to really work on the promoting the cognitive health. However, what happens, there's a stigma that going to psychologists or psychiatrists is that someone is going insane or turning senile. And that's how many times we really miss on rightly identifying them. So it should be a team level, at patient and caregivers level, accepting the cognitive impairment or someone may develop ahead with the family history, with the precursors, and implicate from the beginning before the actual frank cognitive impairment to occur. So again, we all know that disease progression starts in the brain level way ahead, way early, but the actual frank symptoms of cognitive decline might appear late as per the person's everyday health, metabolism, and differences inter and intra-individual. So it is important that we need to really ascertain in terms of how we need to promote and work on preventive workup and also preserving workup in terms of how we learn, how we relearn, how we forget. And you all know the plasticity, brain plasticity in terms of lose it, use it or lose it. And when you are actually slowly losing it with the effect of age, effect of environment, stress, lot different factors, how the different words, different memories, different skills, different abilities we have used, we have learned, are they adapted, are they utilized, are they maintained for your successful living? So as a role of SLP, it's important that we work in cognitive aging beyond speech. So we need to understand mild cognitive impairment, how mild is mild for that individual in terms of vascular cognitive impairment, cerebrovascular diseases, risk of Alzheimer's disease. As you know that there is a risk of MCI to the conversion of Alzheimer's and vascular dementia continua with the diabetes mellitus metabolic encephalopathies and their irreversible and reversible neurocognitive disorders. So it's important that we understand the timely revision of the person with DM and their cognition, what we need to plan, how we need to execute the holistic well-being. So we need to educate right, promote right, we need to preserve the abilities which are still really well in the person and what are getting affected, what are mildly affected, what are severely affected. So it importantly that prevention of cognitive decline and promoting of cognitive behavioral skills could be a cognitive psychological principle based, and it should be importantly ICF based framework where you understand the functions impairment so that you help the person not to get socially isolated, not to get handicapped because he or she is forgetting, not able to count, not able to continue doing the banking, not able to go back to the community. So we need to compensate and we need to restore. So there are two important approaches. So restorative approaches and compensatory approaches across the attention, executive functions, long-term memory, short-term memory, procedural memories, then your importantly retrograde memories, anterograde memories, verbal, visual, tactile, different modality-based, activity-based cognitive rehabilitation needs to be planned. And we need to have a SMART goal where they should be specific, they should be measurable, they should be attainable, and we need to even revise our plans. So etiology-based goals, then sort of the onset of the type 2 DM, the comorbidities the person have, the diet what the person has, the occupational needs, the medication what they are having, because there are certain medication based cognitive impairment also. And there are many people, they take a counter medication on their own. Sometimes I see patients that in terms of type 2 DM, when my scenarios, I have seen patients on their own go into some alternate medicine, and they stop their medication for long. They feel happy, they feel nice, they don't check their blood sugar level, and then they have a huge again decline, and over the period they again come back to the allopathic medication, and then they feel that somewhere it has harmed them. So there is a right way of educating the patients and how we can still help them, that yes, CAM can be helpful, but rightly getting the medication and the exercises, the right plan is important, and not that they sometimes drop out of from the team. So it is important that we need to have different goals to tap on the person with type 2 DM at risk of developing cognitive decline. Self-awareness is very important. Vigilance is very important about the person's body, person's mind, his needs, about his overall health and his disease and its consequences. So again, I would stress on how mild is a mild cognitive impairment. Is it mild only? Is it moderate? Or is it severe enough in terms of interfering with a person with DM? So metacognition, this need to understand the awareness about the person with type 2 DM. Can I have quick 10 minutes, ma'am? And just flash one case capsule.
No, 10 minutes is
5.
about 1 minute. 1 minute should be allowed. 10 minutes is not possible.
Okay, I'm so sorry. So this 62 years female with the history of 8 years of type 2 DM had come to me when her GP referred to me. And then what I understood that is the diabetes is really multifactorial. So understanding the person as a whole and their family members is also important in our everyday workup, so that we can further prevent cognitive decline, so that she or he cannot progress, or we can prevent or delay the onset of dementia, the frank dementic behavior in the person with, actually can we prevent cognitive decline. So not really if we fail to help the person identify the family members not understanding, controlling metabolic factors, not able to receive adequate help. We can't address the stress, depression. If we are not able to adapt the MBM in our Indianized model, this could be really, really non-deleterious and pushing towards the dementia incidence and prevalence. But we still can prevent, actually possible, if we rightly identify the patient at early stage, from middle age, older persons or elderly. We help them with the teamwork, objective and subjective workup, address the stressors, work on a serial cognitive evaluation, domain specific work, and that could be helpful, that we work in terms of promoting brain health using art, pre-morbid likes, music, social, spiritual skills, enhancing, promoting important compensatory strategies. And then with that, we can have important prevention, or I would say promoting cognitive health and maintaining the cognitive health by physically being active, reducing cardiovascular risk factors, regular discuss with family and the patient how he or she is feeling, and overall cognitive health in terms of focusing, rewinding, rejuvenating mind, which is full versus mindful activities. In a person, individualized and group-based activities. We have several constraints to meet these solutions, but technology can be helpful. Everyday computerized cognitive modules can be given. We can have some simple WhatsApp or a Zoom calls, so that patient need not to come all to the clinicians all the time, but we can see how they are able to do it. Are they cheating and not following the program, unregime brain gyms? Are family members not caring enough, or they are really making significant progress? So small and steady steps are very important. So active trials could be really implemented in type 2 DM, where not active trial alone, but it could be a similar replicated trial like active trial, which could be helpful in terms of understanding cognition in human brains, specifically with systemic diseases like type 2 DM. and we can prevent, promote brain health, we can address the key issues, we can maintain holistic brain health. So there is a long way, but yes, we can still take a small, steady, optimistic steps. So I dedicate this talk to Dr. Sanjay Phadke sir, Dr. Leena Phadke ma'am, and my first mentor in cognition, Dr. Suvarna Alladi, for always supporting me in cognitive neuroscience rehabilitation. I thank my team, Bharati Vidyapeeth, School of Audiology, Speech Pathology, and Deenath Mangeshkar and Neuro Society of India. And I thank Mind Body Medicine team. And thank you so much for all.
Thank you, Dr. Sonal, for covering all the pertinent aspects of cognitive issues with respect to the diabetic pathology, particularly highlighting the role of the speech and language professional and the assessment. Our next speaker, it's my pleasure to introduce Dr. Shripad Pujari, who is my senior from BJ Medical College. He further went on to complete his internal medicine training and trained in neurology at the Sir J.J. Hospital in Mumbai, and has done a fellowship and research work in London. His special interests are multiple sclerosis, neuromyelitis optica, and neuroinflammatory disorders. Since coming back to our HQ, that is Pune, he has set up a thriving practice with good patient outcomes and is an ardent practitioner of patient-centered treatment and mind-body medicine. He will address us today about the cognitive issues in diabetes mellitus. Welcome, Dr. Shripad Pujari. You're muted. You'll have to unmute yourself.
Thank you, Dr. Kulali, for this very nice introduction. And I'll just share my presentation. Is it visible and am I audible?
Yes, sir.
Yeah.
Yes, sir.
So I'm so thrilled today to be with my colleagues, many of them right since my BJ Medical, as Dr. Kulali said, from my BJ Medical undergrad days. Vaishali and Chetan, we've been together since our MBBS days. We did our medicine residency together and then went on to Mumbai together to do our respective DMs. And I'm really thrilled here that they've managed to form this sphere, and through that they are propagating knowledge and practices of this very unique area of medicine, which is relatively less addressed, certainly by the Western conferences. I'm very proud of both of them being my so close colleagues since my internal medicine residency, that they have managed to hold this 4th year of this conference. And I'm thankful to them and to all organizers of Synapse. Thank you, Vani, for introducing me. So Sonal has already introduced the topic so well and put in so many points, right from assessment, following up those patients, the pathogenesis a little bit, which actually I am also going to introduce to you, and then how to look after cognitively these patients. My lecture, I have pitched it in the following way. The first 4 points are the preamble to therapies, and which will include the domains of cognition involved and the way to measure them. The pathophysiology a little bit, although Sonal has also introduced it, I'm going to introduce it in a way by which I can use those points in my therapeutic slides. And a strong relation between diabetes and Alzheimer's, a little bit on summaries of all the pathways, how they cause neuronal death, the therapies, the role of anti-diabetic drugs themselves on cognition, the rationale for treating with intranasal insulin, which is a concept that is coming up, acetylcholinesterase inhibitors themselves, cognitive therapy. I have put in as a bullet. We've already heard from Sonal, and exercise and yoga, and then my conclusions. So, as rightly said by Sonal, less attention has been given to the effects of diabetes on cognition. Unlike some others, where we have poly OPDs now, which look after the other areas. Let me remind you that it's not just type 2, but the cognition is worse even in type 1 diabetes. And the onset actually occurs earlier than type 2 diabetes patients because their diabetes is even worse control and difficult to control as compared to type 2. And it worsens with increased diabetic complications. Type 2, we all know, has been associated with global cognitive dysfunction and with an increased incidence of both vascular as well as Alzheimer's dementia. The ways by which we can measure are through cognitive testing, as Sonal mentioned, imaging, wherein we can use both MRI as well as the PET and SPECT scans, and also electrophysiologically through EEG and evoked response potentials. And I'm going to show even therapeutically how changes come in diabetes. As Sonal mentioned, the common deficits are in recent memory, slowing of information and processing speed, worsening of psychomotor efficiency, and there are more in terms of motor speed, vocabulary, visuospatial construction, attention, somatosensory evaluation, and in executive function. A bit of looking at the brain imaging. A systematic review of brain imaging studies has already been done in patients with diabetes. Data on relation of imaging with cognition has been recorded. CT and MRI studies have shown a relation between diabetes and atrophy as well as with lacunar infarctions. MR spectroscopy, you all know, is another tool that has come up. N-acetyl aspartate is a marker of neuronal integrity and myoinositol of glial cell damage. And diabetic patients have shown reduced NAA to creatinine ratio and elevated myoinositol to creatinine ratio. PET and SPECT studies have also shown regional alterations in cerebral blood flow. EEG correlates of cognitive function have been studied and compared with Alzheimer's disease. And even type 2 diabetes will perform worse. The study has shown mainly worse on learning and memory tests. An EEG counterpart has shown reduced alpha and beta activity and increased delta and theta. And remember, the delta and theta are slow waves associated with cognitive dysfunction. With that, I'm going to move on to the pathophysiology, and there are a host of factors, as you can see, that contribute to cognitive decline. Before I start talking on pathophysiology, I have introduced this simple slide on neuropathology and neurotransmitter problems in Alzheimer's because I'm going to use these points to explain you the pathophysiology. We all know the main pathological markers in Alzheimer's are beta amyloid plaques, as you can see here, and the intracellular neurofibrillary tangles. And I'm going to show in my next slides how type 2 diabetes contributes to formation of these. And at neurotransmitter level, most of you know that there is acetylcholine deficiency in Alzheimer's disease. So, advanced glycosylation end products are formed, we all know, during chronic hyperglycemia. They bind to the receptors on microglia, stimulate release of free radicals and cytokines, and promote development of amyloid and neurofibrillary tangles. These end products induce beta amyloid and tau protein glycation itself, thus leading to their aggregation and hyperphosphorylation, leading to Alzheimer's progression. The end products themselves induce insulin resistance by forming adducts with insulin and thereby interfering with insulin signaling, which is so important in the brain. Hyperglycemia itself increases production of oxygen and nitrogen species, and we all know they worsen the oxidative stress, thus promoting Alzheimer's. Acute hyperglycemia itself, immediately, you don't need long-term hyperglycemia. Acutely as well, it causes slowing of cognitive dysfunction. Effective glycemic control has been seen in cognition. Just improved glycemic control has shown improvement in cognitive functions. DCCT, our most popular trial, itself showed that those with HbA1c less than 7.4 fared better than those who had worse HbA1c levels. And effect has also been shown on MRI. Comparison of intensive diabetic control with standard therapy has shown slowing the rate of brain atrophy on volumetry of MRI in patients with intensive control. Hypoglycemia, we all know there have been several studies. It is clearly linked to cognitive decline and increased dementia risk. We all know diabetes is one of the most important causes of vascular dementia, and through macrovascular damage, atherosclerotic stenosis of large arteries leading to cerebral infarctions, what we call multi-infarct dementia, and then microvascular small vessel disease causing the subcortical vascular dementia. Insulin resistance and amyloid, we all know there is many times fold in higher insulin resistance in type 2 diabetes, and Alzheimer's incidence is higher in patients with diabetes. Deposition of beta amyloid itself in the pancreatic islets, it's very similar to beta amyloid deposition and neuronal loss in Alzheimer's, and such deposition in islets leads to beta cell loss. Insulin resistance by itself increases peripheral insulin levels, but reduces the insulin levels in the brain due to decreased permeation of insulin, and also causes reduced insulin function in the brain due to reduced insulin signaling. The role of insulin resistance, it causes increased levels of beta amyloid peptide, facilitation of phosphorylation of tau. It leads to oxidative stress and activation of pro-inflammatory cytokines. Altered insulin and insulin-like growth factor signaling modulates acetylcholine levels, modulates amyloid peptide levels in the brain, increases tau phosphorylation, thus leading to increased NFT formulation. And the cholinesterase connection is very important. At neurotransmitter level, I just said acetylcholine deficiency in Alzheimer's. Acetylcholine esterase enzyme is the enzyme that degrades acetylcholine. Activities of this enzyme are elevated not just in Alzheimer's, but interestingly, their levels are higher even in type 2 diabetes patients. And a very important issue, the relation of diabetes to Alzheimer's disease itself. We all know type 2 diabetes is a risk factor not just for cognitive decline by other modalities, but also for Alzheimer's dementia. Both disorders share common pathogenesis in the form of altered glucose metabolism, impaired insulin signaling, increased oxidative stress, inflammation, premature senescence. So type 2 diabetes has to be addressed for cognitive function. So how does this happen? Type 2 diabetes is associated with hyperinsulinemia. Insulin degrading enzyme by itself regulates not just levels of insulin, but also beta amyloid protein and its precursors. So both insulin and beta amyloid are substrates for the enzyme. Therefore, hyperinsulinemia will lead to accumulation of beta amyloid through competing with insulin for the insulin degrading enzyme. Also, altered insulin signaling interacts with beta amyloid protein deposition and tau protein hyperphosphorylation, which we all know are basic substrates for Alzheimer's. So to summarize the causes of neuronal cell death, altered brain metabolism, insulin resistance, alteration of amyloid precursor processing, beta amyloid toxicity. Another point is defect in signal transduction leading to tau hyperphosphorylation. We all saw oxidative stress leading to mitochondrial dysfunction and defecting energy metabolism, and signal transduction shifting in glial cells leading to pro-inflammatory cytokine release. All of them put together lead to neuronal cell death. And then to summarize all the pathways leading to dementia and diabetes, we saw micro as well as macroangiopathy, then hyperglycemia and glycemic fluctuations and its related cascades, hypoglycemia, then insulin resistance, which contributes to amyloid and tau aggregation and phosphorylation, and then the inflammation and age itself. So with that preamble, I move to therapies. The therapies are divided into medicines, and I'm going to talk a bit about anti-diabetic drugs, how they improve cognition itself, then the role of acetylcholinesterase inhibitors and nutraceuticals, cognitive therapy, Sonal has so nicely elaborated, And then other non-pharmacological interventions such as exercise, yoga, and meditation. And I'm going to produce evidence for most of them. So anti-diabetic drugs themselves, drugs currently approved have been found to be useful in treating cognition and Alzheimer's as well. They not only improve the diabetes and the cell metabolism, but they also counteract inflammation, oxidative stress more so associated with insulin resistance, and they positively affect cell metabolism in the brain and improve cognition. I'm going to show a bit of both the hypoglycemic agents as well as the anti-hyperglycemic agents. So this table includes experimental studies both in mice as well as humans. And this first one is on the hypoglycemic agents. Beginning with insulin, has shown to reduce hippocampal amyloid, reduce apoptosis, and improve hippocampal synaptic plasticity. In humans, it's shown to improve attention as well as memory. Sulfonylureas has again showed similar pathogenesis in mice, and there are studies on improved verbal learning. As far as the anti-hyperglycemic agents are concerned, in mice, metformin shows to reduce tau phosphorylation, and hippocampal amyloid. And in humans, improved working memory and has been shown to reduce dementia risk. After metformin, the highest evidence has been with GLP-1 analogs. And they've again shown to reduce beta amyloid plaque in the cortex, inflammation, and tau hyperphosphorylation. And evidence has been found in improving cognitive decline even in humans. The rest of the drugs, thiazolidinediones, as well as DPP-4 inhibitors and the amylin analogs, have shown to produce good effects in mice, such as, again, hippocampal beta neuronal apoptosis here, as well as synaptic plasticity. With the DPP-4 inhibitors, also on the nitrous oxide stress, inflammation, and on tau. With myelin, you see again on oxidative stress, neuroinflammation. But data on these three on humans is still underway. And I'm sure in future we are going to see some evidence in human beings as well. Most important effect of insulin is mediate. How does insulin mediate its effects? Insulin binding to IGF receptors attenuate the glycogen synthase kinase alpha and reduce effects of beta amyloid precursor and tau. Remember, this GSK3 alpha otherwise promotes amyloid aggregation and tau hyperphosphorylation. Insulin also causes attenuation of beta amyloid binding to neurons and thus protects synapses. It also leads to increasing transcription of anti-amyloidogenic proteins such as insulin degrading enzyme we just saw, and reduces transcription of pro-amyloidogenic proteins. There are several studies poured in justifying the rationale for using intranasal insulin. What are the points? The points are insulin receptors are identified in the brain, highest concentration, remember, in the hippocampus and other cognitive centers. Intranasal application bypasses the blood-brain barrier, directly enters the brain, and detected in biological relevant concentrations in 40 minutes. And intranasal insulin has not so many side effects as systemic. Alzheimer's itself is associated with brain insulin resistance and insulin deficiency. Diabetes patients successfully managed with insulin had a significant improved cognition and attenuated progression of Alzheimer's. And insulin therapy itself has improved memory and cognition in patients with Alzheimer's. So with that, I move on to next set of agents. We all know acetylcholinesterase inhibitors are recommended by both American and European Academy for treatment for Alzheimer's. They've also been extensively tested in vascular dementia. A Cochrane database review more than 4,000 participants have shown moderate to high evidence that donepezil and galantamine, two important inhibitors, have a beneficial effect on cognition. There are a lot of literature on nutraceuticals. I have just listed a few: curcumin, flavonoids, omega-3 fatty acids. But My assessment is there are limitations as majority of them have been tried either in normal individuals or age-related cognitive impairment and Alzheimer's. I couldn't find much specific data on diabetics with cognitive impairment. Having said that, they are harmless and they can be used along with other rational agents. Moving on to non-pharmacological interventions, you heard Sonal on cognitive therapy, and I have here now a very important study on exercise. SMART study had shown convincingly that exercise interventions were effective in reducing cognitive impairments, not only in Alzheimer's. In Alzheimer's, they say exercise and sleep are the only two modalities that clear up amyloid from the brain, but not only in Alzheimer's, but also in diabetes. With yoga, there have been several meta-analyses which have shown effects on cognition. I've just quoted two large meta-analyses. The first one has using mainly pranayama and dhyana have shown strongest effect on many of the cognitive parameters, and another one by GARD, wherein studies were on transcendental meditation, mindfulness, and kirtan kriya, has shown positive effects again on several areas of cognition. With diabetes, initially there were small studies like the one I have shown, which have shown improvement in cognition on Edinburgh scale. Then larger studies which tested specific modalities. This one, as I show, yoga practice over a long period of 6 months compared with 8-sex matched control have shown a significant role in eliminating decline in memory as assessed by PGI memory scale. And another one with yogasanas and pranayama for a long duration, again, a case controlled one, again has shown improvement, beneficial effect on Edinburgh's cognitive assessment. Not just on yoga is not just shown on cognitive parameters, but also on metabolites. We all know, I just showed in my previous slide, chronic hyperglycemia and diabetes affects CNS by altering concentration of brain metabolites. And AA, as I said, is an indicator of neuronal integrity, and myoinositol, an indicator of glial cell damage. And yogasanas and pranayama have minimized damage as shown by minimal changes in both of these neurometabolites on dorsolateral frontal lobe, which is, we all know, involved in episodic memory. Evidence has also already been produced for what we call evoked potentials. You remember we do nerve conductions, and likewise we do evoked potentials for both vision as well as brainstem auditory responses. Likewise, we can perform some for cognition as well. And we have P300 potentials, which measure component of cerebral evoked response. And these are the ones that assess higher functions in the brain. And an intervention of 45 days yoga with recordings of P300 and blood glucose has shown a statistically significant improvement in the latency as well as amplitude of P300 in the yoga group. With that, I finish my lecture with the following take-home messages. Diabetes is associated with improved deteriorated cognition and an increased risk of dementia. And diabetes has a strong association with Alzheimer's through common pathogenesis such as impaired insulin signaling, altered glucose metabolism, inflammation, and oxidative stress. Improving central insulin levels could be a promising method for treatment of cognitive decline. 70 diabetic drugs, as I showed in the table, can impact on neuroprotection, neuroinflammation, synaptic plasticity, and protein aggregation. Preclinical studies on DPP-4 inhibitors, GLP analogs, and antagonists have shown to be promising targets for neuroprotection. As of now, acetylcholinesterase receptors are recommended not just in Alzheimer's, but also in vascular dementia. As we all know, it's the commonest complication of diabetes. And cognitive therapy, even at the level of, into inverted comma, normal cognition, as Sonal just said, has to begin, and cognition needs to be continuously monitored. And through my evidence, through the evidence that I just showed, exercise and yoga have shown beneficial effect on cognition in diabetes. Thank you.
Thank you, Dr. Shripad, for a very crisp and what I would say understandable presentation. Which is process. It was a very good and easy lecture to understand. Today is Rajkumar Vadva. Can I have his introduction slide, please? Sir is joining us from Mysore this morning. He's a senior gastroenterologist and who has more than 2 decades of expertise in luminal gastroenterology, hepatology, therapeutic endoscopics, endosonography, double balloon enteroscopy, and per-oral cholangioscopy. He has much work in, I did some background research, so I found this. He has done a lot of research in functional gastrointestinal disorders and pain management. His style of working is multidisciplinary, and he actively pursues overall recovery for the patient and coordinates with whichever professional is required to give that kind of recovery. I welcome you, sir, today to give your presentation.
Thank you, Dr. Vani. Can I share my screen?
Go ahead.
Can everybody see my screen?
Yes, sir.
Yes, it's very clear.
Before I start, I would like to thank organizers of Synapse for giving me this opportunity to speak on gut-brain link and a prototype disorder associated with gut-brain link. We will speak initially of the anatomy and physiology, and then try to give a prototype disease as to how gut-brain link manifests itself in the form of a GI problem. Gut-brain axis or a gut-brain link is actually a bidirectional link. That is the descending neurons from central nervous system to the stomach and the intestine, and enteric nervous system, ascending neurons to the central nervous system. These 2 core structures is associated with a lot of crosstalk with endocrine, immune, and autonomic nervous system. We need to keep this in mind. We will try to understand all this in today's terminology. So we will look at it in this way, that from the central nervous system, afferent and efferent neural signaling is via vagus nerve and dorsal root ganglia to some extent. Adaptive responses in this system is through hypothalamo-pituitary adrenal axis. This is mixed with immune cells, epithelial cells, enteric neurons, smooth muscle cells, which are present in the gut per se, which functions as a unit to influence intestinal function. And all these 3 are intricately linked to gut microbiome. I'm not going to speak much on gut microbiome because I have been given an idea that gut microbiome has been spoken about as a full lecture. So we will restrict ourselves to the rest of all modalities in between the gut and brain axis. Now, to understand the gut and brain link, let us think in today's term as your mobile phone and take it as a computer hardware software interaction. Here in the computer, the input is given by our diet, the gut microbiome, and variety of neuroendocrine cells in the form of mechanical and chemical signals. You can understand that mechanical signals also can originate from both the diet as well as a gut microbiome. These are called as mechanotransduction, and chemical signals by secretion of variety of substances which come during the processes. To make it simpler, I'm not going to go into the details, but it is something like this, that once you have the input given to them, the processing starts. The processing is done into a variety of tier systems in the enteric nervous system, both for upscaling the input data and for downscaling from the central nervous system. These things are divided into broadly 4 tiers. The first tier is actually the cells which are exposed to the gut lumen, and they have neurons As you can see that neurons are present in every layer of the intestine, which starts in the enteric nervous system, as you can see from the mucosal cells to the submucosal area, muscularis mucosae, and right up to serosa. These neurons have the neurotransmission capabilities which process the information of the state of gut, whether the gut is having food, whether the gut is not having food, whether the gut has gas, some chemicals which are present in the gut. All this is processed by the tier 1 system that is in the form of neurons, and there is a chemical neurotransmission, chemical and electrical neurotransmission. It also has a library of apps. We have on our Android systems, we have apps to do banking, we have apps to listen to music, we see videos on it. Similarly, these systems have a certain specific functions, and these apps can be put it into such a way that you have an interdigestive app, you have a pro-motility app during the time of digestion, you have a physiological ileus apps, are some of the examples which we have. These neurons, and they form a polysynaptic reflex circuits. These are forms the tier 2 of the signal processing. These circuits actually have a stereotypic motor patterns in the gut. You have a migrating motor complex which takes your food in a large scale from the proximal small bowel to a distal small bowel, or it generates the desire to defecate in a single large wave. And these are from the tier 2 reflex circuits. These are called as polysynaptic reflex circuits. Tier 3 is central pattern generators. These are actually the neurons which will intercollaborate with the central nervous system, and they have repetitive motor and secretory patterns from the accessory glands as well as from the small bowel. You need to keep this in mind that while the first tier 1 and tier 2 are dependent on the sensory inputs which are given through or within the lumen or within the wall of the bowel, the central generators are independent of the sensory input. And the last neurons will help us to understand the plasticity or the adaptability of our small bowel. Plasticity, as we describe it, is as the regenerative capacity after a certain component of a particular neuron circuit has degenerated or we have lost it. Then this is called as a plasticity, and this is important for us to understand the physiological health of the small bowel. This is where it starts. So you have an input modality, you have a processing modality, and you have a link to the central nervous system. Now this goes through the afferent spinal, which is also called as dorsal ganglia. These ganglia, 3 to 7% of the nerves from these ganglia actually take the sensory input from the gut and take it to the central limbic system. Majority of the vagus nerve is actually a sensory nerve, while 1:10, that is 10:1 is a sensory nerve. For every 1 motor fiber in a vagus nerve, you have about 10 sensory fibers, and they carry these through. There is a gateway theory for the pain modulation in this situation where the sensitivity or hypersensitivity is modulated at the level of the vagus nerve. Descending projections from the limbic system influences the autonomic activity of the gut, and it is again delivered via the tier 3 and tier 4 neurogenic components which we have described earlier. So now you have the input data, you have the processing in the periphery, you have the processing in the central nervous system, and then delivery back into the thing. But all these things are modulated by a variety of systems. The prominent of them are neuroendocrine signaling. We all know that there are plenty of neuroendocrine cells distributed throughout the GI tract. Some of them which can be like cholecystokinin, gastrin, GLP and peptide YY, motilin, histamine, neurotensin. All these affect the functioning of the gut as the neurons actually get excited or settle down. We also have the affection of the gut-brain link by the immune system. gut-associated lymphoid tissue, or as we call it as GALT, is the largest lymphoid tissue in the human body. And 70% of the body's immune system is formed by the GALT. This has a very important both effect in the association with the genesis of inflammation or subsidence of the inflammation. Whenever the vagal nerves are activated, it actually has an anti-inflammatory effect. While if the sympathetic nervous system is activated by alpha-2 receptors, it is a pro-inflammatory. Anti-inflammatory sympathetic are beta-3 receptors, which are prevalent in gut. So you have both the enhancement of the inflammatory action and suppression of the inflammatory action by the nerve supplied to the gut. We also believe that because of this, the inflammation, which puts up the changes in the nervous system of especially in the tier 2 and tier 3 and tier 4 system, where the neuroplastic changes can persist. Whenever the inflammation causes the changes in the thing, a physiological adaptability is called as neuroplasticity. And when that physiological adaptability is lost, then it is called as loss of neuroplasticity beyond inflammation, which is a classical feature in post-infectious irritable bowel syndrome. We also have the intestinal barrier, which is a single sheet of epithelial cells which separates the host from the intestinal lumen. The junction between these two are called as tight junctions, and they prevent the transfer of the gut, both bacterial polysaccharides, the luminal secretions of bacteria into the system. However, there are situations when this becomes weak, and that is called as a leaky gut syndrome. A classic example is a chronic stress, which is associated with low-grade inflammation, as can be seen in these situations with increasing levels of TNF-alpha, gamma interferon, and interleukin-6. It also downregulates the glucocorticoid receptors and reduces the hippocampal serotonin, thus resulting in what we call it as a genesis of IBS or depression. While we have the input, we have the processing systems, we have the modulators of the processing system. The output is seen in the form of nociception, in which we perceive the bloating or the pain, viscerosomatic reflexes where there is a hypersensitivity to the pain, and alteration of the motility, resulting in the responses of pain, bloating, abdominal distension, and altered bowel habits. This is how the gut actually responds to changes of the gut-brain axis. In summarization, our gut works as a computer where you have an input which can be modulated by microbiota, intestinal inflammation, and diet. These are actually transmitted through either a mechanotransduction or a chemotransduction. Along with that, you have stress, which can give directly a CNS input. These are modulated by a variety of life experiences and the changes in the gut-brain axis, resulting in abnormal nociception, viscerosomatic reflexes, or altered motility in the small intestine. We will look into a typical prototype of disorders of brain-gut axis, where more than 40 disorders of brain-gut axis has been described by Rome 4 Foundation, which is the highest body which actually looks into variety of GI disorders due to disorders of brain-gut axis, or also called as functional GI disorders. We will discuss this in the form of how a clinician should deal with this in a non-expert setting. IBS is actually the most common of the GI disorders in the primary and specialty care. In primary care, up to 25%, and in specialty care, up to 50% of the patients are actually irritable bowel syndrome or a functional GI disease. Affects 7 to 21% of the world's population. Two population-based studies in India, one from All India Institute of Medical Sciences, which showed the prevalence of 4.2% amongst the population of approximately 2,500, and another from Bombay, which showed the prevalence of about 18 to 20%. Wide variation, but we know that our data figures lie somewhere in between. Unfortunate thing is only about 20% of these seek medical care, and majority of them continue to suffer symptomatic problems associated with this. Symptoms are 1.5 to 2 times more prevalent in US in women as compared to men. That data has not been substantiated in India, maybe for the reason that women seek less medical help as compared to men in India. The importance of this is it significantly diminishes the quality of life and the work productivity. As discussed, there are multiple factors which leads to genesis of irritable bowel syndrome, starting from visceral hypersensitivity, psychosocial factors, gut immune activation, microbiome, increased permeability, and abnormal motility. IBS is classically should be diagnosed as a positive diagnosis rather than a negative diagnosis. The purpose of saying this statement is we should be able to diagnose it based on the clinical presentation rather than depending on investigation to prove that it is an irritable bowel syndrome. And Rome 4 criteria helps us in doing this. Recurrent abdominal pain, averaging 1 day per week in the last 3 months with the following criteria: related to defecation, associated with change in frequency of the stools, either constipation or loose motions, and association with the change of form. Criteria fulfilled at least for 3 months with the symptoms onset of more than 6 months is when we define it as irritable bowel syndrome. The characteristic symptoms of irritable bowel syndrome are diarrhea, constipation, and mixture of constipation and diarrhea, or we also call it as mixed type of irritable bowel syndrome. These primary symptoms are associated with abdominal cramping, bloating, or urgency or fecal incontinence. British Stool Form Scale helps us to differentiate this IBS into IBS constipation type or IBS diarrhea type by differentiating the stool form. It has been proven that visual form of stool, asking the patient, is much better than asking what type of stool they pass, because interpretation of stools can be different. So presenting a picture of stools to the patient and asking what kind of stools they form is much more helpful in classifying the disease than actually asking them just a simple question. We do not recommend a large amount of test as far as the irritable bowel syndrome is concerned, but a basic evaluation is desirable. In such situation, we ask for a hemogram, ESR and CRP to look for inflammatory markers, and ultrasound abdomen to look for any disease. In a specific circumstances with diarrhea, you can ask for fecal calprotectin to differentiate it from inflammatory bowel disease. Giardia antigens, we don't use it. We rather treat it with the imidazole group of drugs and get away with it. In certain situation, when you are looking for celiac sensitivity, IgA of tissue transglutaminase or even DGP can be combined and asked for. If we suspect that there could be a doubt in the diagnosis, colonoscopy is asked for, and we have to obtain a random biopsies. Serum HCAT, fecal bile acids, or serum C4 are only in a very specific circumstances. The mixed is basically mix of investigations between the constipation type and diarrhea type. Constipation type is more easier to evaluate, less investigations, mainly to make sure that you do not have an obstructive bowel disease in a constipation. That will be the primary modality to check for. How do you differentiate the irritable bowel syndrome, which is a functional GI disorder, with the actual disorders which can cause a loss of life or it can cause a significant morbidity? There are certain features in the history of the patient which will give us an idea that this is not a simple IBS, and these are presence of nocturnal diarrhea. Nocturnal diarrhea, in meaning a sense, is a patient going at 12 o'clock in the night doesn't mean it's a nocturnal diarrhea. Nocturnal diarrhea is the patient has gone to the sleep, he gets disturbed in the middle of the night, wakes up and goes for toilet. That's when then it is defined as a nocturnal diarrhea. Any elderly person first time presenting with symptoms or presenting with a new onset of symptoms should always be viewed with suspicion. Family history of organic GI diseases, especially malignancies, are a red flag for us. presence of rectal bleeding, unexplained iron deficiency anemia should not be treated as irritable bowel syndrome unless and until you have found a source of unexplained iron deficiency anemia. And unintentional, unexplained weight loss is also in the category, which puts us to the diagnosis that this is an organic disease rather than a functional disease. The differentiation in a constipation form from functional constipation to irritable bowel syndrome is only a single notation, that is presence or absence of abdominal pain. If the patient comes to you with the abdominal pain, then you have an irritable bowel syndrome, which is the key factor in this situation to differentiate between the two. However, treatment remains very similar, except that functional constipation rarely ever requires a cognitive behavioral therapy or drugs related to neuromodulation. When do you send it to a specialist? When do you send an irritable bowel syndrome to a specialist? Majority of the patients of IBS can be effectively managed in primary care. Referral to gastroenterologist is warranted only when you have a severe or medically refractory IBS. Severe in the form that patient is having associated neurocognitive disorders which are affecting day-to-day life, and patient is not improving on the primary therapy. And similarly, in those patients with organic signs, which I just have featured in the previous slide, this should be referred to gastroenterologists and not treated as irritable bowel syndrome. However, make sure that you are familiar with the Rome criteria. Make sure that you are familiar with the diagnostic criteria before you are sending them to the specialist. Treatment of the patient actually starts from explaining the illness to the patient, and this explaining the illness there's an assurance needs to be given that this disease is never going to take your life away or going to cause you severe organic morbidity. Here you can explain that brain and gut constantly communicate using nerves and chemical sequences. When there is something wrong, then you may perceive the gut more strongly impulses or may send an inappropriate signals leading to either a diarrhea or a constipation. We need to make sure that we are speaking to the patient nothing but the truth. We need to explain we still do not know the cause of IBS. We should not tell them that nothing happens to you, don't worry about it. Something like that, you are not going to help him out in any way. We need to tell them that it is not a severe disorder, but it is a chronic condition for which there is no cure. There will be remissions and relapses. There will be times when he will feel absolutely fine. There will be times when he will feel absolutely miserable, looking towards wall or the world collapsing onto him. This can affect the quality of life. It is mainly a symptom-based test, but we may do some tests to get the right diagnosis in these circumstances. He, however, can take back the control of his life. The treatment approach should be in a way that you start with education, reassurance, and diet and lifestyle advice. If the symptoms worsen, then pharmacotherapy can be introduced. Consider that psychological treatment in this to precipitate the stressors when it becomes severe, mainly to get the pain under control. So neuromodulators and psychological treatment can be added into these circumstances. So please keep in mind on day one of your diagnosis, do not introduce neuromodulators in these circumstances. They don't deserve to be added with that. We all know that lifestyle modification helps a lot. I won't go into the details of it, but a proper sleep and a regular exercises will go a long way in helping him to overcome the symptoms. Variety of foods have been discovered. In fact, 80% of the patient will tell us that their food is the precipitant of their symptoms. On internet, there are hundreds of different types of diets which have been given. And I believe that when you don't have a smaller set of answers, you don't have an answer. So you have a multiple diets, you don't have a diet as an answer. Here it is, the diet should be based on basis of an individual person rather than one thing fits all. FODMAPs have been actually most investigated and found to have some effect However, the evidence is still weak for it to be applying universally to all patients of irritable bowel syndromes. So you have lots of therapies available, which will be mainly directed to the symptoms of either abdominal pain or discomfort, bloating or distension, and constipation or diarrhea. They are symptomatic treatment. We will focus on to neurocognitive treatment separately, but primarily, if you have a bloating, then you have to have a diet as a control, and antibiotic probiotic combination can be given once or twice in a short burst of 2 to 4 weeks of duration of therapy. Specific abdominal pain needs to be treated with antispasmodics, constipation to be treated with laxatives, and diarrhea to be treated with the antimotility agents. There are a lot of psychological therapies present, which are the target symptoms. Evidence-based treatments are cognitive therapy, hypnotherapy, relaxation therapy, dynamic psychotherapy. I'm not an expert in this, but I do believe, my colleagues do employ these types of therapy after selecting the patients. When you do believe that you need to put in a neuromodulator, then there are 4 groups which we use: the SSRIs, TCAs, tetracycline antidepressants, and SNRIs. This is Rome 4's recommendation of a particular group of drugs to be used in particular set of symptoms. When you have a depression, phobia, or anxiety, SSRIs are the preferable drugs, while TCAs are the primary drug for pain. If not, then SNRIs can be given. For bloating, nausea, vomiting, try tetracyclic antidepressants like mirtazapine, mianserine, or trazodone is useful. In fact, mirtazapine also normalizes the gut motility. So it has a dual effect. It has a local effect on the gut as well as the central effect on the neural system. I am just adding a couple of slides on to another disorders which can be technically difficult. It is called as the cyclical vomiting syndrome. I will just go through briefly that this includes all of the following: acute onset of vomiting of a stereotypical nature. Patient will have vomiting starting in the morning or starting in the afternoon, starting after the meals, or starting after a particular stressful thing. But they are usually presenting in less than 1 week's duration. When they start with diaphoresis. They will have a series of vomiting continuously, and over a period of next few days, it will subside. Interval period will be completely normal, and then they will have a repeat attack. When these occurs multiple times, at least 2 times in the last 6 months, and we don't find an organic cause, then you can consider cyclical vomiting syndrome. An associated history of migraine headache in the patient or in the family helps in diagnosis of cyclical vomiting syndrome. CVS forms about 15% of unexplained nausea and vomiting. Mean age of onset is usually young people. Both men and women are equally liable. It may be linked to menses. The other precipitating factors are stress, sleep deprivation, infections, foods, other sicknesses, and medications. The classic treatment is 5-HT3 antagonists, which are the drug of choice. Ondansetron or granisetron can be given in these situations. The other drugs which are used are promethazine, prochlorperazine, and aprocitentan. Prophylaxis is usually by tricyclic antidepressant, but it may not work in about 50% of circumstances. Thank you for your patient listening on the brain-gut link and disorders of brain-gut axis.
Thank you very much, sir. We got a lot of information about the physiology of the gut-brain link. I think it's a dynamic and evolving system. And I agree with you that the IBS is a very common, my personal experience also is that it was a question asked to me both in my MBBS final exam as well as the MD final exam. So that's how common it is. So I encourage all the attendees, audience to please ask any questions or share any comments. Anybody having any questions? Okay. So I think then some questions coming to my mind. So Dr. Wadhwa, it is often my experience as well as my colleagues' experience that irrespective of what the key reason the patient is with us in any practice, whether it's neurology, psychiatry, or a general practice, some of the other gastrointestinal symptoms do come up. So what would be the threshold at which we should escalate and refer to a specialist gastroenterologist service?
There is no specific time frame. It all depends on the severity of symptoms and affection of his life on a day-to-day basis. If the symptoms are mild, patient is able to tolerate, then I think, as I described, that is the target 1 and target 2 should be managed in general care practice. At least, 2 to 3 months of trial of therapy at a general level is acceptable. If he is not responding, he's developing a new symptoms, worsening in his symptoms, then that's the time when a gastroenterologist should be involved. And as I said, that it is a multidisciplinary way. So we tend to involve our psychiatric colleagues in the process of treating these disorders, even when I feel that, yes, it's an extremely tough for me to treat these symptoms.
Thank you very much, sir. Dr. Shripad, I was thinking that we went through a lot about the physiology, and many times when patients come to me for assessment of dementia, sometimes I feel, okay, there could have been something I could offer to them had they come a little earlier. So would you throw some light on how we can approach the early diagnosis of cognitive dysfunction?
Yes, actually, I did not elaborate much. I agree with you. I did not elaborate so much on early diagnosis or early detection. I think Sonal did touch upon that point, and she rightly mentioned that, see, formally during our MBBS as well as MD days, MMSC is the thing that we are taught. But as she rightly has pointed out, first of all, MMSC is a very brief scale and with a lot of limitations, and we should probe into detailed cognitive dysfunctions in each spheres, each lobes, frontal, parietal, temporal, as we learn and teach ourselves. And I did mention a brief point as an introduction, actually, that unlike the nephropathy, the cognitive impairment is not screened right at its outset. And I must say, you have really raised a very important point. I say, like we have multidisciplinary clinics, even now in India, where a diabetic patient is seen by the nephrologist, the endocrinologist, and the diabetologist, everybody. And we, I must say, I would take a bit of responsibility for that. We do check for peripheral nerves very sincerely, but not so much cognition. And I think in our clinics, we should deploy a psychologist who will periodically perform detailed scales such as Addenbrooke's or MUCA. And if found, then counseling that wise also need to be performed. I agree with you.
So that's, I think, a very important.
Yes, it
will be an advance in the treatments that we offer to the community, where a holistic approach is there. Now, when we diagnose, Dr. Sonal, what options can you offer for intervention, especially with the early cases of cognitive dysfunction?
Thanks for this question, ma'am. Yes, so when at the early stage, when they are referred and they are found to have either amnestic mild cognitive impairment of a single domain, it could be only memory domain, it could be only attention and executive function domain, or it could be language, or it could be having multiple domains involved. So we target the domain of cognition. Then we need to really understand the person's occupation, his needs, community needs, social and family needs. And as per that, we need to really make a client-centered intervention. So early stage, it could be early for us because it is just 4 or 5 years of the diabetes type 2 or but then for that person, the declining cognition could be from earlier, which he or she must have not even reported or he must have denied. So I feel helping the person identify it rightly, offering the intervention, and then steadily seeing, is he improving on those cognitive domains with the right scales? and the patient's perspective on his everyday memory, everyday cognition, improving, not improving, improving steadily and relapsing. So that is how we need to really work on intervention, which has to be diet, exercise, behavioral therapy, app-based therapy, and then that could be outcome. And I'm sure with the mind-body medicine, we have a lot of good self-efficacy skills. So how angry you are, how irritated you feel. So I feel for cognition, there are so many scales, but they're underutilized. So what is patient perspective about his everyday attention, everyday memory, and then we can still revise, replan, re-execute the intervention plan in a stages.
The key message here is giving a tailor-made solution to the patient, because we are too much accustomed to telling every patient to do crossword puzzles and memorize chanting, which is not going to work in every this thing. So with this, we come to the end of this session. Thanks to Dr. Sonal, Dr. Shripad, and Dr. Vadhva. It was a very enlightening session, although these topics seem to be somewhat remotely interconnected. But from my personal perspective, I think the key points are to detect early, to give the latest interventions, and to seek multidisciplinary and specialist help wherever it is required. And whatever you do, keep the patient in the loop by educating the patient, encouraging the patient, and giving the patient the baseline that yes, you can expect better quality of life and recovery from whatever problem you're having. Thank you. And with this, I hand over the proceedings to the organizers. Thank you.
Thank you so much.
Thank you so much.
Thank you. Thank you very much.
Thank you very much to all the speakers as well as Dr. Vani for this wonderful discussion. We will now have a break for about up to 1 o'clock, and we will join back here through the same link at 1 o'clock sharp. Thank you very much. Good afternoon, everyone. And after the break, welcome back to our third session in Hall B, a topic very close to my heart, that is nutrition in non-communicable diseases, a holistic approach towards this idea. The moderator for our session today is Dr. Geeta Dharmatti, madam. Could I have her introduction slide, please? Dr. Geeta Dharmatti is the director and founder of Geeta NutriHeal Nutrition Consultancy. She is the chief nutrigenomic counselor at Gene Support. She happens to be the PhD guide in nutrition at Tiyak Maharashtra Vidyapeeth. She is the executive member of the Indian Dietetic Association and the chief bariatric nutritionist at Diabetic Obesity Surgical Solutions. Her areas of expertise involve critical care, bariatric, nutrigenomics, wellness, and diet management. Dr. Geeta, over to you today.
Thank you, Dr. Deshmukh. It's wonderful to be here as a part of Synapse team. Congratulations to the whole Synapse and Sphere team to get all these alternative medicine therapies together and look at a very integral part of application with mind, body, and connect to each other. And definitely, as you said, nutrition, the session cannot be complete without nutrition. And I am so humbled and privileged to be a part as a moderating this session. So to start this session, we have initial 20 minutes talk by our senior most dietitian and nutritionist in our fraternity, Dr. Dharini Krishnan. Can I have a CV slide, please? Yeah. It's immense pleasure, and I'm humbled again to be introducing Dr. Dharini Krishnan. She's dietitian and nutritionist. She's PhD from University of Madras. She has a vast experience in various hospitals as consultant dietitian and also been in academia as an assistant professor at Institute of Hotel Management. There are many, many awards and recognitions to her credit, but to name them few, she has Amio Bose Award of IDA, which is Indian Dietetic Association. She was also a former national president of IDA. She was former chairperson of RD board, which is registration board in IDA. She has professional memberships and also she has contributed to a lot of papers, researchers. She has a very active social handles and she does a lot of Instas and Facebooks to keep her patients, audience updated about current dietary practices. She's going to speak on very interesting approach because she has a great depth of knowledge on integrated nutrition. And that is why I think we look forward to hear from her about food versus nutrition. Because we all know food is connect, happiness, social, food is celebration, food is somewhere very close to each one of us' heart. So we look forward, ma'am, to hear from you from this topic, that how differently does this food and nutrition impact on our mind. So over to you, Dr. Dharini, ma'am.
Thank you so much, Geeta, and thank you, Synapse team, for giving me this opportunity. It is indeed a great pleasure to be in this conference, which is so close to my heart, where food is part of the mind. Just bear with me while I share my slides. Just give me a second, please. I hope you can see my slide.
Yes, ma'am.
Yes, we can see it.
Okay. So the topic given to me is, as you see, food and versus nutrition. How differently does it impact our mind? So here we are going to run through the modern a little bit, and then we go on to integration. That is how my talk is going to go today. So what is food in itself? It is basically what we eat, drink, eat, and what energy we get from it to stay alive. But what is nutrition itself? It is part of the food that is used by our cells and metabolized by the body to make all the contributions that our body needs. Not all the nutrients are required to come from food. So we'll learn about this as we go further. So how does food affect the brain cells? An unhealthy diet, which is rich in fats and sugar, which is what most of our people today, mainly the youngsters who eat, which can lead to inflammation in the neurons, and it can lead to lot of brain disorders. One could be depression. So when we have artificial sweeteners or sugar or trans fats, what does it do? it creates insomnia, anxiety, irritability, and the neurons are really in trouble. So food we eat, how does it affect the brain? It basically, if we have a healthy diet, which has good protein, fruits and vegetables, lot of natural vitamins, minerals, phytates, it actually helps neurogenesis, which is formation of neurons, and which also increases the synaptic plasticity, which is basically the connections between the neurons, which helps it become stronger over time. The more the connections, the better we are able to communicate, and we can learn, think, and our memory is much better. There is something called the BDNF, the brain-derived neurotropic factor, a protein that enhances growth and survival of neurons. And how does this happen? Basically, a healthy diet is what increases the BDNF. And the increased neurogenesis in the hippocampus can improve our learning, memory, mood, attention, and mental health. We are in this phase where even a child talks about having not a great mood for the day. So it directly what we eat impacts our mood and our cognitive powers. So what does an unhealthy diet do? It actually, it's kind of a stress hormone which activates the brain's microglia and astrocytes, and this creates inflammation, which can create depression and other problems. Sodas have a lot of sugar, even diet sodas, which contain artificial sweeteners, are not good for the brain. Because a lot of people, even young children, are moving towards artificial sweeteners, thinking that will help them maintain their weight or remove the extra weight that they have taken. But this can lead to irritability, anxiousness, and even sleep disturbances. So does that mean that one size fits all? Does the food we eat digest the same for every one of us? Even in a family, even in twins, it's very different. How do we explain this? This we can explain through the prakriti of our body, which affects the food, nutrition, and our mind. Ayurveda prescribes that food or ahara is beneficial for you, which is called as patyam, because the food that each person needs to take is individualistic. Geeta is a genetic counselor and introduced a lot of us to that field initially. And we know today that genomics, where Ayurveda and genetics are falling together. When the prakriti analysis of a person is done, it is much easier to get your genetic typing, because when you take your genetic typing individually, it's very difficult to understand it. So food nourishes body and mind. And if people without focusing and concentrating and enjoying the food does not get assimilated, you need to enjoy the food. Pleasure is very, very important. If you are not concentrating on your food, the body goes through the flight and fight mode, and it literally does not assimilate your food. The olden way people used to do is chant the Vedas while they ate food, which gave you the right environment, the right vibrations. You need just 20 minutes to yourself while eating, no social media, no smartphones in front of you, no multitasking windows. I always tell my brother, why did you even be part of creating the windows? Because the desk operating system allowed us to do only one thing at a time. And that's what we need to do when we eat. So what does Bhagavad Gita tell us? The properties of food is related to the guna of the mind, or the type of the mind. So relationship between the sattva, rajas, and tamas, and the nature of food that you take to what your mind behaves. So freshly prepared food, you can meditate, concentrate, create, and imagine things. Rajasic nature, spicy food, excess salt, excess sour, hot and thermal properties alone not, also spicy, So creating hot through spices creates anger, anxiety, emotions, too much of energy, which you do not know what to do. Like, how do you manage a toddler? The energy is so much, you don't know how to handle it. Tamas, food cooked more than 3 hours away, and yesterday's food, rotten smelling food. It affects your sleep. It affects the part of mind which gets you sluggish. So, moving on to the Upanishad, the Chandogya Upanishad quotes, food when eaten becomes threefold. The coarsest portion becomes the feces, the middle portion the flesh, and the subtlest is the mind. So, just like when we churn the curd, which most of us don't even know today, you have to prepare curd, cream off the extra cream, and you make the butter. So that butter is how the subtle level, how the butter rises when you churn the curd, is how the mind will be if you have a sattvic food. Preeti food is a particular nature of sattvic food that's satisfied nutritionally, and therefore the mind is also calm and composed. Sattva food that increases the quality of sattva within you, and the food promotes virtue, both in the sense of strength and sense of goodness. It lightens and promotes a healthy body and mind. Food is actually spiritual in its effect. Then we go on to breathing. If you do deep breathing before a meal, you can digest your food better because you're calm. Diaphragm breathing is a very good way to manage stress, which improves your gut health. Getting quality sleep, limiting caffeine, and practicing yoga can help in digestion. Lot of our patients are always complaining. We get gas, ma'am. We can't eat dal. We have acidity. We can't eat this food. We are not able to eat. And as soon as I eat, I feel full and I feel very uncomfortable. So they have a whole list of foods they cannot eat. So you actually can help. Different asanas can help you get over the problems that you have, whether it's flatulence or whether it is indigestion or acidity. Yoga can help in a very big way. Now let's go to the Quran, which says, no human being has ever filled a container worse than his own stomach. The son of Adam needs no more than a few morsels of food to keep up his strength. Doing so, he should consider that a third of his stomach is for food, a third for drink, and a third for breathing. And similarly, Ayurveda says a third should be a gap, a third should be water, and a third only should be food. So everything talks about similar things, but we tend to not follow it. What does the Bible say? Listen to me and eat what is good, and you will delight in the richest of fare. But do we really do this? What are we eating? Smoothies, fruit and milk put together, which is viruddha ahara, which means these two taken together is actually creating toxins inside the body. Cream of tomato soup is sour and milk put together, which is not the best of combinations. Some people who have good digestion can handle it, but people whose Agni, which is called as the digestive power, if it is low, it can lead to migraine, sadness, upset, anger if you take food, which is viruddha ahara, that is foods which should not be taken together. Undigested food can create havoc in the body and mind, and hence we need to watch out. There is a whole list. I've just given you 2 examples, which are one of the commonest examples. And if you keep taking smoothies, specifically with berries, it actually raises your sugar. Now, what is the role of Ayurveda, dietetics, and integrative health care? Because no single system of medicine claims optimum solution for healthcare needs. Health-seeking behavior studies reveal 40 to 70% of the global population exercise pluralistic choices. I was totally surprised. Recently, I was in the US for the postpartum period of my daughter's delivery, and I saw so much of Ayurveda is being practiced there. They even have postpartum massages being organized at home. They take so many spices, whereas we do not seem to be realizing how important it is. India seems to be going backstep on these things. We need to work forward for integration. So the trend suggests that integrative healthcare combining systemic and molecular approaches could be the emerging future of healthcare. What are the key dimensions? Food as a source of health for physiological and mental balance. See, they talk about both. That is very important. Food as a cause of disease, so you need to avoid like Viruddha Ahara, and food is medicine, which will help you get better. So what is the primary focus here? Seamless care, coordinated care for patients and their families. India is so unique that we already have home remedies in place. In fact, every other home was using the home remedy on this 40-day-old baby, which is so good for digestion and preventing cold, cough, and fever. If you're able to match into our systems of dietetics and provide a solution which is unique for a specific person and problem, which also nutrigenomics is talking about, and combining Ayurgenomics, we are going to be the kings of the world. What are the advantages? Higher quality of care, better health outcomes of patients, and optimum health by integrating two systems of medicine. We have enough, Mark Heyman was invited last year to India, and he follows functional medicine. And what do you think the roots are? It is basically this thing of following Ayurvedic medicine. Akhil Palanisamy, he's an MD in modern allopathy medicine. And he has come out with the Paleo-Vedic diet, where he's talking about Ayurveda. So we need to learn that Harvard-trained physician is writing about Paleo-Vedic diet, where he learned Ayurveda, and it re-energizes, restructures, reframes your perspective. So what do? They use Paleo-Vedic diet, which has integrated care. Traditional diets are important. Your genetic type decides whether you're susceptible to NCDs. Initially, we all dietitians used to say ghee is bad, cow's milk is bad, coconut oil is bad, move to sunflower or new age oils. People started reducing even the tadka that they were doing. But what is the new age science saying? Ghee is good, coconut oil is good, do not use processed oils, go to cold press oils and so on. And what does the keto diet say? Drink oils, because the amount of fat that they ask you to eat, you cannot take it. And that can be done only for short time. You can write a PhD on idli, which is one of the traditional foods of south of India, which is kind of world over people know about it. But rice and black gram, the lacunae of one and the other is made up for, and we have a complete protein. So let's talk about vada. Nutritive value of vada, I'm looking at a very medium-sized vada, not a very big one. And you see in front of you the calories, protein, and fat. If I make a curd vada out of it, you add the curd nutritive value to that. And if you have a rasa vada, you add the rasa nutritive value. This is how we look at it in modern nutrition. But what happens in Ayurveda? The plain vada is very difficult to digest. If your Agni is not good, it can actually create a lot of problem and mind issues in your body. Curd vada is even more difficult because curd is difficult and so is vada, and similar dishes is your dahi bala char, which actually can affect your mind if it's not assimilated properly. Rasa vada, because of the spices, the tamarind actually helps in digestion of the urad dal, and it's a better way to help in digestion and helps, once your food is digested properly, your mind is going to be calm. Dal in modern nutrition, different types of dal. We have calories, carbohydrates, proteins, and fat, which are very similar. But how does Ayurveda look at it? That urad dal is difficult to digest and moong dal is easier to digest. So if you have digestive issues, start with moong dal. In fact, after delivery, we start with moong dal and then only proceed to other types of dals. We use a lot of spices to help the digestive system come back. But all this is not practiced or used by dietitians in our country. So digestion is the key. It is the Agni, or your ability to digest food, which creates what you are. If you digest the food properly, remove the waste and toxins from your body, you assimilate your food properly by eating according to your body systems and digestive power, mental health, mind functions will be at your best. But if you do not look into it and you eat anything and everything at any time, whether you are hungry, whether you're not hungry, whether it suits you, whether it doesn't suit you, then the food is not going to help you. It is not going to be assimilated. It is only going to be in the diet chart where you actually calculate the nutrients. If you want assimilation, you have to work towards getting the right type of food for yourself, which will help the food versus nutrition for your mind, which will help you be what you are. Thank you very much for the opportunity. I'm happy to hand over the session back to you.
Thank you, Dr. Dharini Krishnan, ma'am. It was really wonderful to understand the integration of two sciences. And I can conclude, and I'm waiting for the questions from the audience, and we will definitely take up a few questions from the audience. I request the audience to put their questions in the chat box so we can have the expert opinion of Dr. Dharini Krishnan on that particular aspect which you are looking for. But what I could look at is the Chandogya Upanishad, the butter example, which you so beautifully said, and the 1/3 portion of the area where we need to look at food, water, and the air in our stomach very much connects with our own modern physiology, also functional medicine. I think it's time the dietitians start integrating these two, but we need to have evidence. We need to put it as a base for putting molecular nutrition, genomic nutrition, or we could call it as an integrated nutrition in front of the world with some kind of evidence. And I think the dietetics is a very dynamic, changing field now where we have so much new things to talk about. I'm still waiting for the questions. We don't have any questions as yet, but I would ask you a few questions, ma'am. If, as a senior dietitian, with a very less knowledge of Ayurvedic dietetics, and most of the times we do not really have affirmation, or we don't really work on Ayurvedic practices. Very beautiful example of Vada you gave, where for me it's a protein meal. For me, it gives me satiety. It delays gastric emptying. And if somebody says, "Can I eat dahi vada? Can I eat rasam vada?" I said, "Go for it. Work on the calories. Keep the portions controlled." So we work on portions. We don't think about digestibility. We don't think of assimilation. Now going ahead as an integrated approach towards nutrition, if you have to look at NCD, non-communicable diseases, where you have diabetic, obesity, a metabolic syndrome patient, what will be your advice and how you would handle these kind of approaches in your counseling or in your advices?
Correct. See, basically, we cannot learn Ayurveda, and Ayurvedic people cannot learn modern nutrition. So we work together with the practitioner. And first, what we do is we give them a Prakriti analysis. If it's online, we give them, a questionnaire through which we learn the Prakriti. Otherwise, the Ayurvedic practitioner will assess and tell us. And then we work together to come out with the diet chart, which will help their diabetes. For example, in diabetes, they have many more classifications than what we have. So we need to work together to move through. And let me tell you that Ayurveda also is coming out with clinical research. It is not that it is just, the Ved talking about it anymore. they are coming out with very specific research, which is what I put out about the yoga, and I put out about other things where research is coming out. So I think everybody is waking up, and I think the strengths of nutrigenomics, Ayurgenomics, and modern nutrition together, if we work, we, I think, are going to be the king of the world.
Fantastic. So I think here we are with integrated approach and looking forward for a lot of areas, especially in food and nutrition, when food connects with us so much emotionally. And we look at appetite and satiety challenges most of the times while handling food. We don't look at nutrition, we don't look at calories. It's more of appetite and satiety. What you say more sense that we need to integrate all these concepts and work going forward towards this if we really have to look at mind-body nutrition aspect of adherence. Thank you very much, Dr. Dharani ma'am. We do not have any questions from the audience. So I'm actually from the team Synapse, I'm humbled and I'm actually very thankful for you to give time. I understand you have challenges at your place with a small kid at your place. Still, you have taken time to come up and talk about this wonderful topic to us because we couldn't think anybody else telling us about integrated nutrition to us. Thank you very much.
Thank you so much for the opportunity. It was a great pleasure to be. Bye-bye.
Bye-bye. Thank you. So we move on to the second session, friends, and we now have a panel discussion. A panel discussion talking about an integrated approach, what we've heard from Dr. Dharani. I think it's a long way to apply Ayurvedic science still, the constitution assessment and then coming to the application. But let us understand from the experts. We have three wonderful panelists, and we will talk about the approaches towards case studies in this session now. I would like to invite the first panelist, Dr. Shilpa Joshi. She's a very dear friend of mine, and she is a consultant dietitian. Her name is very familiar on a lot of forums and nutrition talks in the conferences. And she is a very, very famous dietitian practicing in Mumbai. Her area of expertise are diabetes. She's been vice president in Indian Dietetic Association 2019 to 2021. She's also a honorary secretary of All India Association of Advancing Research in Obesity, the ARROW. She's a master trainer in diabetes conversation maps. She has presented a lot of national and international papers, and she is a recipient of International Assay Award in 2017 on malnutrition. And recently in 2019, she's been awarded with 3 awards by Foxy. Welcome, Shilpa Joshi, into the panel discussion.
Thank you, Gita. Thank you so much.
Can I have a second panelist slide, please? She is Shaini Chandran. She is registered dietitian. She's from Chennai. Shaini is a very accomplished sports nutritionist and wellness and lifestyle expert. She has a lot of inputs to give on preventive healthcare and wellness too. She is also level 2 gynanthropometrist. She's also a professor, author, speaker, consultant, and very active social media personality where she has a good active followers on her Insta and Facebook. So we'll have a lot of inputs coming from her on this wellness aspect in case discussion. Can we have the third panelist? She's Dr. Supriya Bhalerao, and she is MD, PhD, Ayurveda. So she's PG Diploma in Bioethics. She's working as Head Obesity Diabetes Research Lab, Interactive Research School of Health Affairs, Bharatiya Vidyapeeth, Pune. She has major research areas with herbal drugs, nutraceuticals, behavior treatments on adipocyte biology, adipose dysfunction, and microbiome from various anatomical sites. She's been completing a lot of research projects funded by Ayush, Ministry of Ayush. I think after Dr. Dharani's session, there will be a lot of inputs from her. And I would like audience, as we go ahead, can we stop the screen sharing, please? I request all the 3 panelists to be live. Yeah, thank you very much, Shaini, Shilpa Joshi, and Priya Bhalerao. And I would be now talking about a case discussion. As we talk about the case discussion, I want the audience, as we go ahead with every case, to talk about, to ask what they feel. They can comment or ask on what their approach is, what they have, because these are all day-to-day. There's no presentation. These are day-to-day cases where we are trying to understand the impact of mind, body, molecular health, Ayurveda, dietetics, and number of areas. So we'll pick up the first case and we'll talk about it as we go ahead. And I also, again, ask the audience or the delegates to write what they feel, the comment and the questions. So let us take the first case study, friends. It's 18-year-old male case study, an adolescent obesity. We can see the weight, we can see the BMI. It's a morbid obesity almost, but the height is very good, 180 centimeter. Fat percentage, now normal fat percentage, we all know for males is less than 20%. And you can see the fat percent of this young boy as 45.5%. So we can see the body composition of muscle fat, where fat is more than muscles. Though the BMI is 34.5, but we can look at the fat percent and say the nature of obesity has more fat in his weight. And there are definitely at this age, we know the challenges of lifestyle, physical activity, increased food focused. And for a dietitian, always it's a screening process, which we say A, B, C, D, E. And E I've just added because E also is important, exercise or environment. And A, we've understood that he's overweight, almost morbid obesity with a higher fat percent, but the recent weight gain history is almost 20 kgs. And that is because typical calorie surplus, eating too much of food, too much calories. The recent investigations show little fasting 110. You know, the D3 values are very low. B12 is marginally low. Cholesterol, triglyceride, also dyslipidemic in nature. Clinically, a lot of lethargy, fatigue, irritation, don't want to work out, do not want to follow a discipline of lifestyle adherence, and plus a lot of acidity, bloating too. So the patient or the boy is, we can't call him patient, the boy is vegetarian. He has a lot of calorie surplus intake. He's into a lot of volume eating. I mean, if I ask in terms of pav bhaji, he will say 6 pavs minimum, and then he'll say he'll eat a pulao. Then also he'll say he'll eat gulab jamun 3 to 4. This is his appetite. And this appetite, he says, I can do it for anything. I asked for biryani. Biryani, he said, I can eat a full bowl of biryani when you order it from outside. That's almost 400 to 600 grams of biryani. So that is the amount of volume eating. A whole packet of biscuit he can finish. The satiety, appetite connection is very poor in him, and hence adherence to any lifestyle or any dietary regime is very, very difficult, and constantly food focused. After a meal, he will think about what is the next meal. So that process of mind, which is continuously looking at food as a best friend, happiness, comfort is always there. Very poor lifestyle, circadian rhythm, no exercise. I'm sure most of the delegates here feel post-COVID, this is a very common scenario which all of us are facing. So now we look at the application of what can we do in these kind of scenario. So my first question will be to Shilpa Joshi, and I would like you to tell us, Dr. Shilpa Joshi, that if such kind of an obesity scenario with typical lifestyle pre-diabetics comes to you, as a dietitian, as an expert, how would you be handling the assessment and the conclusion? How would you handle this kind of a patient? Over to you.
So thank you so much, Geeta, and thank you, Team Synapse, for having me here. So now, if you actually technically look at assessment in terms of, what is conventionally taught to us, or, how we are trained, we would actually look at anthropometry. If we have all of that. We look at body fat percentage, we look at biochemistry. But I think a very important part in assessment, which we all do not consider, or probably a lot of us do, but we are not traditionally trained for it, is psychology. And I believe a lot in it because, see, if you look at the age of this boy, he's 18. He's probably writing an IIT entrance or NEET or maybe some other kind of entrance. And a lot of this can be comfort eating. So look at it as, the trajectory of weight gain. Not that he was very much lighter 1 year back, but the way he gained weight, 20 kilograms in a year, is a lot of weight gain. And I think that can have a lot of reasons besides, that he is a big eater. Lot of times we find that people eat because eating is comforting, because eating, is sort of quietens the psychological process. So if he's stressed, if he has one exam after the other on every other day, probably that helps. And then, of course, if you're talking about assessment, then food assessment becomes a very big part. And in food assessment, because he's a vegetarian, probably the diet, that's what we presume, that vegetarians in India, even non-vegetarians in India, eat very little protein. So we talk about protein as an indicator to give satiety. And if protein is missing, we look at if there is enough protein in his diet, enough fiber in his diet in terms of assessment, and micronutrient assessment. Although we have it for B12 and D3, I'm sure with the amount of junk food intake that the person has, probably other vitamins which we do not assess for are low as well. We have already spoken about no exercise, but we really need to talk about forget the exercise. What about NEAT? What about non-energy and non-exercise activities? What about opening a door when bell rings? What about answering phone while walking? Simple things. Whether these are being followed in, his day-to-day life. So I think as far as assessment goes, I think what is the most important thing beyond nutritional, anthropometric, biochemistry, other things is psychology, which probably is the missing link as to what is the trajectory of weight gain. Is it associated with something which is leading to comfort eating? Thank you.
Interesting. So I pick a few points from you where you said, yes, in this scenario, micronutrient deficiency is very important to assess. And definitely we can see D3 coming. So simple micronutrient, because many a times micronutrient deficiencies will lead to a lot of challenges with adherence and sustenance of discipline on lifestyle one. And to protein intake, you can always ask this patient to start with proteins. You can always say, okay, whatever, like pav bhaji example I gave, you can always ask the patient that you first have some kind of a lentil, sprout, and then you eat a pav bhaji. So somewhere adherence can come with applications of micronutrient supplementation, protein first in his meal pattern you start. And definitely I think syncing with your thoughts that psychological assessment. But many a times in our country, it is very difficult for the patient to talk about psychology assessment as a separate issue. I think we need to come out with a tool in dietetics where we look at psychological evaluation.
I'm
Any
sorry
inputs
to
you
cut
want
you,
to give
Geeta,
about it? Yeah.
Just one thing. We do not speak about it, but more often than not, we see that there is a gut-brain link, and hunger and the way we think is linked far too closely. So there are comfort eaters and there are comfort not eaters. So you find people not eating and losing weight or eating way too much. So I think that is something that we need, because that's the time when you crave for pav bhaji and cake and whatever comes.
So would you refer this patient to a psychologist, or you would handle it as a nutritionist?
I mean,
Because
I
again,
would try to do as much, but I am not a psychologist. So it would be great. But like you would agree, most of the psychological consultations are addressed with a lot of stigmatization in our country. So moment you go to psychologist means there is something wrong with you. So I think a lot of times, if they can do it, it would be great. But if they cannot, we need to, I think as dietitians, we need to start looking at psychology as a very important tool for adherence of any dietary regime. So, we follow a diet and then we see a pani puri wala and there it goes down the drain within a second. So I think that's something that we need to talk.
So yes, I agree with you. And let's see how the process unfolds as we finish this case. The next question I thought Shaini Chandran can take up, because she is very much into exercise, kinesiology, and a lot of wellness and preventive. Shaini, with this reference to the case, I would like you to talk about that if such kind of case comes to you, and with such a vast experience of exercise and mind, body, and prevention, how would you initiate the exercise process? How would you agree with the area of adherence and sustenance? Because what we look now is whatever we tell him, he should be able to work on it. There should be adherence. So in your case, how would you look at what are the tools which you will use for this person to get more into a disciplining of his lifestyle to lose weight?
Yeah.
Over to you, Shaini.
Thank you, Dr. Geeta Dharmati, for the kind introduction, and the entire Synapse team for having us here. It's really good to see Shilpa Joshi here, and of course, happy to be, on this platform with all of you experts. Okay, so the main thing is when you say the term exercise, a lot of people see it differently. Some might see it as something fun, where there's a lot of interaction with the other players and then that entire energy coming in. But then there are times that while in school, if you've been punished, it could be go and do like 10 or 20 rounds around the school ground. Haven't you heard this? So people associate. I didn't know this until a very long time. There are a lot of people who have a negative connotation to exercise because as children, they were reprimanded and they were made to run in the hot sun. And for them, the association is very negative. So the moment you say exercise, they're like, no, I don't want to do it. And that's where the challenge comes. Another factor is, I agree totally with Shilpa. Psychology is something which is very important. I still remember there was a 21-year-old morbidly obese boy who had come. He was around 140 kgs from a Marwari community. I'm based in Chennai. So this boy did come and then he was very upset the moment I had mentioned, like somewhere during the end of the counseling session, at the end of 1 hour, I said, it'll be great if you could consider meeting a psychologist. And then when he came back after 15 days for a follow-up, he said, ma'am, I was very upset. How could you ask me to meet a psychologist? I don't have any mental issues. So that's one thing. Then I did tell him, like, I've been practicing for this many years. And then we have noticed that the mind aspect is very important. Then later, slowly what changed is I started using the term mental coach, life coach. They were a lot more comfortable when that kind of a name was given to a counselor, and they were more receptive about when, what, who, is there any medicine that is involved in the process. That's another aspect. So mindset and psychology, of course, I have different psychologists, different age groups. So there are people who come to my clinic. They are a lot more easier when they come to my place, and then I would have on-call consultants coming over, or sometimes they just take up online consultation, because for them to go to a place, it's a lot of inhibitions. So it works this way. So I have a psychologist who's 30-year-old. There's someone who's in the age group of 55. There's another person somewhere in between. And there's someone who's 60 plus. And there are working counselors too. So it all depends on that person's age group and how they will connect. Next, another most important thing is sleep. More than exercise, right now, what I would do with this child, this boy, would be 18-year-old, right? So they're all glued to all their OTT channels and they keep watching. And after one episode is over, the screen takes you to the next episode, right? It automatically goes. And then you're like, chalo, let me sit and watch another episode. So this just goes on and on. So we really have to see when they go to bed, because only when they go to bed, they have better energy for exercise even. Another thing is to understand what is the socioeconomic strata, because if they have a lot of servants or staff at their disposal, then he might not even be lifting their finger, or to even get some water, or even take a remote, to switch on the TV and all that. They might not just budge. And then hours and hours of watching television or else being in front of the laptop could be another reason. So to understand how is the mindset, and I'm sure there will someone who will accompany this boy. So it will be a lot more easier to understand how much of activity he's given at home. So are they pampering? Because recently we had someone of this profile. I know a client who was there in Bangalore. So there was this mother who was, when we had the mother, father and the boy in, the client together, the mother was trying to give some tasks, but then she was still complaining. But then the father immediately jumped in and say, no, he's doing it. Do you understand how it works? It's like, so if, at home, if there is so much of differences right there between the father and mother, if one is going to be very, very supportive and then really going to pamper them, this is just not good. The first thing will be to do household chores, making sure that they open the door, fetch water, fill up the water bottles, keep it in the different rooms, and then climb downstairs. Say, for instance, they're on the 4th floor of an apartment, making sure that they're given certain things so that they can go and give it to their neighbor, but not to use the elevator. So those kind of small tasks. And then also the step count. So if they can use a watch or something, it'll be much easier to track using a pedometer. Another factor is also to tie it with something big. For example, if there is a sports day that's coming up, or else an annual day that's coming up, and then this child is quite excited about looking smart on that day, or if there is some gathering in the school, and at this age they'll be quite so much into having a girlfriend, or they will have a crush or something. So then as we speak, if we understand that and say, hey, listen, you want to get ready for this function that's coming up in your school, then let's work towards it. And then they get very excited. So we'll have to really work on their mindset for that age group, what works. So there are times that I've spoken about their favorite televisions, whatever they're watching in OTT, we ask them, like, what do you watch? How many episodes have you watched? I found that character very interesting. What is your favorite? So the establishing that connect with that person becomes so important. Another factor is, what do they enjoy? Sometimes it might not be the gym. Walking might be extremely boring. So they might be happily playing a sport, or else go swimming, or else go for dance class. So we just have to figure out what ticks for that age group, because they are teenagers. And one more important aspect is also there have been children who have been subjected to some kind of abuse, sexual abuse. These things have again come up. Recently, I worked with a client for 10 years, and then recently she said, "You're the third person in my life to know that when I was less than 5 years old, something happened to me, and then I didn't have the courage to go and address, but then you asked me to go and speak to a therapist, and then I told her, and then I've been working on it and took around 250 hours of counseling over a period of several years. And then that person came and told me that this happened." So whenever there is an issue like this, which is really deep, and it's not easy to go and visit that place, and this can actually come in the way of any kind of intervention. Yeah.
Interesting. So I think you did endorse the psychology part of it and named it differently, saying we need to term them as health coach or some mind coach so that it's more easy and more approachable. I absolutely agree. More of motivation to mobilize. So the follow-ups, connect with them. This age doesn't need a diet chart. This doesn't need do's and don'ts. This doesn't need typical time and eat this much at this time. It won't work. It works. The connect and the adherence works with sleep, the mobilization, the activity. And lastly, I take it from you as the family involvement. I think it's very important that we all go together. When we see a patient, we want the family to be with them so that the whole family changes. And we know that one obesity can have that kind of a family there. So very well taken, Rashini. And your examples of how you handle also has been very beautifully explained. I also again ask the delegates to ask any questions on this case if you wish to ask the experts. So it will help us to have more of interaction from the audience point of view. So now we take up Dr. Supriya's inputs here because she is an expert in integrative. And this session, we're looking at a holistic approach. So if, like we had an earlier speaker, Dr. Dharini, telling us that you should look at the constitution and then you assess the patient and then give the interpretation. So Dr. Supriya, with your vast experience in alternative medicine or Ayurveda medicine, how would you handle? The patient did also complain about some gastric issues, bloating and irritation. So any expert inputs from you, we look forward for that. Over to you.
Yeah. Thank you, Dr. Geeta, and thank you, Synapse team, especially Vaishali madam, not only for inviting me here, but for thinking of including Ayurveda into the dietetics section. So thank you very much for that. And Dharini madam has already done my job very easy. So it will be easy for me to give answers to few of the questions which we will be discussing in this session. And my previous panelists have already discussed the role of psychology and exercise also to some extent. So I will restrict myself to dietary aspects. And there are some basic concepts of Ayurveda which we follow in every case. And there are only 3 principles which I will highlight. That is Hita Bhuk, Mita Bhuk and Kali Bhuk. So Hita Bhuk is you should have a quality food. Mita Bhuk is you should have a limited amount of food. And Kali Bhuk is like you should have a timely food. So I will first highlight the importance of Kali Bhuk or how I will deal with this patient in terms of Kali Bhuk. So the first thing is he should have a dinner early as possible, maybe before 8 p.m. or by 8 p.m. And second thing is, though he is having habit of snacking and munching too much, I would still suggest and I will advise him not to have anything between 3 hours. There should be a difference of at least 3 hours between 2 things which he will have. So that is also a famous Ayurvedic quote like Yamu Muddhena Bhuktavyam. That means within 3 hours one should not eat anything. And then I will come to the Mita Bhuk, that is limited amount of the food which a patient should consume. So in this case, it is very difficult because the boy is in his adolescence, so he may not like this kind of advices also. But what we can do in this case, like we can explain him the principle which Dharini madam has said, that solid half part, liquid 1/4 part, and the 1/4 part should be kept empty. So whenever he will have food there, he should keep some part empty for the proper digestion, and that will solve many of the digestion complaints also which he is having. And last thing is Hita Bhuk, that is what should the person eat or what is a quality food. So here the Ayurvedic principles of dietetics differ little from the modern dietetics. And though I will also advise protein to this person, in the form of mook, because as Tarini madam has shown that different proteins or different dals have different properties. So mook is the best protein according to Ayurveda for vegetarians, and that is what I would advise this person, mook soup, mook chilla in this form. But definitely not raw sprouts, because Ayurveda never recommends raw sprouts. It should be boiled and cooked, because then the Agni component works better if the food is already cooked and boiled. So no to raw and boiled sprouts, but mook in form of chilla soup, that is something which I will recommend. Another two important things which from Ayurvedic perspective are important, which will take care of his gastric complaints also. And the first thing is that he should avoid the Viruddha Ahar, which Dharini madam referred in her lecture. So the Viruddha Ahar is incompatible food, and we consume many such combinations throughout day, knowingly or unknowingly. So milk with salt, so milk with chapatis, milk with biscuits, milk with khari, and milkshake. This is also something which is consumed very frequently. So these things should be avoided. Smoothie is another example that should be avoided. And another thing which is very common in this age group is frozen food, chilled water. So these things, like he should take as much as possible freshly cooked food, and no to frozen food and ready to cook food and chilled water. So I think this will be the Ayurveda approach to look into this case, and that will solve his gastric issues. Also, there is nothing separately to be done for the gastric complaints, because if he follows this, half of his complaints will get relieved immediately. And last thing which we have not discussed is sleep pattern, because he is having irregular sleep pattern also. So I would work on that aspects also, to highlight the importance of circadian rhythm to him and try to explain him like how important it is. So that is something which I would like to advise the patient.
So fantastic. I think if I need to summarize with these three inputs, an integrative approach, which we are looking at in this case study, and I think we have just 10 minutes to go and I have another case to discuss. So very quick understanding is, I think portions are very important. Circadian rhythm is very important, time discipline. Looking at tools in nutrition, like Dr. Shilpa had already mentioned, that some motivation, some WhatsApp, some neat steps counting, all that is important. A mental health coach, if needed, is important. But at the same time, looking at food which is easily digestible and accessible, like Dr. Supriya said, that the moong, we do say protein, but why not we pick up a protein which is easily digestible and assimilable? Milk, now we at this current dietetic practice also, milk, casein and lactose, we are finding it difficult. We are shifting to A2 milk. There's a lot of controversy. So according to Ayurveda, it was already Viruddha Ahar, but now I think the current practices also tell us that the gluten, the casein. So we are definitely working on molecular pathways to understand that how personalized the nutrition can become. And I think it's the way forward. So thank you very much. I think this is the integrative approach. I'm just looking at any questions. Dr. Shilpa is already writing the tools which she's using, and I think that will be appearing on the chat for everyone to see. So we move on to the case 2. And since we have only 10, 12 minutes of the time now which we have with us, we'll try to pick a quick recap of the case, and then we move on to the discussion. So the second case is a pre-diabetic case and a metabolic syndrome case. It's an adult case. So definitely the weight is 81.4 with a pre-obese BMI. And if you look at the fat percentage, again, that's a major challenge. More body composition has more of fat. And again, a recent weight gain of 10 kgs. The pathological values give us this typical metabolic syndrome with also hyperuricemia. There are energy issues, poor adherence, and a lot of gastric issues too. We can look at his dietary habits. There's drinking, there's socializing, there's non-vegetarian, there's a sweet tooth, there's a craving towards sweet, and definitely poor energy expenditures. But yes, he makes an effort to work for 5,000 steps daily, and very poor sleep pattern. I think the 2 days conference has spoken a lot about sleep. And sleep for us also becomes a challenge when we start looking at the patient's overall counseling. So I'll start from you, Dr. Supriya, here, that as you've already mentioned, I mean, we take it from you, what you've spoken for the previous case. Here, the patient is more matured. The adherence level can be better. He's cared for his health. He may be able to work better on his health. So with such kind of adherence and the self-drivenness for this patient, he wants to work on his health. So how would you look at this patient's metabolic health?
Yeah. So as you rightly said, this is a more mature patient, and according to Ayurveda, this is a middle-aged person, which is typically age of pitta, and he is having complaints of also pitta, like he is having loose motions, diarrhea, and what he is consuming, the diet is also pitta aggravating. So it is the case of pitta according to Ayurveda, and we will try to have a dietary advice which will alleviate or pacify the pitta dosha. So that is the first thing which we will be doing. And in this case, what I can see is many of his habits are because of his work. And then it is very difficult to tell him to change them abruptly. Like suddenly change in the diet may not be possible, but we can give him simple tips like what he can do and how he can change his habits. So, for example, he is having alcohol twice a week. So we can at least suggest him that alcohol should not be taken when he is completely hungry or something like that. And there should not be any what we call as snacks, chakna kind of, not to have that groundnuts and all with the alcohol when he will be having that. He is having sweet tooth. That is what has been mentioned in the case. So in this case, I would suggest like he should go for something like moong laddu or kind of black raisins or something which will peanuts chicky. So that will, help his craving for sweets also, and that will not be very that will not affect his metabolic profile also. So that is the second thing which I will be telling him. And third thing is, as he is having outside food as a part of his job, I will at least suggest, I can suggest him, the advice is like not to have a fermented food when he is having outside food. So he can have poha, upma kind of things when he is eating outside. That is if possible for him. And lastly, he is non-vegetarian. So in that case, the choice of non-vegetarian food as per Ayurveda will be fishes will be more preferred over chicken or mutton, and not the very oily or fried things. So steamed soups will be preferred for his non-vegetarian dietary habit. So these changes I will try to bring out rather than changing abruptly everything. And this is how I think will help his metabolic health.
Interesting. So from a dietetic point of view, we don't look mostly when it comes to these into the food list. We try to look at calories, we try to look portions, we like to look behavior management. I think your inputs definitely will help the thought process of including the food list.
Yeah, because I just want to say in one word that Ayurveda doesn't have a calorie concept. So correct. Ayurveda looks into the inherited properties or qualities of the food substance which we are having. And that is how we plan the dietary schedule. So that is some little bit different approach.
Correct. So interesting. Now I would ask Shaini here that Shaini, in your in your experience, how would you look at this tips? Now, very beautifully you have explained for the last case where how you have handled such kind of patients. Now this patient is very well motivated and he wants to take help of yours. So from a dietetic point of view, looking at Dr. Bhale Rao's inputs, how would you now integrate this concept of the diet and metabolic health in your practice, in your case in this patient?
Yeah. So the main thing is definitely sleep, as Dr. Supriya had mentioned. That's very, very important to make sure that they go to bed on time, because a lot of people think they can exercise late in the evening. Once they are finished their office work, they come back and then start exercising. So around 6 p.m. or 7 or 8 p.m. Now what happens is with the adrenaline rush, they won't be able to sleep. And that delays sleep a lot. In fact, that's what I had mentioned in the chat box. And it's very important that they also start understanding that they need to go to bed according to the circadian rhythm. It's not about 8 hours of sleep, but going to bed at a stipulated time like 9:30 or 10 p.m. And then you wake up at say 4, 5 a.m. also not a problem, but going to bed at a particular time. So I'd rather set right that factor, because this has a connection to their rate at which they lose their fat percentage, and also the food craving that they get, the sugar cravings that they get is connected to the sleep. This is one of the major factors that I would definitely want to integrate or rather emphasize. Next is to make sure that they believe that it is possible. I think that is a very important factor. When somebody believes that, yes, I will be able to make changes and see results, and then talk to them, and then maybe affirmations, asking them to maintain a journal, even if they're stressed, because there's a lot of stress eating, because when, working professionals, we get to see that a lot. Journaling helps a lot. I ask them to keep writing quite a lot in case they're just not ready to meet a counselor. That's another aspect. Less amount of sugar, even if it is honey, jaggery, demerara sugar, whatever it is, definitely going low on sugar, refined flour, processed food, and then stepping up the protein, fiber, including good fats. So that's where the ghee and the coconut oil and the pure butter, and as you mentioned, A2 milk, or maybe even that very thin buttermilk for probiotic health, and stepping up the protein and fiber. Protein is low. And as Madam has mentioned, of course, different, so moong chilla, besan chilla, green gram ka dosa, those are things that we could consider. Food intolerance, I learned it from you, Geeta. Food intolerance through nutrigenomics, a very important game changer, because a lot of people at the cellular level, when they have inflammation, it becomes very, very difficult. They might be exercising, doing everything right, but if they don't understand that they could be sensitive to gluten or lactose, or sometimes it could be a food allergy to soy, eggs, or peanuts. I think once that awareness comes and they shift, then the inflammatory markers come down drastically. And for metabolic health, I think that is a game changer. Next is, of course, to emphasize on increasing the lean muscle mass. So doing some kind of exercise to increase their muscle mass, because that again helps in the glucose uptake. So bringing these factors together, and another factor is, while they have gained that much of weight, what was happening to their personal or professional life? That is very important for us to understand. They could have gone through a major crisis, some traumatic event, and then they really have to go through that. If it was losing a loved one, then grief counseling is important. Or if there's something to do with work and all that, they definitely have to go to somebody to discuss that and sort that out. So cognitive behavior therapy is something which I found very helpful. And of course, I'm not a professional in that. So sending them to a mental or a health coach is very important, right? And also the benefits. Show them that if you do this, then you're going to be very confident. You can go on vacations. You can go for trekking, hiking. You can wear that slim fit shirts, and showing them that, these are the benefits that you do, right? So why you do what you do. So figuring out why you want to shed the weight, and to reach this place, what are the benefits you're going to reap. So show them both, and that will actually help them get started.
Wow, too good. We'll summarize once we finish Dr. Shilpa's opinion on this. So as a clinical nutritionist, he's diabetic to his dyslipidemic, his hyperuricemic. So we have in our theory that proteins to be avoided, and Shiny mentioned, Priya mentioned that give proteins to help them. So how would you now look at a medical nutrition therapy to be applied here? Does it go so beautifully as what we've learned in theory? Or no, it's very, very personalized approach here. So over to you.
So you answered it. It's extremely personalized, and it begins with what is the caloric intake that the person you are assessing with. I think there is a lot of merit in what both the speakers before me said. I think awareness is very important. And as far as diabetes goes, awareness comes only with monitoring. So, while weight is a source of awareness, I think what is very important is you monitor your blood sugars. So if, say, eating X kind of food increases your blood sugar, then it may be one of the recommended foods in the list, which is available, say, on Google or wherever. It's not for you. And more often than not, we start seeing this when, so for example, millets, there are people whom millets work, and there are people who eat millets and the sugar goes sky high. And that's not meant for them. So I think awareness comes. So while we are talking about how do you do energy calculation? So you begin with the recall, and then you try to reduce calories. Now, idealistically, you look at 500 calorie reduction, but I think that is a very textbook picture. A lot of times people are not ready for a 500 calorie reduction, and we can go really slow. You can look out about supplementing balancing by giving more proteins and more fiber. And like you said, choose protein first. So first, he's a non-vegetarian, uric acids are high. But remember, always it's not the protein who is culprit for uric acid. More often than not, it's the simple sugar and alcohol which is causing the hyperuricemia, and not the protein. So while chicken is a great idea if the person has high uric acid, because fish will increase the uric acid, so will the red meat. So you would want to give, say, chicken and eggs. But what's very important, to control the beer consumption, if at all, and also the liquor consumption and the chakna, of course, which goes with it. So looking at that, and also remember, alcohol consumption will drop the blood sugar initially, and then will shoot it. When the blood sugar drops, there is immense amount of sweet craving. And that is probably the reason why he's having. And also, we just have 1 pp on him. A lot of times when you eat a very carb-rich meal, there is a lot of oversecretion of insulin, and then there is a reactive hypoglycemia which happens. And reactive hypoglycemia in most of the cases makes people go and find sweets, buy sweets, swiggy sweets, just to overcome that hypoglycemia. And that you will know only if you monitor your sugars. If you just say that I feel like eating sweet and look after that craving, it's not going to work. So you have to find out if actually your sugars have dropped, and that's the reason for hypoglycemia. So I think these are the things which I'm going to be talking about. Good fats are going to help, like you spoke, maybe nuts. Nuts are going to help, and not dry fruits. In India, we always speak of nuts as dry fruits, but dry fruits are raisins and khajur and kharik, and they're all going to raise the blood sugar. But you want to give them almonds and pista and walnuts, and even if peanuts, if at all, and they're going to help.
Agreed. So wonderful. So we have already exceeded to 3 minutes. I just want last liner, and then I can just summarize. Is with this discussion, I always thought that it is an integrated approach. We need to have now an open eye thought process of incorporating all the experts, maybe a sleep expert, maybe a psychologist, maybe an Ayurvedic expert. So we are now have to multitask, identify the problem, and then apply it. So we are now into an era of integrated mind-body nutrition to work on mostly the NCDs or behavior modification. I would like to have a last liner from all of you before we conclude. First, Dr. Shilpa Joshi, you can give your last liner comment for a take back home message. And I don't see any questions from the delegates, so I think we can have a last liner and conclude here.
So I think this whole concept which Dr. Vaishali has introduced about, having an integrated approach is here to stay. Because more and more we start seeing patients, more and more years of practice that we have, we realize it is never one thing that is impacted. We are a milieu of many things. And I think what I have learned so far is that really psychology plays a more important role than dietetics or than anything else, because to follow a diet, you need a very strong mind. So if you have to give up something or you have to take in something, both. So if you tell people, you need to eat methi seeds, it requires a lot of courage to gulp them down. And that is coming from your mind. It's coming from the conviction. And I think, therefore, having a psychologist on an integrative approach team or introducing psychology as a part of our curriculum or as a part of practice is very, very important. And I think, I think that's my take home message.
Perfect. Work at a root cause change the syllabus where we have psychology, we have a lot of areas which is not explored as yet. Fantastic. Shiny, over to you to give your last line comment on this kind of a thought process.
Yeah, I'm going to keep it short. Dr. Vaishali and team, hats off to you, because all of us have been sitting in different parts of the country doing things, whatever is possible for us. I think you brought people together. So I would say the take-home message is find your tribe. Align with people, work with people who understand the same language. This is a year of collaboration, integration. So go ahead and find the tribe. And I think just bringing people into this conference itself has been amazing.
Thank you so much. That's what the Synapse is all about.
Yeah, thank you.
Yeah,
thank
that's
you
what
so
this forum is all about. We have so many people of different areas coming together. Absolutely well said. Dr. Supriya, over to you about how do you look at an integrated approach from alternative medicine?
Yeah, I cannot more agree with my previous panelists that we should have psychology in our syllabus and we should integrate. And I think this is a platform where we can start this kind of integrative activities. And certainly I also learned many things from last 3 mind body conference and of course in this conference also. So I look forward to have this continued interaction and dialogue in future also. And I think that is the future of medicine also. So thank you very much. Thank you, Shilpi and Shilpi.
So cannot agree more, panelists. Thank you very much for being a part of this wonderful discussion. It was nice connecting with all of you. Hope our delegates got the inputs which they are looking for. And it's time now we close the session and hand over the session to the organizer. Thank you for all of us, Dr. Vaishali Deshmukh team, to give us this opportunity. Thank you very much.
Thank you. Thank you so
much. Thank you very much. Thank you very much
Thank
to
you
all
so
the
much.
speakers and
Thank
Dr.
you.
Geeta for moderating the session. After about a couple of minutes now, we should move forward to our next session, which will be a sponsored symposium, but it will be conducted by Dr. Sagarika Mukherjee as well as Dr. Yogesh Kadam sir. Thank you. Good afternoon, everyone, and welcome to our next session in Hall B for the conference Synapse 2023. This session will be discussing the management of chronic fatigue in hypothyroid patients. And to deliver this session, we have an eminent endocrinologist from Kolkata, Dr. Sagarika Mukherjee, Madam. Madam is a consultant physician and endocrinologist at Kolkata. She has achieved the Fellow of American College of Clinical Endocrinology degree. She's a visiting consultant in Columb Asia Hospital, Kolkata. She was the treasurer of the Indian chapter of RCPI. She is the examiner of MRCP Clinical Examinations of India. She is the executive director and vice president of Remedy Clinic Study Group in Kolkata. With a vast clinical experience, Madam here will tell us about the management of chronic fatigue in hypothyroid patients. Dr. Mukherjee, Madam, over to you. You're on mute, Madam.
Good afternoon. Thank you very much.
It's a real privilege.
To the Synapse Committee and particularly to Dr. Vaishali Deshmukh for asking me to come and talk here. It's been truly a learning experience to find out about the chronic fatigue associated with hypothyroidism, which I shall be talking about. So we learn a few new things about how do we manage chronic fatigue associated with hypothyroidism and why patients who are fully treated or fully thyroid and complain of chronic fatigue. Now, hypothyroid remains a significant clinical conundrum for clinicians. Majority of the patients who are treated with thyroxine replacement remain asymptomatic, but however, 5 to 10% of patients complain of residual symptoms despite having normal thyroid function test. They might be complaining about cold intolerance, fatigue, weight gain, cognitive impairment, impairment in their mood, or as well as reduced quality of life. And these symptoms remain despite that their free T4, free T3 and TSH level remains normal. And therefore, this led to the thought that whether combining therapy with levothyroxine and liothyronine, that is LT3, can lead to amelioration of symptoms. This approach is based on the concept that hypothyroid patients with polymorphisms in the deiodinase 2 may exhibit some reduced conversion of T4, T3 and resulting in reduced intracellular levels of T3, which results in reduced activation of the intracellular T3 receptors and thereby leading to complications like feeling dissatisfied and persistent symptoms of hypothyroid lingering on. Clinical studies, however, shown that levothyroxine and liothyronine combination therapy sometimes do produce good results in some of the studies, but most of the studies, the results are a bit disappointing with no significant difference in psychological or quality of life. The treatment with levothyroxine monotherapy reduces concentration of FT4 in the serum and therefore creating a ratio of higher LT4 and LT3 ratio. Lower levels of serum FT3 may imply reduced availability of intracellular thyronine in the brain and other tissue despite optimal TSH level in the serum, and LT3 monotherapy might achieve higher intracellular LT3, T3, therefore causing the possible improvements in quality of life. We need to understand or look back upon the hypothalamus pituitary thyroid axis, which through a network of feedback and feed-forward loop controls the thyroid hormone in FT3 hormones, that is FT3 and FT4 production. The hypothalamus provides a hierarchical setting and it provides a feed forward to the pituitary via the TRH and the pituitary to the thyroid gland via TSH. T4 is converted to the biologically more active FT3 through a multi-enzyme process in the peripheral tissue. And both the FT4 and FT3 provide a feedback to on TSH and the TRH. Energetic needs of the body is jeopardized whenever the HPT axis does not function properly, particularly basal metabolic rate and energy and resting energy expenditure remains low. And also the HPT axis must also adapt to the various endogenous and exogenous influences like changes in body weight, body composition, aging, thyroidal and non-thyroidal illness, psychosocial stress, administration of thyroid hormones exogenously, or some epigenetic influences. the adaptation of HPT axis occurred on a slower time scale compared to the more dynamic HPA axis. We need to think about the homeostasis about T4 and T3. Now, the contemporary diagnosis of thyroid disease is based on the conventional view of the HPT axis regulation, which is confined to free T4 regulation and free T4 feedback on the TSH. It does not incorporate regulation and effects of FT3, which is the biologically more active hormone than T4. The needs for protection of homeostasis of FT4 goes beyond the regulation of FT4 production. The bulk of T3, which is found inside the cells, as opposed to the FT4, is predominantly FT4 or thyroxine is predominantly extracellular hormone, whereas T3 is predominantly an intracellular hormone, and this intracellular hormone variation can lead to various sorts of symptoms, which is exhibited in patients who are not really fully satisfied, even being thyroid. The sum effect of circulating FT3 is reported back again to the hypothalamus and pituitary in order to adjust the FT4 production. So there is some protection mechanism of FT3 homeostasis even in the presence of mild thyroid failure. However, some inter-individual variation can exist in the distribution of TSH, FT4 and T3 response curves and their various combinations. While TSH and FT4 concentrations are very sensitive markers of thyroid gland failure in primary hypothyroidism, free T4 gives you more information about the functional state for the rest of the body, but guidelines have only partly addressed this conundrum by separating the therapeutic targets from the diagnostic targets. Thyroid function tests mainly include measuring your TSH level, FT4 and free T3 levels, and hypothyroidism consists of an elevation of TSH with low levels of FT3, and also if hypothyroidism is very severe, FT3 level is also reduced, and hyperthyroid is just the opposite with low levels of TSH and elevated levels of FT4 and or FT3. TSH conventionally is considered to be the most sensitive of all the thyroid function parameters, and TSH level has been considered to be is also promoted as the first and perhaps the only necessary test for euthyroidism, with some exceptions in understanding that a normal thyroid function test implies euthyroidism. And an abnormal TSH implies dysthyroidism. In this context, an abnormal TSH level subsequent measurement of thyroid hormone level allows for classification of dysthyroidism. Now, combination of normal thyroid hormone level with abnormal TSH level is regarded as subclinical thyroid dysfunction. Management for patients with replacement for hypothyroidism, mainly we rely upon the TSH level, and this paradigm is continued despite that there is no empiric evidence that TSH level in fact a best guide to thyroid state of the peripheral tissue as distinct to the thyroid state of the pituitary tissue, and the best guide for successful replacement of hypothyroidism. Maybe we need to look into the thyroid hormones as well. Now, variation of the thyroid function test. Now, multiple studies have indicated that thyroid function test variation within the normal range can be associated with a variety of physiological and clinical parameters. The outcomes are associated with high normal thyroid function, like with high normal thyroid hormones with low TSH levels may include, that is on a state of hyperthyroid state, might include atrial fibrillation, low bone density, cancer, dementia, and adverse pregnancy outcomes, and also death. And associated with low normal thyroid function, that is low normal thyroid hormone level and high normal TSH level, include fatty liver, metabolic syndrome, diabetes, high BMI, etc., and also adverse pregnancy outcome. So, restoration of euthyroid state. There is a biochemical restoration or biochemical euthyroidism, and there is a clinical euthyroidism. Now, following development of primary hypothyroidism, thyroid function is typically restored by administration of levothyroxine or LT4, and based on this consideration, there is interaction of the hypothalamic pituitary thyroid axis hormones. Biochemical euthyroidism is defined as achieving the thyroid stimulating hormone within the normal laboratory reference interval, and sometimes you really need to achieve the TSH level within a very, very narrow parameters of the given population reference range that you're looking into. And all the LT4 replacement may need adjustment for its absorption metabolism and can be relied upon for normalizing your TSH to within the normal reference range. But however, TSH suppression may contribute to normalize, but however, your TSH does control the substituting the TSH level is within your normal range. It does not really reflect that your T3 level may also be normal in the tissue levels, and therefore this can lead to all the symptoms which are associated with chronic fatigue in hypothyroidism. What about clinical hypothyroidism? Most patients with hypothyroidism report that their symptoms have resolved with replacement of levothyroxine. However, about 10 to 15% of patients continue to have persistent symptoms like fatigue, low energy level, problems with weight, low mood, reduced quality of life, etc. So the potential explanation for these unresolved symptoms can be broadly divided into either thyroid-related or thyroid-unrelated causes. And most compelling explanation for this is that they might be deficient on the T3 concentration at a serum, cellular, or even in the tissue level. And there is a complex interrelationship between the serum tissue levels of T3 in various tissue and deiodinases contributing to the T3 production and clearance. Therefore, in order to address the reduced T3 level in the levothyroxine treated patient, a trial of combination of both LT4 and LT3 have been tried about in different populations, and some were successful in ameliorating the symptoms, but most of the trials were not successful in ameliorating the symptoms, either because there were various reasons for failure of the trial, because either they failed to recruit the right kind of patients who were symptomatic, or the trial was done for a very short duration of time, or that the LT3 has got a very short half-life and therefore did not yield the proper results because maybe the dosage was not appropriate. The potential explanation for impaired quality of life despite treatment of hypothyroidism with a thyroid-related is that ideal TSH, as per the patient's own innate production, may not have reached within the TSH may not be within the reference range. Patient's personal TSH point may not have been achieved. There is some negative effect of thyroid autoantibodies as well. High impact of high free T4 levels does not recreate the normal thyroid physiology within the body, and FT4-FT3 ratio may be altered. And also there is tissue hypothyroidism, that is low concentration of T3 at a tissue level or cellular level may not really produce proper symptoms of proper amelioration of hypothyroid symptoms. So there are certain causes of the impaired quality of life because of in patients who are treated for hypothyroidism, which may not be related to thyroid, like negative effect of other autoantibodies which may be present in Hashimoto's thyroiditis, which may not have been diagnosed properly. Symptoms may be because of other comorbid conditions the patient may be carrying. Patient might be taking just the thyroid hormone alone, and maybe this may be the only medication that he's taking, and may be very unhappy about continuing to take medication for a prolonged period of time. And also impact of symptoms caused by awareness of a chronic disease, lifelong requirement for medication might really create an impact in his mind. This is a very busy slide which gives you an idea about potential difference between primary hypothyroidism for various etiologies. Now, more or less, subclinical Hashimoto's hypothyroidism, there will be an elevation of TSH, presence of antibodies, free T4 and serum T3 levels will be normal, and other subclinical etiologies, even the T3 and T4 may be reduced and TSH level may be elevated. Radioiodine therapy, like elevation of TSH to various degrees, but usually antibody is not present. External beam radiation for non-thyroid malignancy, antibodies are not present, although TSH level may be elevated, but however T3 and T4 level may be reduced. And for thyroidectomy or either hemithyroidectomy or total thyroidectomy, TSH level is elevated, but usually anti-TPO antibody may not be present, and serum T3 and free T4 level may be reduced. Now, following treatment with Hashimoto's thyroiditis, TSH level normalizes, but antibody level persists in the blood, although it may take a prolonged period of time for the antibody to get washed out. T3 and T4 level may be normal, and similar kind of things follows with radioactive iodine, external beam radiation, and total thyroidectomy. So what is the relationship between fatigue perception and the said level of serum thyrotropin and free thyroxine in euthyroid subject? Now, this is a study which is which was done in Sweden, From a Swedish medical register. The data was collected on more than 5,800 patients, and the data collected was that whether this patients with that euthyroid, there was a relationship between serum TSH, free T4, and thyroid peroxidase antibodies, and they measured the various ranges of TSH, the FT4 level, antibodies level, and also a questionnaire was given to them about fatigue was evaluated by RAND36, and shortened fatigue questionnaire was also done with this patient population. It was concluded that euthyroid individual who did not have any history of thyroid disease, there was a modest relationship between thyroid function and fatigue, with subjects having an apparently high production of T4, experiencing more fatigue. That subject with a history of thyroid disease with normal TSH and FT4 concentration had more fatigue than general population. The reason was unclear, but for the subtle abnormalities in the dynamics of thyroid hormone secretion. So is there a biologic rationale for persistent complaints in levothyroxine treated patients, in hypothyroid patients? Non-specific causes related to chronic nature of the disease. Having a chronic disease, lifelong dependency on medication may make the patient feel unhappy about it. There has been no prospective study to test the hypothesis that attitude, health perception, and mood of the patient prior to levothyroxine therapy differ between those with and without persistent complaints after treatment. When the patient experiences hypothyroid symptoms, initial diagnosis, the perception of disease susceptibility and adherence to levothyroxine therapy is better, but patients who remain unwell despite a normal TSH level felt that the normal result presented a barrier to the further evaluation. We need to have information, and is usually restricted by the time and often centered on the symptoms rather than patient education. Amongst general practitioners and nurses, the qualitative studies have been done which reveal inadequate knowledge of the medication interaction and the levothyroxine pharmacokinetics. They rely totally upon the blood level, on the blood parameters, and the reference range of the laboratories. What about the autoimmune diseases? Now, associated autoimmune disease occurred in about 14% of patients with Hashimoto's thyroiditis and 10% in Graves' disease. Thyroid autoimmunity per se might be responsible for particular symptoms. It remains really questionable. However, there has been a small study that after removing a thyroid gland in patients with Hashimoto's thyroiditis, there have been some improvement in the symptoms of the patient when the TPO antibodies were reduced in patients who had thyroid gland excised. What about inadequacy of the dose of the levothyroxine given now? According to ENHANCE, participants using levothyroxine and having normal TSH level experience high total and higher T4 levels and a lower T3 and lower T3 concentration than the healthy matched controls. FT3 values remain below the lower limit of normal in observed about 15% of hypothyroid patients who are treated with thyroxine. Now, the reason for this low T3 is maybe the reason for persistent complaint, necessitating high dose of levothyroxine to normalize T3 level. Now, however, slightly lower or higher LT4 does not produce measurable changes in hypothyroid symptoms, well-being, or quality of life of the patient. Now, TSH suppressive doses of LT4 are required in order to achieve a proper level of T3, similar to that before the thyroid dysfunction, and this provides a rationale for thyroid T3 replacement. There is no good evidence that low serum level of T3 or FT3 and FT4 ratio are linked to persistent symptoms. But however, there might be one mechanism involved that with the iododeiodinase, the type 2 iodothyronine deiodinase, which catalyzes the deiodination of T4 to T3 in the extrathyroidal tissue, might be defective, and this might cause reduction of the T3 level. Levothyroxine therapy, which usually normalizes the serum TSH level, does not normalize all the system markers of thyroid hormone signaling, including the serum LDL cholesterol and total cholesterol. A normal TSH level, therefore, does not guarantee that a euthyroid state is reached in all the target tissue. It has been shown in experiments that hypothyroid rats, only combination of levothyroxine, LT4 and LT3 could ensure simultaneous euthyroidism in all the tissues. Although LT4 may not be the ideal form of the hormone replacement, given the fact that your LT3 remains normal, And it's again hypothesized that there is a nucleotide polymorphism in the DIO2 involved, and therefore this causes reduction of your T3, which causes more of the symptoms. There has been a Dutch population-based study as well looking into this this SNP dysmorphism, and they found that 11% of thyroxine users and 10% in the general population, this dysmorphism can be present. So one has to conclude that the origin of persistent complaints of levothyroid treated patients or in hypothyroid patients who have normal TSH level but still remains incompletely understood. Levothyroxine monotherapy is not ideal mode of thyroxine replacement therapy, and there has been a survey done in 2013 amongst endocrinologists that indicated persistent symptoms despite achieving target TSH value would prompt testing for other causes. 84% respondents amongst endocrinologists, referral to a primary care by 11%, and changed from levothyroxine plus the thyroxine combination therapy was done by 3.6%. What about the need for T3 replacement? Rescue mechanism for a free T3 homeostasis is built within the intact hypothalamus pituitary thyroid axis. But however, if it's disrupted in thyroid dysfunction patient, levothyroxine monotherapy is fully dependent upon the efficient T4 T3 conversion. In a portion of patient, escalating the T4 dosage may therefore prove unsuccessful to restore the FT4 balance to the pre-thyroid state homeostatic level. In such situation, targeted levothyroxine supplementation, similar to the natural homeostasis, may correct the FT3 disequilibrium and also provide some potentially unfavorable effects on FT4 excess. And this has been linked even within the euthyroid range, and also some adverse cardiovascular effects and direct T4 effects like type 4 signaling unrelated to the T3 signaling, including malignant growth. Secondary hypothyroidism, pituitary TSH is TSH deficient, affects the TSH feed forward and TSH FT4 balance and FT3 homeostasis, and again replacement guided by FT4 measurement alone may miss out optimizing FT3 target. Non-thyroidal illness syndrome, low FT3 is mainly because of disturbed balance in the HPT regulation between peripheral and central type 2 dehydrogenase activities and intracellular T3 levels, whose net effect strengthens FT3 feedback inhibition on the TSH and weakens the TSH forward on the FT3. So this is again a small study on female hypothyroid patients with residual symptoms of hypothyroidism despite being on levothyroxine therapy. This is a small group of patients studied, and levothyroxine combination therapy was given with LT4 and LT3 for 12 weeks, and it was concluded that there was an improvement in quality of life with residual hypothyroid symptoms on combination therapy. However, this study was done on a short-term basis and it did not include induced biochemical or clinical hyperthyroidism, and no cardiovascular adverse effects was recorded. And this study was from a Swedish medical register. So is there enough evidence that LT4 and LT3 combination serves the hypothyroid patient better than levothyroxine monotherapy? There was a 2006, there was a meta-analysis of 11 randomized control study comparing LT4 monotherapy with LT4 and LT3 combination therapy, found no difference in the outcome. Adverse effects also did not differ between the regimen. Most of the randomized control study can be criticized on a number of issues. There was a selection bias because there was due to inclusion of heterogeneous patient group by etiology and prognosis, dilution of the true effect by low proportion of symptoms of patients, sample size was small, misguided by different types of TSH targets, and also there was confounded by caused by variation in T4 to T3 conversion in efficiency and wide variation in the treatment response. 7 of the randomized controlled trial patients were asked about the preference for a specific treatment. 48% preferred T4 plus T3, 25% preferred T4 therapy, and 27% patients did not have any preference at all. So therefore, the guidelines really could not be really advocated to be adopted universally. So which are the patients who would qualify for LT4 and LT3 combination therapy? Now, 2012 European Thyroid Association guidelines suggest that LT4 and LT3 combination therapy might be considered as an experimental approach in those patients who continue to complain of hypothyroid symptoms despite achieving biochemical euthyroidism within the reference range of TSH. So T3, T4 combination is not recommended for pregnant women and patients with cardiac arrhythmias. This has been adopted by Italian and British Thyroid Association, whereas American Thyroid Association has more or less a neutral role. And it's also suggested that you may discontinue LT3 and LT4 combination if there is no improvement on the symptoms. However, there are some concern exist about giving this combination, that about especially cardiac problems, bone problems, etc. Do atrial fibrillation, fracture after use, these always remain. Although the small number of studies which have been done with the combination does not really give you any concrete evidence that these conditions exist. Demand for combination therapy is increasing worldwide, especially USA, Canada, Australia, and most of the European countries, and there has been a sharp 3.8-fold increase in a number of prescription or replacement for reimbursement for FT4, T3 and T4 and T3 therapy in Denmark between periods of July 2012 and June 2013, and again up to 2014. What should be the appropriate dosage for T4, T3 and T4 combination therapy? The recommended dosage for European Thyroid Association in 2012 guideline, with the assumption that euthyroidism can be reached simultaneously all tissues of hypothyroid patient only when LT4 and LT3 is in a dose ratio that mimics the physiological T4 to T3 secretion in the human. Morel et al. Concluded that therapeutic substitution of T4 and T3 was achieved in a ratio of approximately 3:1. So it suggested that if you start T4 and T3 combination therapy to a dose ratio between 13:1 or 20:1 by weight. So in summary, there are many thyroid-related factors that combine with non-thyroid-related factors in order to affect the patient's response to treatment with hypothyroidism in terms of satisfaction with therapy. Some of the thyroid-derived factors include etiology of hypothyroidism, an amount of residual thyroid tissue left, and also the presence of thyroid peroxidase antibodies. Downstream consequence of interaction of these factors influence both the free T3 and free T4 concentration, TSH and thyroid biomarker concentration. The thyroid biomarkers might extend to other tissues, other serum parameters like lipids, sex hormone binding globulins, or thyroid hormone metabolites, and sometimes the interplay of thyroid hormones at tissue level may not be understood fully. FT4, FT3, and TSH during the thyroid hormone therapy at ideal ratios are poorly understood, and identification for better biomarkers of thyroid function that are accessible and could be combined in clinical practice would advance patient care. And you can conclude that guidelines on T4 and T3 combination therapy were published in 2012, but however, since then, nothing has progressed. There is some dissatisfaction outcome of T4 monotherapy in small group of patients, and persistent symptoms of fatigue, weight gain, problems with memory, thinking, quality of life, etc. can remain in patient, although they can achieve a biochemical euthyroidism. A normal TSH level consequently does not necessarily indicate euthyroid level. Persistent symptoms may be attributed because of low levels of T3 at the tissue, and one of the hypotheses is that there is a SNP dysmorphism in the DIO2 levels requiring a local production of T3 out of T4 and interferes with the kinetic or action, resulting in local tissue hypothyroid or in the brain. So one might try a combination of T4 and T3 combination in order to ameliorate these symptoms, and well-designed randomized controlled clinical trial in selected patients are really required to make further prognosis. Thank you very much for your kind attention.
Please post them in the chat box. The backend team, do we have any questions?
Not yet, ma'am.
All right. Okay, so then thank you, Dr. Mukherjee. We will now proceed for the next
session.
Thank you. Our next speaker for the session will be Dr. Yogesh Kadam, sir. Sir will be talking about transforming diabetes with digital solutions. So, sir is an honorable associate professor in medicine at BJ Medical College, Pune. He's the director of Pune Diabetes Center. He's the member of the Endocrine Society of USA and has a vast clinical experience along with numerous global, national, as well as international clinical trials since the very year of 2004. Sir, over to you for today.
At the outset, let me thank Dr. Vaishali Deshmukh and the entire Synapse 23 team. What I'll be start sharing my slides to start with. I hope my slides are visible.
Very much so.
Okay. So thank you once again. And what I'll be talking through this next half an hour is the transforming diabetes with digital solutions. A very interesting talk, actually. I had to do a lot of get into a lot of reading with this topic. So this is the IDF 2021 estimates for estimates for diabetes, and clearly you see we have a issue on hand. We have a lot of diabetes in the adult population, not just diabetes. There is IFG, 1 in 18 patients. This is IGT, 1 in 9 patients, adult patients. Undiagnosed diabetes, almost 1 out of 2 undiagnosed. We have a lot of GDM as well, type 1 diabetes in children and adolescents increasing. And we have a big burden in the low and middle income countries like India. And we know it's an expensive disease, management of diabetes and its complication has a big toll on the healthcare expenditure, which is out of pocket for most of our patients in India. We know there is a lot of complications, morbidity and mortality associated with this disease. So this is just the overview. And we know that the patient involvement, diabetes self-management is a key part of management of diabetes. I mean, it's just not just a pharmacotherapy. It's not just a prescription which is going to do the job. Patient involvement is very important. Patient self-management to educate, empower, and to impart those skills to the patient which are required for his day-to-day management, and which is an evolving process, a continuous process for his entire lifetime. So the DSME, diabetes self-management education, is a very important part of that treatment structure, that structured diabetes care. However, we know that patient comes to us average about 4 times a year, every 3 months, and he spends about 2 hours per year with the physician. This is data from the West, of course. And the rest of the year, between the 2 visits, the patient is left by himself to manage the disease. So it's very, very important that patient is thoroughly educated in SMBG, tracking blood glucose trends, adhering to medication, insulin therapy, right from storage to the injection to rotation of sites, all that is important. Nutrition and physical activity. So medical nutrition therapy, physical activity, lifestyle modification, all this is what patient needs to do on a day-to-day basis between the 2 visits. And if he does that correctly, then we get the results of the pharmacotherapy to get the HbA1c under control and to get the lipids and blood pressure, and the multifactorial intervention is what is required to prevent complications, both macrovascular and microvascular. However, this remains a big challenge. And over the years, we have had diabetes educators, dietitian, diabetes nurses who have been trained. Unfortunately, like in the West, we do not have a system which can generate educators who are trained to train our patients with all these requirements of diabetes care on a daily basis. But we do have educators, we do try to do the best of job. But clearly, even with just two hours spent in the clinic in a year and the remaining more than 8,000 hours at home, it's clearly very important that there is a big lacuna. And this is reflected in the HbA1c control over the years. Now, there is a lot of data available that in spite of having the best of medications over the last 10, 15, 20 years, the HbA1cs over the decades have not changed much. In fact, there is a trend towards worsening of A1c in the last 10 years, even with the best of pharmacotherapy available. That means that patient adhering to all these strategies, adhering to medication, adhering to diet, exercise, medical nutrition therapy, physical activity, adhering to insulin, and doing that for a long time. It's a long disease, so lifestyle modification has to be done for a very long time. And doing that for a very long time becomes a challenge for the patient. Doing it for a few months and few weeks, most of our patients are able to do a good job. But doing it for years together, doing it for decades together, and we know that this long-term control is actually going to prevent complications in our patients. So that remains a big challenge. to keep the patient in the structured care and to impart this education, the diabetes self-management education, on a chronic basis, on a long time basis, which needs to evolve over a period of time because the disease is going to evolve. It has got comorbidities and complications. So it is a dynamic process, and to have that system which caters to this education and to make the patient follow these things for a long time to prevent complications is a big challenge. And this is where I think the gist of my talk is going to be: can technology help us in these particular aspects? So this is what I'm going to talk about. And innovation has happened. Definitely, technology is available today. No doubt, we have newer therapies, newer monitoring devices, the CGMs, and the app-based glucometers, which I'm going to talk about a little more detail. They are available, and patients do use them. But the number of patients using them and number of patients using them in the right way to help them in the long run is very, very, very few. And this is what I think the need of the hour is to expand this platform, this digital platform, to get in patients on this platform with using these technologies which can help the patients. Basically, you have the devices, hardware, software, the apps, and the platforms, the data monitoring systems. All that is available. So I think all of us have to be more digital oriented, have platforms where our patients can engage with us in meaningful ways. The previous slide showed us the various the parameters of patient education, and all this can be simplified with this technology and coupled with education and follow-up in a digital platform. There is a lot of evidence which is now getting generated and now available that actually it can improve the quality of life, help control sugars, and also cut down the cost in diabetes therapy. So this is what is going to be the gist of my talk. So can digital solutions help to address some of these challenges? And this is a very nice paper by Iyengar and Wolf et al. And these are the various things which are available to us. We have data, and I'm going to go quickly through each one of them. We have the data management platform. So there are a lot of gadgets available in the market today, right from monitoring saturation, SpO2 and pulse and physical activity trackers and diet trackers. You have so many gadgets available which can monitor a lot of health parameters. Now, to have a platform where all this data gathered from various devices can be uploaded to a single platform, which can analyze it in a meaningful manner and help the healthcare provider to make decisions in pharmacotherapy and help the patient make changes in lifestyle, physical activity, diet therapy, and everything else. This particular information which is gathered, uploaded to a platform, and can help both the patient and the healthcare provider to make his treatment better, more meaningful, so as to have impact on his quality of life and reducing his complication in the long run. We have telehealth services. I think this has really picked up since the pandemic. COVID-19 made us more digital than what we were before. I think all of us are engaging patients on tele platforms through various means, and that has really been taken up by the patients also in a big way. It also has an advantage to overcome the geographical barriers. Patients in rural areas who cannot access us physically can use these platforms for a meaningful consultations. Then we have digital prevention programs. I think this is again a big area, taking cue from the DPP program from the US, which showed phenomenal reduction of progressing to diabetes with lifestyle modification. These programs are now available. Many of them are available online, and they can really engage individual patients where it becomes more costly, but then engage at a community level, multiple patient groups, so that the prevention programs become more effective. Mobile apps, and we are going to talk about the My Sugar app a little while from now. Mobile applications are available both for type 1 and type 2 diabetes, and we'll talk about that a little later. and engaging patients on social media. So these are the various, and of course, not last but not the least, cloud connected glucose monitoring system. So we have now glucometers from the top manufacturers, which have Bluetooth technology where they're connected to their mobile and is digitally connected to the healthcare provider through various devices. There can be a tracking of this glucose using cloud technology remotely, and that is again what we are going to talk about little more detail. So we have these 6 digital health solutions, and we are going to look at each one of them. How good are they? Can they address these various challenges which I spoke about earlier? So let us look at the digital data management platforms first. So these are the electronic systems that download and consolidate data from blood glucose meters, CGM devices. So this is not really only for the blood glucometers. You can have various data available from fitness trackers to a single standardized report. So various gadgets can be connected to this platform where interpretation of the entire, whatever is monitored by the patient is done and generated into a single standardized report, which gives us a meaningful interpretation of the patient's health status, and then make therapeutic changes at the HCP end and lifestyle changes at the patient end, depending on the data which is available from the entire monitoring. And I mean, it's an ultimate vision to have the single platform which can analyze multiple parameters and can be interpreted by patient and providers. Basically, patient education and patient empowerment. It's not just enough to monitor. So many of our patients monitor multiple things, but they hardly ever upload it to a data management platform. And if they upload it, there are very few HCPs which would download it at their end to analyze it and to make a change in treatment. I think all of us, there is a healthcare provider level, there is a lacuna. At the patient level, there is a lacuna. There are time concerns, there are resource concerns, and all these patients we need to overcome the clinical inertia. And if all these devices which generate so much of data can be uploaded to a single system, which gives us an analysis, and then the analyzed the interpretation is used for better patient care. So I think digital data management platforms would go a long way in this. So how do they help? They reduce patient burden. So basically, as you know, uploading the data from multiple devices is a cumbersome thing and time-consuming thing. And therefore, patients do not upload it regularly. And therefore, that valuable data which is available and could improve care is not available for the HCP to work upon. Second is the provider burden. So basically, majority of providers, they don't download this data and review the data so that to make changes in the patient treatment. So having this single platform can make it so much easier for the patient as well as the healthcare provider, and it can happen easier and faster. I think that is where problem today is, that the time issue and the cumbersome issue can be simplified by making it easier and faster, and help providers reduce the burden of managing data. So at the patient end, it is beneficial. At the HCP end, it is beneficial. And there's a lot of analysis available with available platforms today that they actually improve glycemic care. They actually improve patient care. Patients, they increase awareness, they motivate patients. So at the patient end, they are very, very important to the patient. Looks at his data, knows exactly what he's doing. It's a very good motivational tool. It's a very good educational tool to show them these charts and to then educate them about the lifestyle changes which are required to make improvement in those mechanisms. So all this can be done digitally instead of waiting for in clinic appointments. The second part is we are going to is telehealth services, and I think as we have all actually upgraded in this matter using various platforms, video text calls, and then patients very remote who could not come to us in COVID, 100, 300, 500 kilometers away, could access us to these teleconsultations and get the best of our consultations. there is a rapid expansion since the COVID-19 pandemic, but I think all of us should be aware with the Government of India guidelines. There's nice 40-page guidelines clearly given by the Government of India about what would be the platforms, what formats are to be maintained, and how the various clauses, even patient identity clauses and the doctor identity clauses, everything is available in this very useful guidelines for telemedicine, which the Government of India generated as soon as the pandemic reached India. Now, does that teleconsultation help lowering costs? Because again, as I told you, patients pay cost of transportation today is high. Patient coming to us from 150 kilometers away. The time lost in transportation, the cost of transportation is reduced by teleconsultation. You can have patients can have second opinions and for a complex disease, especially remote areas. Patient can access the best of consultants across any part of the country. And not just in diabetes, even in critical care, you could have the person sitting remotely, specialist in that facility, where the person typically in a rural area, suppose a patient is being managed by a HCP, where he requires a specialist sitting in a city to help him out, which is possible, where transfer of the patient is not possible. And home care monitoring and ambulatory monitoring. I think this again is a very important part of diabetes care. So telehealth services have become refined the way we treat patients today as far as consultation is concerned. A lot of these software offer patients the options to upload their reports and their documents before a consultation is done. So typically one would look at these reports and it's as good as in-clinic consultation, of course, with its own limitations. But most of the data which patients can upload and is available for the HCP for consultation. Next is the digital prevention program. And this again is a very, very important aspect. The OMADA's Health Prevent, Canary Health, so virtual lifestyle management, Noom's Health Coach. These are the typical examples. And all these are basically, as I told you, based on the famous DPP done in the US, where effective lifestyle management helped in weight loss, helped in prevention of diabetes. So all these parameters for lifestyle patients can be engaged through the digital program. They can take the patient to either individualized program. The cost would be high for an individual to be enrolled in the program. But if it is done at a bigger scale, it becomes more cost effective. And again, using digital tools, these coaches can serve many more patients and becomes much more cost effective as well. So having a diabetes prevention program online and a patient engaging in it, and these programs have shown good results as well, as we see in the next slide. So analysis of some of these programs, like the OMADA Health Prevention Program, reported 2-year data where average 4.9% of the initial body weight was lost after 1 year in the program. So it gives you effective effective changes in body weight, almost 5% reduction, and the A1C reduction reduced by about 0.4% at 1 year and 0.46% after 2 years. So definite. These do work in the remote setting as well, in the digital setting as well. And as I told you, the cost done for individually for the DPP and the cost done at a community-based setting, you can see the difference, almost 3 times reduction in the cost, almost 4 times reduction in the cost, for these programs which can be done on a digital platform. So they work and they become less expensive. So these programs are definitely in need of the hour. The next is, of course, mobile apps. And many of these mobile apps are available for type 1 as well as type 2 diabetes. Just to name a few, type 1 diabetes, you've got the GlucoBuddy, you've got the DID, the Diabetes Intervention Diary, you have Diabetes Manager, and these are robust programs. On the type 2 diabetes front, you have the Blue Star program, you have the Diabetes Manager for type 2 diabetes as well. So many of these apps are available for both type 1 and type 2 diabetes. Type 1 diabetes, these apps have facilities to upload the blood sugars, the insulin doses, and then algorithms to help out the patient deciding the bolus the requirements before the meal. So fairly comprehensive apps are available where patients can be guided by through the management of for insulins and even carb counting for that matter. Again, there's a very good app called as Go Carb for the type 1 diabetes people, where carbohydrate counting, which is a major requirement for effective type 1 diabetes patients, can be met by these apps. So these apps help in advancing the knowledge of the disease, the complications, personal self-management, and can have positive self-management behaviors, diet, exercise, blood glucose monitoring. And the use of these apps, even in type 2 diabetes, can work as an adjuvant to standard self-managing results, and also can give you a good reduction of HbA1c. I'm going to see one app which is a beautiful app, and this is the My Sugar app. So basically, with huge availability across for the population with the mobile phones, ownership rates have increased. And these apps are potentially available to most people, as they help in multiple ways, as we have discussed earlier. And this can help patient improve the skills to live with diabetes, the communication between the patient and the HCP. So basically, can be a very good communication between the provider and the patient. And patient compliance is increased, and we know that anything which increases compliance is going to improve the HbA1c. And a nice feedback loop between the patient and HCP. So these apps again have come a long way for being a good platform for increasing patient skills, for being an interface between the patient and the healthcare provider, and have a positive feedback loop between the HCP and the patient. This is what I was talking about. This beautiful app called as the My Sugar app from Roche, and this app was rolled out way back 2012. It has evolved over a period of time. A beautiful app, and there are two studies which I'm going to show, this one and the next one, where this app has been actually studied and shown by retrospective data analysis to be beneficial. So this is a 440 randomly selected high-risk type 1 diabetes patients, average age about 30 years. 31 years, 15 years of diabetes, 57, half of them females, 6-month follow-up. Patients who were really high engagement with the app, logging in at least 5 days a week for 6 months consecutively. Mean blood glucose 183, coming to a A1C of about 8.0 at baseline. And the baseline T0 was the baseline. And T1 over you see T1 was at 2 to 4 weeks, and T2 was at 3 to 6 months. The time intervals, and what was analyzed was the mean glucose, the standard deviation, high blood glucose index, low blood glucose index, measures of hyper and hypoglycemia, measures of glucose variability, the mean blood glucose, standard deviation, and these were assessed at T1 and T2. And if you see clearly, the mean glucose reduced at T1, T2, a significant p-value, the high blood glucose index reduced significantly. So basically, less glycemic variability, hyperglycemia came down, an estimated A1C dropped from 9% to 7.7%. So nice 1.3% drop of A1C. So one of the key studies for type 1 diabetes, there have been retrospective analysis of large number of patients. This study actually takes about 440 patients, but there are analysis of 4,000, 5,000 patient analysis also available. So clearly, they help in reducing glycemic variability, help in better glycemic control, help in reducing the glycemic burden, which in turn, of course, we know would help in reducing the complication rate. So this is data for type 1 diabetes, the My Sugar app. So this app actually has multiple things: the insulin doses, the insulin dose calculator. You can upload the glucose values. Now we have the Bluetooth technology, where from the glucometer is directly uploaded to the mobile. And as a HCP, you can access all this data from within your clinic, which could be many hundred kilometers away as well. So again, this is another study, retrospective real-world data. And here you have 52 app users, 55% of with type 1, 36% with type 2, and 5.8 with LADA, LADY as well. So LADA. And 77% of the total 52 patients were on insulin. So you had non-insulin patients as well, of 23%, and almost 20% were on insulin pumps. So multiple patients, even type 2, on oral drugs as well, patients on insulin pump as well. Again, you have this baseline value. T1 is 3 months before the apps were used, and T2 is 2 months after the app were used. And the mean glucose dropped from T0 to T1, a significant p-value. The standard deviation of blood glucose dropped. The estimated A1C dropped. The time in range, test in range increased, and the testing frequency also increased as seen in this slide. So significant improvement in A1C, significant improvement in monitoring frequency. And those patients who are actually, these patients were not very badly controlled. The A1C at entry was 6.7% baseline. And those patients who actually more than 6.7 got the maximum benefit. So clear evidence available through real world studies and retrospective analysis with this app. This definitely helps patients with both type 1 and type 2 diabetes with their management of diabetes and better outcomes. The second last is social media. Social media can be engaged in various ways, through patient blogs, podcasts, online forums, general social media platform, information sharing. So a lot of patients can come together and actually encourage each other through various activities for proper patient care. And as last but not the least, the cloud connected glucose monitoring system. So again, Roche has this very nice logbook, the Roche logbook, which is an online logbook app, the online logbook app, which is again beautiful. Because we have used these manual logbooks long time. We know there is a problem to analyze the data. Patients misplace the logbooks. The data is written in a very illegible manner. High blood glucose values are omitted by the patients. There is definite manipulation of data at times, and it takes time to note these sugars down for the patient and to analyze from the healthcare provider end. So we have had these challenges with manual logbooks. That is why Roche has its own now app for the logbook, which is a beautiful app which can help our patients a long way. And then last, but we're coming to this particular topic of IPDM, the Integrated Personalized Diabetes Management, IPDM. So it's a very nice tool where things are integrated and personalized. So basically, we know now diabetes therapy is personalized. It's an interventional approach, structured disease management process, which utilizes digital tools. So basically, it brings together physicians and patients for collaborative therapeutic decision-making. The patient is very important in empowering for decision-making and working together with the HCP. 6 defined steps that are repeated, basically 6 steps that are repeated iteratively through the diabetes care process and adapted to individuals' patients' unique circumstances. So use your digital platform, use a structured program, and we'll come to a little bit of details about that as well. But the first lot of things are required. First is the patient education. Patient is educated for the requirement and the process, and every patient requires a different education. Patient has to be motivated through the program, because unless there is good education, this motivation which is required for long-term treatment will not be there. Patients have to be imparted the expertise not just to monitor the blood sugar, but also interpret the data. Because anything which is done is useless unless there's interpretation from the patient and to see how his day-to-day behavior, his diet, his exercise, his medications, how are they impacting the blood sugars. So that is very important to impart expertise to the patient. And then engaging the patient through a digital platform to see that data, to analyze the data, both the HCP and the patient, and to make changes in the existing therapies to help that data. Patient empathy, a close interaction with the patient, good HCP patient bonding, and is very, very important for the IPDM to work effectively. And these are the 4 C's of the integrated personalized diabetes management. The characteristics of the IPDM, the confidence of the HCP and the patient, the caveats and the contraindications for the same. So let's see each one of them. It is a patient-centered approach. It has to be an easy-to-use interface. It has to be a real-time communication of data between the patient and the provider. It has to be accurate, time-efficient interpretation of the glucose data. Data security and privacy has to be ensured, and collaboration and shared decision making. I think those days of just giving the patient something to do without his own involvement is, I think, that is not encouraged. Collaboration by the HCP, his team, and the patient is very, very important. So these are the various characteristics of the IPDM, apart from the 5 E's which we have seen in the previous slide. Confidence, more informed treatment decisions from the HCP, improved adherence, because when the patient is taking into confidence and he knows exactly what is required to do and he sees the results, the adherence is better. Treatment satisfaction for both patients and the provider is better. Greater patient understanding, greater empowerment, reduced therapeutic inertia. That is a big area from the side of the patient as well as the healthcare provider. I think this is something, if we have such good pharmaceutical therapy now and still not failing to get good A1C for our patients, I think this is the key word from both the ends. So I think this platform, the IPDM, can reduce this to a big extent. Improve glycemic control, clinical outcomes, monitoring of clinical data is possible, and quality of life. You can cut down the hypoglycemia and hyperglycemia. It fills the void between patient and provider. So basically, all this really helps to improve the quality of life for the patient. The glycemic control and empowerment and satisfaction is much, much better with IPDM. Caveats is you have patients who have lack of enthusiasm, have insufficient literacy and skills to be a part of this program. Training has to be adequate. Fear to use technology. I think some large part of our rural population still has some hindrance to use of technology. Non-compliant patients. And as I told you, all 5 E's, which I discussed earlier, have to be established. So these are the caveats. And contraindication, patient refuses to consent. He doesn't want to be a part of it and has poor numeracy skills. These are the patients where it would be contraindicated. So these are the various C's and E's of IPDM. So what exactly is IPDM? Basically, you assess the needs. With sitting with the patient online, you can assess the needs of the patient. Every patient is different. You can individualize it and then give him a structured therapy-adapted glucose monitoring. Patient is taught about the skills to monitor and the skill to upload these readings. Now, ready upload is available with the Bluetooth technologies. And so all this data. So basically, there has to be a structured glucose monitoring. Patient has to be repeated glucose, either a 4-point profile or a 7-point profile. 3-day 7-point profile works beautifully. You can have 1-day 7-point profile. So depending on the patient and his disease and his blood sugars, you can decide what is the best structure of SMBG, which is good for him, which is handed out to him at the onset. He's trained for monitoring and by his assessing his needs. The documentation is structured on a data management platform and which is viewed by the healthcare provider. So assessed and viewed by the healthcare provider remotely, and then have a consultation where this treatment is personalized depending on all the parameters and all the data available. This treatment is then personalized in terms of lifestyle management for the patient and in terms of pharmacotherapy at the HCP's end. And not just stop there, but to assess after 3 to 6 months of the various changes, how they are working, how much they are working. And if not, a lot of reinforcement is still required. This process goes iteratively, continuously. This is how the IPDM works. And has this been studied in a clinic, like a clinical trial? Yes. This is the clinical trial, the PDM Pro Value Study Program, that in Germany, done in 900 plus patients on 51 sites across Germany, and patients followed up for almost a year. So this data is available, and at the end of it, there was significant improvement in HbA1c of the patients. Basically patients were this was a randomized study, randomized to conventional treatment versus IPDM, and the IPDM group had lower A1Cs, had better physician treatment satisfaction and patient adherence as compared to control group. So definite evidence is available that this program helps the patient for good glycemic control as well as patient treatment satisfaction and adherence as well. The various other benefits were also seen because there was also analysis of the health economy of this IPDM program. It clearly showed there is adding qualities of life, there is reduction of complications, and hypoglycemic rates reduced by 8%. So that's again very important, especially for patients on diabetes. Hypoglycemia is the real worry. And I think this IPDM would work best for patients who are on diabetes or on insulin or therapies which can cause hypoglycemia, because you're going to get a reduction in the hypoglycemia, which is always a concern while we are managing our patients. So these are the all benefits of the IPDM. So I think come to the end of my talk. Technology is rapidly changing, but there is no one size fits all approach. As always in diabetes, everything is individualized. And so the technology also has to be individualized based on patients' needs, desires, skill level, and availability of devices. So I think over the last half an hour, I have covered how digital platform can make it easy for patient management using the various technologies and IPDM as well. So thank you very much for the listening. Any questions, we'll take them.
Thank you so much, sir. I believe now we have a fair idea about how technology can be used for the management of diabetes care by doctors as well as by patients. So the backend team, do we have any questions?
No, ma'am.
In case anyone does have any questions, we can mail them to sir and we will come back to you with the answer. Thank you very much.
Thank you, Synapse. Goodbye.
Goodbye. So moving forward with the next session, Mr. Darshan, should we go ahead with the next session? All right. Okay. So moving forward with the next session, we have with us Dr. Indumati Kuberan, who is going to be the moderator for this session. Madam has she is a diabetologist in Mumbai, and she has special interest in diabetes. She's been practicing the same in Borivali East for about more than 20 years. She has 2 clinics. She has postgraduate certifications in diabetes specialties from the Public Health Foundation. She's a member of RSSDI and United Diabetes Forum. She is an accredited speaker of the MMC and has delivered many lectures for the general public in Indian Medical Association, the Malad Medical Association, and has a lot of publications in this regard. With a vast expertise, Madam will now help us moderate this session on diabetes. Over to you.
Thank you. Thank you, Paulami, and thank you, Synapse, for the invitation. And this is a Novo Nordisk Symposium. And our first speaker will be Dr. Sonali Patange. She is practicing as a consultant diabetologist from 2001 till date. She is also a consultant diabetologist at Sushruta Hospital, Dadar. She was a diabetologist to our honorary CM of Tamil Nadu, late Madam Jayalalitha. She's the director and founder of Dr. Sonali Patange's Specialty Diabetes Center. She's an honorary diabetologist at Juvenile Diabetes Foundation, Oshiwara, and she is an obesity treatment consultant, SCOPE certified in 2022 by World Obesity Federation. So I invite Dr. Sonali to deliver a talk on ultra long-acting basal insulins, out with the old and in with the new.
Thank you, Dr. Indumati. Many thanks to Synapse and Team Synapse for having me here. I'll be sharing my screen. Are my slides visible?
Very much, ma'am.
Yes, ma'am.
Thank you. Yes. So let us begin with a very good evening. I think very interesting talks previously as well. So let us go out with the old and in with the new with ultra long acting basal insulin. So this is my financial disclosure. Let us look at this case study of a person named Ajit, who is 45-year-old engineer by profession, a diabetic since last 6 years. He is having an A1C of 9.2, a BMI of 27, fasting and a postprandial which is pretty high at 202 and 220. He has a previous history of hypo. He has hypertensive as well. There is dyslipidemia. He also has microalbuminuria. We are looking at family history of diabetes. We're looking at alcohol intake, which is more than 2 drinks per week, non-smoker. Exercise is irregular. He's been a known case for last 6 years, and hypertensive for last 7 years. He also is a known case of dyslipidemia since last 2 years. So what are his challenges with previous medication? The treatment history was as follows. He's on 2 grams of metformin. Then he's on injection liraglutide 1.2 milligram per day, empagliflozin 25 milligram once a day. However, still his blood glucose remains uncontrolled. There is uncontrolled hyperglycemia. Subject has a hectic work life, fears insulin initiation will affect his work life due to hypoglycemia risk. He has to travel often and hence he's unsure about actually taking insulin at a fixed time daily. So what would be the ideal choice of insulin at initiation? If we look at the ADA 2023 guidelines, here we are looking at if injectable therapy is needed to reduce HbA1c, patient is, you do consider a GLP-1 or a GIP-GLP-1 RA in most individuals prior to insulin. Now, if the patient is already on a dual GIP-GLP or a GLP-1 RA, if these are not appropriate or insulin is preferred, A1C is above target, we will add a basal insulin. So consider insulin as a first injectable. Definitely, if there is an ongoing catabolism, symptoms of hyperglycemia present, A1C levels more than 10, blood glucose levels at 300, or a diagnosis of type 1 DM is a possibility. So what are the features of an ideal basal insulin? We all want our insulin to be like this, a flat peakless activity profile to minimize the risk of hypoglycemic events, a long duration of action, more than 24 hours to allow for dosing flexibility, and a minimal variability. So let us look at the first generation basal insulin analogs. Now it's time to leave them behind, and why? So consistently proven hypoglycemia benefits across the BEGIN study, the SWITCH 2 study, the DEVOTE study, and the RWE also. So this was Gludec versus Glargine U100. This is the evidence. So if you look at overall hypoglycemia reduction by 28%, nocturnal by 49%, severe by 86%. Now this was a pooled maintenance phase population, it was insulin naive. Here we are looking at 40 reduction in the SWITCH 2, 30% overall reduction. DEVOTE had a 53 and a 40%, and a real world evidence of EU had treat to type 2 DM had a 61% overall reduction. So very, very significant that we all know that people do tend to discontinue insulin once they occur even one episode of hypoglycemia. Now we can achieve lower glycemic targets with degludec versus insulin euglargine before incurring an equivalent risk of hypoglycemia. So the blue line here is the degludec and U100 glargine is the gray line. So these are all type 2 DM people. Now when we look at degludec versus glargine U100 profile, here we're looking at the onset of action of 0.5 to 1.5 hours, duration of action more than 42 hours. Glargine U100, onset of action 2 to 4 hours, and a duration of action of 22 to 24 hours. So degludec has a faster onset of action, prolonged duration of action as compared to glargine U100. Now, when we look at flexibility, we all know that people do not want to stick to specific hours when it comes to people who are traveling a lot and who need better flexibility. So with glargine U100, there is no flexibility. This needs to be taken at a fixed time daily. However, with degludec, there is a flexibility of 8 to 40 hours. So even if the person is delaying his injection, he won't be in trouble. Here, when we look at within day variability versus glargine U100, so this you're looking at a publication which was done in 2018 in March. So degludec at 0.5 unit per kg in 22 people versus glargine U100 0.4 unit per kg in 22 people. So look at the time interval in hours where you're looking at a sustained insulin in the bloodstream. Here you're looking at a much lowering action. So as the time is going on, you're seeing a lower and lower dose. So the total glucose lowering effect was more evenly distributed across a 24-hour dosing interval with degludec as compared to glargine U100. Now we're at 82% with glargine U100 and only 20% significantly lower intraday variability. Now, when we talk about time in range, previous speakers speaking about IPDM and how CGM, and these things are important. So now when we look at the Switch Pro RCT, it is a CGM based evidence. So there is a better TIR and a lower nocturnal time below range, the TBR, with degludec. So when we talk of superiority of IDEG, this was actually confirmed where a treatment difference was significant. It was 20.6 minutes per day in favor of degludec over glargine U100. This was presented at the ESG 2020. So time below range, if you look at nocturnal level 2, nocturnal level 1, and level 1 plus level 2 hypoglycemia, both were better with degludec. So significantly better TIR also, and a nocturnal time below range. So now when we compare the ultra long acting basal insulin. So let us see the confirmed study first to begin with glargine U300 and degludec. So this is the data from real world evidence hypoglycemia results. So here you're looking at the change in the rate of hypoglycemia, change in the proportion with hypoglycemia favoring degludec versus glargine U300. So degludec again has shown a significantly lower risk of hypoglycemia versus glargine U300 as evidence from real world practice. So again here, when we look at the same study in the hypoglycemia results, it changes in the rates of hypoglycemia demonstrated a 30% lower rates of hypoglycemia with degludec versus glargine U300. So again, the change in the proportion of people experiencing more than one episode of hypo was significantly lower with degludec versus glargine U300. So again, a significantly lower risk of hypos versus glargine U300 as evidence from real world practice. Let us look at the profile of both these insulin. So here you're looking at degludec, which begins its action in 0.5 to 1.5 hours. It has a minimal peak duration of action of more than 42 hours. Glargine U300 is a little slow to begin its action, to minimal peak and a duration of action of 30 to 36 hours. Here degludec has a faster onset of action and prolonged duration of action as compared to glargine U300. Degludec thus offers unparalleled flexibility versus glargine U300. So you are looking here at 8 to 40 hours where you're looking at plus or minus 3 hours. So definitely greater flexibility with degludec. When we look at within day variability versus glargine U300. So we had previously shown this with glargine U100 also. And now when you compare it with degludec with U300 also, again, the same amount of dose, 0.4 unit per kg in equal group of people, 57 and 57 in both the groups. This has a lower within day variability in the glucose lowering effect versus if you compare it with the time interval with glargine U300 over a period of 24 hours, there is a increase in, and then the levels are dropping. And again, there is a improvement. So it is not very consistent like how we need our insulin to be. Now, when we look at degludec, a lower day-to-day variability versus glargine U300. So this is your degludec and this is the glargine U300. Again, here you are seeing a consistent basal insulin, and here we are seeing actually a peak coming on. So insulin degludec is thus more potent. Glargine U300 has a 30% lower potency versus degludec. So area under the curve. So if you look at this, you're looking at a glargine degludec U300 ratio of 0.698. The p-value is less than 0.001. So significantly lower dose, 23.5% lower dose was seen with better FPG control with degludec in the BRIGHT study, which had compared degludec with glargine U300. So again, we are requiring lesser amount of insulin with better results. Glargine U300 requires 20% extra doses as stated by RSSDI 2022 guidelines, where there is definitely a bigger dose required for glargine U300. Better adherence with degludec, this was a confirmed study. So we all know that there is a risk of treatment discontinuation with insulin. And there they have actually compared ultra long acting to insulin, so glargine U300 and degludec. So the likelihood of discontinuation of basal insulin treatment in people who received the initiated treatment with either degludec or glargine U300. So time to discontinuation, here you are looking that there is looking at this graph where there is a 27% lower risk of treatment discontinuation, again in favor of degludec versus glargine U300. So to summarize, the ideal insulin degludec definitely fits the bill. It has a flat, peakless profile activity, minimizing the risk of hypoglycemic events. There's a long duration of action, more than 24 hours, allowing a dosing flexibility and with very minimal variability. Thank you so much for your kind attention.
Thank you, Sonali, for taking us through the ultra long-acting insulin. Our next speaker is Dr. Suhas Gopal Erande. Sir has been practicing as consultant from the last 35 years, has his own diabetes center and insulin pump clinic at Akshay Hospital, Karve Road, Pune. He is noted for his social work. He has been awarded the Diabetes Mitra for social awareness and diabetes education in Pune. He is the honorary consultant in Pune Municipal Corporation. He has written various diabetes patient education books and audio CDs for heart attack prevention. Dr. Sir is a trustee of the Diabetes Care and Research Foundation, Pune, working actively for more than 1,000 juvenile diabetes adopted children. And he has given lectures to more than 12 schools for increasing the awareness of childhood obesity and implementing exercise programs. And Sir was the scientific chairman, Focus Diabetes State Conference 2014, and also the organizing secretary for Maha RSSDI 2015. With this, I invite Sir to talk on addressing an unholy trinity of type 2 diabetes, weight, and cardiovascular disease with oral semaglutide. Welcome, Sir.
Let me share, madam. Once again, a very good evening to all my friends who are participating, and huge thanks to Dr. Vaishali and the Synapse organizing team. This is really an enlightening program of mind and body in endocrinology. I will be talking about the oral GLP-1 analog, which is oral semaglutide or Rybelsus in the market. We know that we have a huge burden of type 2 diabetes, and most of the type 2 diabetic patients, if not all, are either overweight or obese. Let's understand the pathophysiological interplay of diabetes, obesity, and the complications. And let's try to revisit the approach to the management of diabetes upstream or downstream. And let's look at the role of oral semaglutide as well. So we know that diabetes itself is a higher risk to develop organ complications, and diabetic people have higher all-cause mortality as well as cardiovascular mortality, which may vary between 2 to 5 times in male or female compared to the non-diabetics. Add to that we have across the globe, we have every 10th person, so 10% of the population of the world, the prevalence is practically 10%. So every 10th person is diabetic. Add to that every 4 in 10 diabetic adult patients are obese. So we have 20.4% overweight diabetics and 67.3% obese diabetics. So taken together, type 2 diabetes and obesity increase the risk of all-cause mortality as high as 7 times compared to lean non-diabetic people. So this is a vicious cycle. How does the vicious cycle really look like? So you can easily see here that we have cardiovascular disease as the main complication of type 2 diabetes. Type 2 diabetes is, of course, a hard risk factor for cardiovascular disease. And there is a nexus between overweight and type 2 diabetes, as we know. In fact, we say that the pandemic of type 2 diabetes is actually fueled by the pandemic of obesity across the globe. So weight or overweight obesity, type 2 diabetes, and taken together culminating into cardiovascular disease. So this is something which is very important to really give a thought to. And can pharmacological weight management address this triad when we address diabetes and cardiovascular disease? This is a point which we'll briefly discuss. So there is a weight, overweight on the x-axis and the increase in different costs of treatment on the y-axis. So if the person has a overweight, BMI between 25 to 30, then the health cost, they increase by 11%. BMI between 30 to 35, the rise in cost is 17%. 35 above, it is 29% costlier. And hugely obese people, BMI more than 40, the health cost can go up by as high as 46%. So this is something which is very important for the patient, for the healthcare providers, and for the policymakers as well. So let's try to understand the pathophysiological interplay between all these. So if we really look at the pathophysiological interplay of type 2 diabetes and obesity or adiposopathy, the diseased or dysfunctioning adipose cells, we know that there are a lot of environmental triggers. For example, the plenty of food available, lack of physical activity, then excess intake of alcohol, other addictions, and the food security. All these, or in fact, insecurity also. So that can result into excess gain of weight and generation of adiposopathy. The fat cells are overflooded with fats, and that's why they start producing a lot of adipokines, which can increase the sympathetic nervous system tone, free fatty acid output, and of course, the visceral obesity, fatty liver, fatty heart, fatty kidney, so on and so forth, and insulin resistance, which is a risk factor for development of type 2 diabetes as well as cardiovascular disease. If the person is obese to start with, not diabetic, then he can always suffer from sleep disorder, breathing, inability to be active. He finds it difficult to move around. And then, of course, there are psychological factors like having obesity can be a stigma and it can impair the mental health of the person as well. Taken together, the insulin resistance in the liver, skeletal muscles, adipocytes, and the lipotoxicity, excess collection of fat in the islets of pancreas that can produce type 2 diabetes. And adiposopathy, the insulin resistance and this promotion of the insulin resistance as well as beta cell decompensation culminates into development of type 2 diabetes. So there is an approach to managing type 2 diabetes where if we appreciate that it is the adiposopathy, excess weight, which can culminate into type 2 diabetes in majority of the people, I repeat, majority, not everybody, then looking at the weight management or making the patients lose weight, would it be a more prudent factor to management of type 2 diabetes? Because weight loss can certainly promote glycemic control, what with various excellent trials by Professor Roy Taylor, the counterpoint and point and counterpoint trial, and so many others. He has shown that very low calorie diet, weight loss can certainly improve glycemic control. Then it can also affect the cardiometabolic risk factors, dyslipidemia, high blood pressure, central fat reduction, etc. The weight loss can certainly disrupt the underlying pathophysiology, and it can, down the line, may reverse or slow down the progression of type 2 diabetes. So we can, in the long run, look at prevention of both micro as well as macrovascular complications. So weight management rather than glycemia management, is that really going to be the way forward? So let's look at the importance of weight loss in type 2 diabetes, incidence control, and remission down the line. So if we look at the different degrees or extent of weight loss the patient has achieved, or we have made the patient achieve, what can really be the conclusion? Greater weight loss can improve obesity-related complications. So if the patient loses between 0 to 5% of weight, there is the amelioration of both high blood pressure as well as high blood sugar. If the patient loses more weight, between 5 to 10%, we can certainly, if the patient is pre-diabetic, then the DPP trial and Finnish diabetic prevention program, even our Indian diabetes prevention program has shown that the conversion of pre-diabetes to type 2 diabetes can certainly be retarded or delayed by 5 to 10% of weight loss. NAFLD, non-alcoholic fatty liver disease, and NASH, that can also have some amount of amelioration with 5 to 10% of weight loss. The girls who are suffering from polycystic ovary syndrome, their symptoms can certainly get abated, and dyslipidemia also can be curtailed. Looking at a weight loss of even higher, 10 to 15%, we certainly can have a relative reduction of development of cardiovascular disease, urinary stress incontinence, which comes with excess weight, that can certainly get down. The sleep disorder breathing can come down.
the gastroesophageal reflux disease can come down, because the excess fat accumulation in the muscle diaphragm that comes down, and the tone of the esophageal gastric valve that certainly improves. We can histopathologically prove that the non-alcoholic steatohepatitis parameters on histopathology, they also improve with 10 to 15% of weight loss. And of course, the physical burden on the knee joints that can be coming down, improving the knee joint osteoarthritis. These days, we also talk of weight loss, which is more than 15% by either a powerful pharmacotherapeutic agent or maybe by bariatric surgery. So more than 15% weight loss, you can look at type 2 diabetes remission, improvement in the heart failure with preserved ejection fraction, and relative risk reduction of cardiovascular mortality. Triglyceride levels can come down by more than 15%. They keep on coming down with more than 15% weight loss. Blood pressure keeps on coming down with more than 15% weight loss. And HbA1c certainly can be reduced very, very effectively, maybe between 2 to 2.5% also, with a weight loss of more than 15%. So higher the weight loss, better are the benefits on different cardiovascular parameters and some other elements also. Look at the three variables: blood pressure, triglycerides, and HDL and LDL. The yellow is the diastolic and blue is the systolic blood pressure. This is a look ahead program. These were type 2 diabetics, and some of them were subjected to routine care and some were randomized to intensive lifestyle intervention. What happened? Some people really had an extremely good, impressive weight loss, more than 10%, more than 15% within the first year of starting their treatment. And what happened to the blood pressure? So the blood pressure kept on coming down. As you can see, if the patient were successful in achieving more than 15% weight loss, the blood pressure came down systolic by more than 15% and diastolic also to a significant extent. Then triglycerides kept on coming down. Okay, kept on coming down. So higher the weight loss, higher was the decrement in the triglycerides. There was a better level of HDL with weight loss. And you know very well that HDL is a cleanser of the arterial structure, and that improves the risk of atherosclerosis. And the LDL, the main culprit for formation of the atheroma or the plaque, that keeps on coming down. So lipid parameters improve and the blood pressure comes down. That was the observation in the look ahead 1 year data. 48% lower hazard of cardiovascular disease was seen. And when was that seen? Those people who lost their weight significantly in the first year of look ahead study, at the end of 10 years, look at that. Loss of 5% body weight in the year following diabetes diagnosis was associated with improvement in the risk factors and a 48% lower hazard of cardiovascular disease at 10 years. So imagine that you have a newly diagnosed diabetic patient, type 2 diabetic patient today. He is, let's say, overweight or obese, and you start him on a management, of course, for glycemic management, but also making him lose weight. And if he really loses weight, as little as 5% in the first year of his diagnosis of type 2 diabetes, at the end of 10 years, he has 48% lower hazard of cardiovascular disease. That's something which is very important. So let's be therapeutically very, very alert and prompt when we start treating our newly detected type 2 diabetes. What are the effects of available anti-diabetic drugs on weight? There are different oral as well as injectables, we know. So drug classes like the glucagon-like polypeptide 1 receptor agonist, the sodium glucose cotransport inhibitors, metformin, pramlintide, they can make the patient lose weight. DPP4 inhibitors, alpha glucosidase inhibitors, they can be called as weight neutral. They may not, you can say, make the patient lose or gain weight. And then there are secretagogues like sulfonylureas or meglitinide, the glitazones, especially pioglitazone these days, and of course insulins. They can make the patient gain weight. So this is something which we know. Now, looking at the GLP-1 receptor agonists, which provide the right balance of efficacy of HbA1c lowering as well as safety. What are the different points? So comparing metformin, SGLT2 inhibitors, and the GLP-1 receptor agonist, we can see that the physiological actions are: metformin improves the insulin sensitivity, it reduces the hepatic neoglucogenesis. SGLT2 inhibitors, they reduce the glucose reabsorption from the proximal convoluted tubule. And GLP-1 receptor agonists, they increase the insulin secretion. In fact, they say that the insulin genes in the beta cells are overexpressed or stimulated by GLP-1. They reduce the excess postprandial alpha cell mediated glucagon secretion. The postprandial hyperglucagonemia is abated by GLP-1 receptor agonist, and they also slow down the gastric emptying. So the postprandial hyperglycemia is curtailed, and they improve the satiety in the hypothalamic satiety centers. So they reduce the appetite. HbA1c lowering efficacy, metformin is intermediate, SGLT2 inhibitors intermediate, GLP-1 receptor agonist, the glycemic efficacy is very high. There is no hypoglycemia risk either with MET or gliflozins or with GLP-1 receptor agonist. Weight effects may be low with metformin, SGLT2 inhibitors, some amount of weight loss certainly, but the weight loss can be really appreciable with GLP-1 receptor agonist. And cardiovascular benefits, not really, you can say, significant metformin point of view. They are certainly there. The ASCVD risk reduction, cardiovascular death relative risk reduction, the heart failure, both reduced ejection fraction as well as preserved ejection fraction benefits with SGLT2 inhibitors. Renal protection also to add. GLP-1 receptor agonist, also the liraglutide, the dulaglutide, F-peglinatide, and semaglutide. All of them have proved in robust clinical trials their anti-atherosclerotic and reduction of MACE they have already shown. Now, revisiting the management either upstream or downstream. So this is the, you can see the roadway of pathophysiology of diabetes, which keeps on worsening all the time. But what are the problems which the patient meets with upstream? Probably even before the patient starts getting clinical diagnosis of type 2 diabetes. So they could be probably having obesity, overweight, or they could be suffering from adiposopathy. Down the line, they may get the other comorbid like hypertension, coronary artery disease, and the villain itself, which is type 2 diabetes. And then when they keep on traveling with type 2 diabetes, maybe with comorbids, downstream, they have problems like hyperglycemia, microvasculars, and macrovasculars. If they are only obese, as I have already mentioned, they could suffer from osteoarthritis, dyslipidemia, fatty liver, or NAFLD, NASH, and sleep disorder breathing. So if we go the prudent way, which is weight-centric approach, we can stall the gaining of weight. We can curtail the obesity, adiposopathy right here, maybe in the pre-diabetic stage, and the patient may never develop type 2 diabetes at all. Or if the patient has developed type 2 diabetes, we will not probably allow him to worsen to huge hyperglycemias and maybe micro and macrovascular complications. And of course, the sleep disorder breathing, NASH, osteoarthritis, hyperlipidemia, etc. So that's a weight-centric, prudent, upstream intervention of type 2 diabetes. Vis-a-vis the traditional wisdom or the custom of treating diabetes, patient gets diabetes, maybe comorbid, then he comes to you and you start with the treatment, which is usually centered on glucose. So glucose-centric approach, which is called as a downstream intervention, which is a traditional, or I would say it is a clinically inertia kind of way of treating type 2 diabetes. So there is an opportunity in intervening upstream rather than downstream. So the pathophysiological drivers of type 2 diabetes and obesity can be stalled and the patients can be saved from different complications down the line. What are the unmet needs in weight loss therapies? We certainly know that the patient can, in the initial days, appreciably lose weight, but sustainability and quality of weight loss both are important. We want the patient to lose more of the central fat or the visceral fat rather than the whole body weight. Other important thing is we have to address long-term cardiovascular risk factors, and effective glycemic control also needs to be looked at. This sustainability or maintaining the weight loss is something which is very, very important. That was seen even in the look ahead trial, which I have just now alluded to. So now looking at a molecule which can address probably all these gaps, well, yes, the evolving guidelines look not at glucose-centric approach, but organ-centric approach, which now we can call it as a cardio, adipose-centric approach of looking at management of type 2 diabetes. So in 2000, the glucose-lowering agents were aimed at improving the HbA1c, so glucose-centric approach. 2008, the glucose-lowering agents were aimed at improving the HbA1c without increasing the cardiovascular risk, weight gain, or risk of hypoglycemia. 2015, the glucose-lowering agents were aimed at improving the HbA1c, improving the patient's cardiovascular disease and renal outcomes and class effects. And 2020s, we are not only looking at the diabetes or glucose-lowering agents from the point of view of glycemic improvement, but organ protective or cardiovascular and renal outcome improvement also. So we want the patients to improve HbA1c, improve the patient's cardiovascular and renal outcomes as class effects. And we also want to reduce the weight of the patient, the visceral adiposity of the patient, if possible. This is the 2023, the latest ADA guideline. And as you are all aware, after diagnosis, we have to reiterate the healthy lifestyle, diabetes self-management and support, and the social determinants of health also should be looked at. Then we probably start with metformin, and if the patient has established atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease parameters, then we certainly start him on drugs like liraglutide, dulaglutide, semaglutide, or maybe empagliflozin, dapagliflozin, canagliflozin, which are cardiorenal and heart failure protective drugs. These drugs can certainly steer clear of hypoglycemia risk, all of them, and they can make the patient reduce some amount of weight or impressive amount of weight, especially if you are talking about the GLP-1 receptor agonist. So, looking at the fine print in people with heart failure, chronic kidney disease, or established cardiovascular disease, or multiple risk factors for cardiovascular disease like obesity, strong family history of CAD, smoker, dyslipidemia, hypertension, etc. The decision to use the GLP-1 receptor agonist or SGLT2 inhibitors, which have proven cardiovascular benefits, that can take over the starting of use of metformin. In fact, the European Society of Cardiology has endorsed this approach way back in 2019. And now the ADA EHD guidelines also mention a similar approach. Other fine print: when choosing glucose lowering therapies, choose the regimen with a high to very high dual benefit, which is weight reduction as well as glucose lowering. And semaglutide certainly belongs to this high efficacy of losing the patient's weight as well as improving his blood sugar. What is the other part of the story? This is the ADA EHD recommendation again: increased importance to weight along with glucose control. So on the left hand side you have glycemic management, on the right hand side you have weight management. And you can very easily see here that there are some drugs like dulaglutide high dose, semaglutide, and then the drugs which are not in India but they have already come in the market like tirzepatide and some more, which have a very high efficacy of making the patient's glycemia come down, approach the target of HbA1c 7%. And on the right hand side you can see that semaglutide, tirzepatide, these are the drugs, or high dose of dulaglutide or liraglutide, these are the drugs which are very, very efficacious, highly efficacious to make the patient lose weight. So these drugs count on both glucose improvement and the weight improvement categories. So my friends, to summarize, 7 out of 10 patients of type 2 diabetes are obese. Approximately 7-fold mortality is seen in people with diabetes who also have overweight or obesity. Upstream approach, looking at the weight as well as sugar control rather than only sugar control and then the other things. That upstream approach can lead to early intervention in treatment of paradigm of diabetes and can reduce the complications. Weight is given more importance in according to recent international and national guidelines in managing diabetes. Let me mention here that the scenario in India is not very different. Our type 2 diabetes, typical type 2 diabetes outpatient department, at least 70% of them are either obese or overweight. So our patients, type 2 diabetic patients, also can be certainly benefited with the upstream approach of weight as well as glycemic management rather than downstream glycemic management only. Oral semaglutide is a molecule which can fulfill the role of effective glycemic control along with excellent weight management also. My friends, I thank you so much for your kind attention. Thank you so much. And once again, I am obliged to Dr. Vaishali and SANAPS organizers for making me participate in this discussion. Thank you so much.
Thank you, sir, for the clear explanation of the upstream approach with oral semaglutide. Next up is Dr. Anjali Bhatt, madam. She is MD in medicine from Mahatma Gandhi Institute of Medical Sciences, Varda. She stood second in the university. She has been trained in the prestigious Department of Endocrinology at CMC Vellore. She is very passionate about patient care, research, teaching, forming curricula for various courses and community-based activities. Ma'am has contributed many publications in journals as well as books and invited for talks in many conferences. Ma'am is passionate about watercolor paintings, writing, reading, traveling, music, and motherhood. With this, I invite ma'am to present Beyond the Frontiers of Glucocentric Approach with Oral Semaglutide.
Thank you so much, Dr. Indumati, and thank you so much, Dr. Vaishali ma'am, to invite me for this prestigious meeting of Synapse. Can I have the right to share the slide? Yeah, I think, is the slide visible?
Yes, ma'am.
Right, it's seen in the PowerPoint mode, right?
Yes.
Can the technical team say go? Shall I start?
Yes, ma'am.
Yeah, thank you. Thank you so much. So we had lucidly heard from Erende sir just in the previous talk that we need to go beyond the glucocentric approach for management of diabetes and think weight as one of the most important parameter that we track when we treat our patients rather than just being glucocentric. And after having heard the lucid pathophysiology that sir explained very well in the previous talk, let's come to the practical application of this wonderful molecule that is oral semaglutide in management of our obese type 2 diabetic patients. So this is the disclosure. We know that Novo has supported this. The agenda is today about talking about oral semaglutide. In short, the evidence behind use of oral semaglutide in patients who are overweight and with type 2 diabetes mellitus, how their quality of life is better with GLP-1 receptor agonists, and the benefit of early initiation of oral semaglutide in these patients. So coming to the first, we know that oral GLP-1s have been path-breaking in providing very good HbA1c reduction along with body weight reduction, very low hypoglycemia risk and cardiovascular benefits. They are safe in large amount of population, large subtypes of populations. Side effects like nausea or gastrointestinal side effects are transient. And now we have the convenience of having a GLP-1 agonist, receptor agonist in an oral form, which is much more acceptable to our patients rather than the injectable form. So if I have to explain all the evidence that we have about oral semaglutide in one slide, this would be the slide, which is a canvas of Pioneer trials, where Pioneer 1 was conducted in comparison to placebo, Pioneer 2 when it was compared with SGLT2 inhibitors, Pioneer 3 when it was compared to sitagliptin, DPP4 inhibitors, Pioneer 4 versus liraglutide, then we have Pioneer 7 with insulin, not as versus but as an addition to insulin. And then we have some trials, Pioneer 9 and 10 in Japanese patients, and then we have an ongoing CVOT superiority trial, which results of which will be available in a couple of years, or maybe lesser than that, I'm sure. Then we have special populations studied, the population with renal impairment, and we have a CVOT in Indian subjects in Pioneer 6. So having looked at this, let's see how, as a comprehensive look, oral semaglutide fared well when it comes to HbA1c and weight reduction in patients with type 2 diabetes. So looking at the HbA1c reduction with oral semaglutide, you can see here as a monotherapy, the HbA1c reduction was a whooping 1.5 with 14 mg oral semaglutide, but also 1.3 with 7 mg of oral semaglutide. When compared to empagliflozin, the HbA1c reduction was almost double than that of empagliflozin. We know with sitagliptin, the HbA1c reduction was also statistically significant. It improved the HbA1c even compared to liraglutide, even though it was not statistically significant, but you can numerically see that oral sema was even better than liraglutide in reducing the HbA1c. And what you can see here in the last bar diagram was, in addition to insulin, it reduces HbA1c to 1.2 percentage. Now, we know insulin as one of the most potent hypoglycemic, anti-hyperglycemic agent, where we can reduce n number of HbA1c percentage with oral insulin, injectable insulin. But we do have large number of patients who are on insulin, but still are unable to achieve the target HbA1c. And when added to baseline insulin therapy, oral semaglutide can further reduce HbA1c by almost 1.2%, and which is very significant because it, along with the HbA1c reduction, what it is also going to cause is weight loss. So we can see that in patients with HbA1c below 9%, there is a very strong 1.5% reduction in HbA1c with oral semaglutide compared to all the standard of care drugs. Now, as I said, coming to change in the HbA1c when the HbA1c is more than 9%, the baseline HbA1c more than 9%, you can see that on an average, oral semaglutide reduces HbA1c by more than 2%. So somebody with 7.8, 7.9 is expected to come down to 6 to 6.5, and somebody who is 9.5 or 10 maybe will come down to around 7, and that is the amount of HbA1c reduction that happens with oral semaglutide. So it's a very, very potent anti-hyperglycemic agent, and higher we know that baseline HbA1c, more is going to be the reduction with any drug for that matter. And when it comes to oral semaglutide, the average HbA1c reduction is around 2.6%. So in addition to HbA1c reduction, what we are now looking at as an upstream approach to manage type 2 diabetes, we want agents that can reduce weight. We had agents that can increase weight, then we came down to agents which were neutral, but now we are looking for agents which can cause weight reduction. And if you look at oral semaglutide, 5 kgs is an average weight loss that oral semaglutide can cause. As a monotherapy, you can see that 4.1 kgs with empagliflozin versus empagliflozin, there is 4.7. Even though the difference is not statistically significant, numerically it causes more weight loss than empagliflozin. We can see with compared to sitagliptin. Again, as I said, even though statistical significance was not achieved, numerical significance was oral semaglutide made patients lose more weight than 1.8 mg liraglutide. Of course, there are trials for higher doses, but with what is commonly available in India, liraglutide 1.8, oral sema is found to have larger weight loss. And of course, with insulin therapy, we are worried about weight gain. And when we add oral semaglutide, not only HbA1c goes down, but also the weight is lost, and on an average 5 kgs weight loss is expected. So in summary, when we use oral semaglutide compared to other oral anti-diabetes agents or in addition to insulin, we can see 1.5% reduction in HbA1c when the baseline HbA1c is less than 9%. In people with HbA1c is higher than 9%, we can expect 2.6% or higher HbA1c reduction, and we can expect 5 kgs weight loss. But I have seen individual to individual, the weight loss is different. I've seen people losing from anything from 5 kgs to 15 kgs weight. And if you continue them on for a longer period of time, I have a patient who is on oral sema for last 9-10 years, and she's constantly losing weight as the time progresses. So the weight loss in 26 weeks, that is the general time for trial, is somewhere around 5 kgs. But if the drug is continued, the weight loss keeps going, keeps progressing in the favorable path. So apart from that, if we look at from the point of view of people achieving the weight targets for oral semaglutide, 1 in 2 patients, that is 50% of patients, achieve a very clinically significant weight loss, which is defined as 5%, 5 to 10% of the current body weight, and 50% of people will achieve 5%, while almost 20% people do achieve more than 10% of their basal body weight loss. Now, is the weight loss in the right way? Are we asking the patient to lose the right amount of weight, or are we making them weak? So GLP-1 receptors, we know, work directly or indirectly by activating the hypothalamus and hindbrain that is involved in appetite regulation. They increase the satiety and remove the cravings for savory or junk food and correct the body weight. So it is happening in physiological way by reducing hunger, energy intake, and food cravings, in addition to acting on the satiety center, which prevents overeating and actually causes alteration in the food preferences. When it comes to body composition, semaglutide reduces fat loss, fat mass much more compared to the lean muscle mass. Of course, with any loss of weight, there is small decrease in the lean muscle mass also, but the significant amount of fat loss is found when the patients are treated with oral semaglutide. So, of course, when the weight goes down, all the risk factors that are very strongly associated with increase in weight, that is the signs of systemic inflammation, HSCRP, lipid parameters, and systolic blood pressure, waist circumference, also go down hand in hand along with the increase in weight. So, better outcomes when we start initially. We heard Dr. Erende sir in the previous talk that a higher time the patient spends in hyperglycemia, higher is going to be the rate of complication. So the early initiation of such a molecule that will that will act upstream or act on the basic pathophysiology rather than just acting on glucocentric approach is going to be going to make the patient spend lesser time in the hyperglycemia exposure. The patient is going to have the benefit of prevention of the long-term cardiovascular risk. So higher patient achieve when we start it earlier, the target achieved is higher. 8 of 10 people who had early initiation of semaglutide achieved the target of weight as well as HbA1c. Now, we know the legacy effect, and that is why we want the area under the curve of hyperglycemia in any given patient as early as possible to prevent the longer exposure. Now, it has been studied in a large canvas of pioneer trials and proven to be very safe to use oral semaglutide. The large database is available for around more than 5,000 patients. Even though the most common adverse effect was gastrointestinal, if we think pathophysiologically, even though these are effects that come out of the mechanism of action of the drug, and rather than calling them side effects, we call them as unfavorable effects because they're not exactly side effects. They are the how effect of the mechanism of the drug, and that is how the drug works. So if we explain the patient that this is how the drug works, it is going to cause it is going to act on satiety center and appetite center and make you feel like eating less, or sometimes it can go beyond that feeling and make you feel nauseated. But these are very transient and go away within a few weeks period of time, and after that the patient settles very well to the molecule. So they're very well tolerated apart from the initial gastrointestinal side effects. They are available for convenient use of a large population, including elderly people. There are no special precautions required for them. Hepatic or renal impairment, no dose adjustment is required. In fact, it is now given in patients who are undergoing hemodialysis also. So we don't really have to worry about renal and hepatic impairment. Patients with upper GI tract disease also has been shown to not affect the absorption as well as effectivity of oral semaglutide. So it can be safely given to a large population without worrying much about the organ impairment. Now, it's very important to take the oral semaglutide in a very proper fashion. First of all, we know that a patient is paying out of pocket for a huge amount for this molecule. Even though the effects are tremendous, we may lose the effects if the drug is not taken properly. That is why the instructions are to be given very precisely to the patient that the tablet has to be taken on empty stomach first thing after getting up in the morning with 120 ml of water, not very large amount of water or not lesser than 120 ml. Somewhere around 120 ml of water is required to be consumed along with the tablet. And after taking the tablet, the patient should not go back and sleep, because we have patients who get up in the morning, take the tablet and go back to sleep. So it's important that the patient remains upright after taking the tablet for some time. And these instructions are extremely important. Nothing else should be consumed along with the oral semaglutide, because it's going to hamper the absorption as well as the action of the molecule in the stomach. So remain empty stomach and remain upright for half an hour at least after taking the tablet. So these instructions are extremely important, because we know the innovation of oral semaglutide is in a fashion which is very difficult to have a peptide in a tablet. But this innovation that has happened makes us make sure that the tablet is taken properly and we give the maximum benefit of the innovation to our patient. So coming to the efficacy summary of oral semaglutide, we have seen that patients who have HbA1c of less than 9% have HbA1c reduction of 1.5, but the higher HbA1c persons will have higher reduction of up to 2.5 to 2.6. 5 kgs weight loss is expected on an average, but clinically, all of us have seen that the weight loss can go on and get higher as the patient continues the medicine as the time goes on. And it reduces all the cardiovascular risk factors that are associated with weight, that is systolic blood pressure, lipid parameters like LDL cholesterol, triglycerides, total cholesterol, and waist circumference, along with the fat mass as compared to the lean mass. So this is world's first peptide pill, even though that was not the highlight of the talk, but I think the credit goes for the innovators for developing a pill that can be given, peptide that can be given as a pill. It is very effective option for type 2 diabetes management, strong reduction in HbA1c, also weight loss. It acts through the central nervous system pathway to provide significant and sustained weight loss by working on the satiety center. We have seen that around 5 kgs or even more, and waist circumference loss of 4.7 centimeters or higher is also seen with oral semaglutide. It's easy to titrate, and we don't need to really worry about hepatic renal impairment or age of the patient to provide such a molecule. So those patients who can afford this molecule, I think, should be given the benefit of this molecule, which is the standard of care, which should become a standard of care in patients with obesity and type 2 diabetes. With that, I would again like to thank Dr. Vaishali ma'am for having me here to discuss about this molecule. And if there are any questions, I'll be happy to answer.
Thank you, ma'am. Thank you for the detailed explanation on oral semaglutide. The next speaker is delayed by a few minutes, so we will take the panel discussion with our panel.
Sure.
So the first question is to Dr. Sonali. Sonali, can you throw light on the use of degludec in pregnancy, GDM? Because till now we were not using degludec in pregnancy. So what is the latest data show?
Yes. So the latest data shows that it is safe. Now it is a class B recommendation. So we can definitely use degludec in pregnant women in GDM as well. So we have already started using it and excellent results. So no questions about it.
Okay. Thank you, Sonali. And ma'am, Anjali ma'am, what are the absolute contraindications to oral semaglutide in type 2 diabetes?
So, as such, allergies are considered as absolute contraindication. So if someone who is known to have allergy to any the active as well as non-active components of the drug is an absolute contraindication. It's generally avoided in patients who have a very strong baseline gastrointestinal symptoms. So even though I have seen a couple of patients whom I have explained that the gastrointestinal side effects may be different, and the molecule, the gastrointestinal side effects that come out of the molecule might be very different, but very severe gastrointestinal symptoms at the baseline are contraindications. Of course, we are not trying it in sick patients. We're not trying it in patients who are hospitalized as a molecule to be started or initiated. Absolute contraindication. Type 1 diabetes, right now, we do not think of it as a treatment modality in type 1 diabetes. Right now, we have no clear idea as to whether we can give them in patients who had gastrectomy, post-bariatric surgery. We don't know whether that will be useful or not. We need to have data. So right now, we're not giving it for weight loss after gastrectomy of bariatric surgery. Otherwise, I think there are very few contraindications as such for the molecule to be initiated. Then as the time goes, if the patient is developing severe gastrointestinal side effects, we might have to withdraw the drug. But to initiate, there are very few contraindications.
This question is to both of you, ma'am, Dr. Sonali and Dr. Bhatt. Is there any rebound weight gain on discontinuation of the drugs? Because of the cost constraint, some patients do discontinue after a couple of months or 3 months. So the weight loss, is it regained back on discontinuation of the drug? What is your personal...
There is some amount of regain which we have seen, definitely. But although it doesn't go back to where we began with. So thankfully, that is one plus which we can say. But having said that, I think that is why it is extremely important that when I begin dialysis, I always tell them the cost of therapy, explain to them that this is not something which we can start and stop and start and stop and do away with. It's like any other drug which you will have to continue. And if it is not feasible, let us not use it altogether rather than, this on and off effect. I don't know. Dr. Bhatt, what about you?
No, absolutely. When we are accepting a pharmacotherapy for weight loss, there is a very clear scientific thought that the effect will remain as long as you're taking the tablet. So there is no recommendation for discontinuation of the medication when it is accepted for a particular indication. Of course, diabetes is not going to go away, and the epigenetic environment for obesity is also not going to go away. Of course, when you are accepting a drug, the drug's effect will remain as long as you are taking it. But what happens is, it's a strong motivator for the patients when you start the drug. the patient loses weight very fast for initial few time, and that can become a push or a kick kind of a thing for patients to start on a very strong lifestyle modification. And there are patients who, after having the motivation of losing 10-20% of initial body weight, are more motivated to follow a good lifestyle. I think the coming time will give us more information whether after discontinuation, whether patients are able to do. But I feel that patients who are on medications and are seeing that the weight is going down are feeling more motivated to follow the nutritional advices as well as exercise. And some mechanical issues also come when you are extremely overweight. So with losing some amount of weight, you can overcome the mechanical issues and are in a better shape to exercise than when you are extremely overweight.
Yes, ma'am. Thank you, ma'am, for the enlightening points. Another question for both the panelists is, any midway between up titration, is it 3 to 7 straight, or is there any mid doses which we can try between 3 to 7? Because some of the patients don't seem to tolerate 7 well when we up titrate from 3 to 7.
So I have used a strategy where I'm using, if people are not able to tolerate 7 milligram from 3 milligram, what I'm doing is, after I ask them to alternate it for 2 days of 3 mg, 1 day of 7 mg. I think that works well with some people, whether the nausea doesn't go up to that extent. At the same time, you're maintaining a good level of the drug. At the same time, you're having all the benefits associated with the drug. Over to you, Dr. Bhatt.
I don't think I have much experience on patients who are not able to tolerate 7 mg. Because at such 3 mg, 7 mg are quite small doses. Because I have seen most of my patients tolerating 7, even 14 mg very well. If you do it slowly, take your time, let the patient be very, very comfortable with 3 mg and then initiate 7 mg, that has a higher success rate. Because now they're coming up with 25 mg, 50 mg of oral semaglutide. So I think we should not be worried about unfavorable effects of 3 mg and 7 mg is what I would like to say.
Thank you, ma'am. And how to convince the patient, or once we start semaglutide, what are the do's and don'ts for our patients, which we should be counseling about?
Yeah, so like Dr. Bhatt has told us about the technique, that is very important. Very true that patient has to be upright, cannot go back to bed. Many people do that because it's first thing in the morning. So in fact, you can ask them to go around for a walk. That would be still better, because then that waiting period, they are not so anxious about that. I don't have to eat for another half an hour. So that kind of anxiety goes away. I think do's will be mainly that. Yeah, don'ts is that we can't combine it with any other drug. So yes, patients who are taking thyroxine, yes, that has to be monitored well, because then the dose of thyroxine, the bioavailability does go up. So I think some studies have said that taking it at bedtime, late in the night, thyroxine, and taking your oral sema Rybelsus early in the morning does help, because that's what we've seen with our patients. Other than that, nothing more, because the 3 mg is very, very well tolerated, I feel. 7 mg, yes, some people do not tolerate it very well, but I've gone up to 14 also. So I think it is really decently tolerated if started early. I think younger population does very well. So do not hesitate to use it early in the course of the disease. I think it's excellent drug.
Yes, absolutely. I totally agree with Dr. Sonali that the instructions regarding how to take the drugs are very important, because you're popping a pill which is 300 rupees per day. It should be given in a very proper fashion, and all the benefits of the drug should be extracted. That's why the patient has to be given those instructions written down, told by you, told by the person who is explaining the drug. Ask the pharmacist to tell the patient to take the drug in that particular way. Bombard the instructions of taking the drug properly. Don't take anything else with the drug. Secondly, I personally feel that I do not ask them to follow a particular nutritional advice along with the initiation of the drug. I often tell them that you be comfortable with the drug first, and then we will start the nutritional changes that are required. Because if you bombard them with both the instructions together, then one side they feel nausea, and other side you have given them a diet chart which says that at 8 o'clock you have to eat this, or at 10 o'clock you have to eat that. that becomes very confusing to patients. So as a personal tip, I would say that I don't give nutritional advice and the drug at the same time. Let them be comfortable with the drug and then start slowly the change in the diet pattern that we want to start.
Thank you, ma'am. And any data, Indian data on use of oral semaglutide in non-diabetic patients? Has it been tried?
No, we'll have to wait for the results. Right now in India, it's
No.
not recommended for non-diabetic obesity.
Yeah, it's not licensed for any non-diabetic use.
Yes.
That's true.
But off record, is it used by any?
No.
Let it be off record.
Yes.
Okay. Okay. Last question, ma'am. Is it only because many clinicians in various forums, when I've spoken about semaglutide, they seem to be of the idea that it should be used only within the first 5 to 10 years of diabetes, early diabetes. They don't feel that when the patient is having an established diabetes of 20 to 25 years, vascular disease, vascular complications. So how do we bust that myth which is in the mind of the clinicians?
No, actually, GLP can be used at any stage of the disease. I strongly believe that. I have used it even with insulin with people who have diabetes since last 20 years, and I've got excellent results. Not only the dose is lowered, the glycemic variability is so superbly affected that you can actually demonstrate it with the CGM to the patient, and it is really mind-blowing. So even with a small dose of 3 milligram also, you're able to set it right. So I think definitely
does it
that
lead to
be
decrease in doses of insulin, Sonali?
and improve the variability. So with insulin, like we talked about hypos, yeah. So there are a lot of people have hypos. We know that, right? We see that in our practice. So when we are adding Rybelsus to this group of people, so what we've seen is that the variability reduces, the A1C improves, and the hypos are out. So because you're going down, you're reducing the dose of insulin concurrently, and that really helps a lot. Over to you, Dr. Bhatt.
Yes, absolutely. I have a very good experience personally in using this drug with patients on dialysis, because there we are worried about insulin causing weight gain, dialysis, CKD causing water retention, and higher doses of insulin and extremely high glycemic variability. On the day of dialysis, the blood glucose goes down. On the day of non-dialysis, the glucose goes up. So it works wonderfully. And as we know, dialysis is the end spectrum of type 2 diabetes progression. So there is no stage where GLP-1s are actually contraindicated as such. You can use it in any stage. As early as possible is better.
Any lowest limit of EGFR below which we should not use, or we can use it?
We can use it in all stages, including dialysis.
Okay. Thank you, ma'am. Thank you for all the inputs by Dr. Sonali and Dr. Bhatt. So I think we will wait for Dr. Hemant Fatale to join us for the next session.
Thank you. Thank you so much,
Thank you,
organizers. And thank you, Dr. Andu.
Thank you.
Thank you so much
Thank you,
to the
everyone.
speakers. We really appreciate you guys giving your time here. You all are really busy people, but thank you so much for your expertise today, and we appreciate your efforts. Thank you.
Thank you. Thank you, everyone. Thanks.
Dr. Kuberan, madam?
Yes.
Madam, sir will be joining in another 2 minutes shortly.
Okay.
This is what the backend team has told me. So
Okay.
if you could wait for
Yes, yes, definitely.
Sir, join, ma'am.
Oh, he's joined.
Yeah.
He's joined.
Hello, sir. Good evening, sir. We were all waiting for you. So a brief introduction about Dr. Hemant. He has been established since August 1996. He is the Vice President of Maharashtra Endocrine Society. He was faculty in Asia Pacific Obesity Conference, was faculty in accredited scope by World Obesity Federation, trained more than 100 physicians and gynecologists in certificate course by PHFI, and established a unique childhood obesity center in 2006. So now sir will talk on insulin co-formulations, unraveling the strong wall of evidence. Over to you, sir.
Can I have slides, please? Should I get it?
Any help required, sir?
The backend team, could you please help sir with his slides?
Okay, slides are there.
Not yet.
Okay, just I'll download from and then I'll present it. Just hold on.
Okay.
I thought you have the slides.
No, sir, we don't have, yes, sir.
molecules. So any audience question or any questions which you think are relevant to these topics probably can help us in taking the discussion till the time the technical glitches are available. So if we have doctors online, Dr. Erende or Dr. Anjali or yourself, whoever.
First, till the time they get the...
You can share your experiences on semaglutide and Rhizoteg and other molecules till then. Maybe that will be helpful.
Yes. So the take-home message till Sir gets his slides is the take-home message about Dr. Sonali's talk on Tresiba, that is Degludec. Till now, we were having that handicap of not being able to use it in pregnancy, the GDM patients, because of the recommendations. They're not enough for the use of Tresiba. But now it has been approved and we have all started using Degludec in our GDM patients with very good results. So that's a welcome change, and this should be, the clinician should know about this development in the field of diabetes. Secondly, about oral semaglutide, in my experience, I've used in certain clusters of people in my experience, especially patients with pre-diabetes and PCOD. Nowadays, girls are very much, they marry late and they are into work. So they plan pregnancy really late, in the end of their fertility cycle only, they plan the pregnancy. So I think if Sir is ready, then I will cut short my experience.
No, you can go ahead by the time he shares his presentation.
Yes. So this particular cluster of patients, pre-diabetics with who are planning for pregnancy, I get calls from gynecologists saying that, ma'am, inka thoda sugar control karo, then we can go ahead with IVF in the in vitro. So, but the girls and the families are really apprehensive when they come and sit in front of me. And what I noticed from them is that they are extremely anxious, the whole family. Secondly, the girl is really overweight. And if we put them on basal bolus insulin, sugar levels are high. So actually, till now, the practice is we treat them with insulin. Because in case the IVF is successful and the lady gets pregnant, we can only continue metformin and insulin. We cannot use other molecules during her pregnancy. So I have a heart-to-heart talk with these patients and their families, and I tell them to postpone this IVF and all this pregnancy for 6 months. Let's put her back into health, and then we plan for pregnancy. And most of them buy this idea. And the most important molecule I use in this cluster of patients is semaglutide. So I start off with 3 milligram, but taking an undertaking from them that they will not try to become pregnant in the first 6 months. So they are put on Rybelsus, and the appetite comes down. They start losing weight. They become more positive. And in fact, two patients of mine, they became pregnant in the natural way without IVF, with weight loss with semaglutide. Of course, semaglutide has to be stopped once they become pregnant. But this is a really game changing.
I agree with you that insulin. In fact, I have a lot of patients on semaglutide with basal insulin. So I think now I'm very happy that Tresiba is now approved in pregnancy also. So I just have to withdraw the semaglutide. So I'm really happy about the fact that now I can use Degludec in pregnancy.
So this
So,
is a
sir,
good
are you
cluster of
ready?
patients.
Sir, are you ready? I can't hear.
He's in
So
mute
you're
now.
on mute. You're on mute.
His internet connection is weak.
Yes, I'm ready.
Yeah, please go ahead, sir. Please go ahead.
Okay.
Madam, we'll continue after sir's talk. I think that was an interesting discussion.
Okay. Is my slide all visible?
Not
Yes,
as
ma'am.
yet.
We'll continue later.
Yeah.
Okay. I need to share. Need to share the screen, no? Just hold on. Yeah.
Darshan, can you help him?
It's okay. Casting will just start now. Soon we will access. Okay. And
Or we can play it at our end if we have received it.
that's actually the you are not having the.
Yes,
that's
ma'am.
the problem.
Just receive PPT, ma'am.
So I think Darshan, you share it. That would be better.
Yes, ma'am. Shared already.
Okay, fine. Sir, they have already shared. You can just carry on.
Okay. You have slides then?
Yes, sir. We have the slides. You can go ahead.
Okay. Okay. Fine. Good evening. It's evening now. Sorry for the late and the concern which all the troubles which today is about the maybe an insulin co-formulation and revealing the wall of evidences. And as you see on the wall, there is a there are two pins are there. That is randomized control trials and real world evidence as such. And with that, actually, we in addition to that, there is some clinical guidelines also we're going to talk about that. What about talking about this the insulin co-formulations? And when you look at that, this insulin actually discovered in 1921 with Benting and Best actually invented. And from that onwards, it's a continuously we are getting invention, understanding the molecules and engineering of the insulin and developing the various analogs. And before developing analogs, we reached from the animal insulin to the human insulin. It was 1980 where human insulin being introduced. And this human insulin is having a clear-cut advantage of purity and a better outcome. But at the same time, these insulin are not able to tackle the hypoglycemia part of it and the milk flexibility part of it. But later on, there is it's a better engineering with insulin Lispro. Then insulin Lispro mix were made available, and with that we have got some like the biophysic insulin which was able to developed by Y2K, and with that we are able to little bit lifestyle flexibility in terms of milk flexibility with better control, with less adverse events and less hypoglycemia as compared to the human insulin mix formulations. And then by 2018, it was the two insulin formulations separately, which put into the one solutions, and that is the insulin degludec, which is a dihexamer. After entering into the subcutaneous tissue, it becomes multi-hexamer. And at that time, insulin aspart, which is also a hexamer, but it can be immediately released. And this combination in a cartridge solution doesn't get mixed with each other. When you inject subcutaneously, it also doesn't get mixed each other and released separately. With this background, it is more potent with least hypoglycemia and a little bit more flexibility, and achieves equivalently addressing the fasting as well as the prandial glucose. And this is how we evolved over a period of time. It was 2013 when this insulin two formulation put together with the combination which is available in market. Next slide, please. And this is how it has been shown the dihexamer of the IDEC, which is 70% in a combination, while there's a single hexamer which is in a short acting in a which is 30% in a combination. And next, please. When you look at this actually the long acting insulin once appear in a subcutaneous tissue becomes multi-examer, and zinc being used, it is slowly released, as against is a phenol being used as injectable, it will immediately release of the short-acting examer like aspart, and that's how the diagrammatically very beautifully has been shown. This next please. So you can experience this real one. Next. This is how these two, and next please, and this how the short acting immediately get resolved. Next please. And that's how aspart has gone away, immediately release, and it was a zinc which caused slow release over a period of 24 hours and maybe up to 36 hours of release of insulin degludec, which is better than the glargine. Next slide please. If you look at this, actually this 0.6 unit per kg in 22 patients has been studied, and this is how the peak which we have got, immediate peak of aspart, which is shown in a light yellow or orange shade, while the green shade which is showing a long-acting insulin degludec, which is a peakless actually insulin, which is over a period of 24 hours, is the ideal combination of two formulations in a single with 30-70 combination with this IDEC aspect. Next, please. So if it has, it's a basal insulin which is built in with rapid acting component of aspart, and this is basically it when it takes in the morning, it addresses the prandial glucose because of immediate release and long duration of action, which controls fasting as well. So it's a basically, we Indians are a high carb based diet, and hence we have high prandial glucose, and the patients which usually are uncontrolled with multiple OADs. It is the drug of initiation, and the safety is proved beyond doubt with less chance of hypoglycemia. So if you take an immediate release of short acting and over a period of peakless insulin over a period of 24 to 36 hours with IDEC. Next, please. So after understanding the pharmacological part of two formulations of IDEC and aspartame 70 and 30, let's move towards phase 3 clinical trial. And phase 3 clinical trial, which is 3A and 3B, and where it has been controlled with an maybe with that, it's a type 1 diabetes has been compared with an routine formulations, then with maybe and associated with an glargine part of it, type 1, in type 2 also, and 3B also. It has been further, this population has been seen in fasting and prandial control, and over a period of time with various type 1, type 2 versus insulin, glargine 100, glargine 300, and routine human insulin as well. And next, please. And we came to know that this is better glycemic control with least chance of hypoglycemia, better prandial control, and when with an insulin new patients with compared in a type 2 diabetes, almost 296 with this randomized trial, as compared with an IDEC aspart, with as an once a day with or without oral diabetes, which is 147 populations, with insulin glargine U100 with or without oral anti-diabetes, 149 populations. When we compare these two, and we can say that is better fasting control, better prandial control, as against only fasting control with the insulin glargine U100 in these two populations. Next, please. So there is a superiority of A1C reduction as well in this IDEC aspect combination, 1.4% superior reductions, and the prandial glucose is 50. Average prandial glucose is reduced by 57% more with prandial than the IDEC insulin glargine U100. Next, please. So 72% of more patients is being on better control with least hypo. The next week's compared with this iodine aspart with the basal bolus therapy. And where is the one group where there is an iodine aspart once daily with an oral antihypoglycemic agent, while this other group is that either with insulin glargine plus aspart as meal related, that is bolus part of it. When we combine the glargine with aspart, that is basal bolus, while the iodine aspart either once daily or twice daily with or without oral hypoglycemia, and we compare these two, it is found that the dose requirement is much more less with the two formulation combined together versus the basal bolus therapy. And similarly, the nocturnal hypos is much more less within a two insulin formulation rather than a basal bolus therapy. That's how it has a little upper hand with the basal bolus therapy when it's compared to the two formulation twice daily in the management of type 2 diabetes patient with secondary OH failure. Next, plus. And when this iodine aspect is compared with the insulin glargine U100 plus the iodine aspart once a day only, that is only the major meal related short acting. And when you compare that with the iodine aspart once daily, or maybe an aspart with twice daily meal related with an U100, and then the digludec formulation twice daily. And this is from base. This has been first 26 weeks. It has been compared with the two formulation versus glargine 100 once daily versus aspart once daily. And after that, that is we have the next group will be after that the changeover, and then we'll see the results. Next, please. So iodine aspart has achieved almost a similar improvement as far as fasting and A1C as compared to the basal bolus therapy. The 6.6% significantly lower dose requirement in a two formulation versus the chances of hypoglycemia, especially the nocturnal hypoglycemia, which were less with the two formulations than iodine insulin glargine with short-acting aspart. Next, please. When you compare this again, iodine aspart versus basal insulin, the changes in the mean self-measured blood glucose and the changes in mean self-measured the glucose in the glargine and the short-acting aspart. If you look at that, the iodine aspart significantly reduced the mean self-glucose measured glucose level and the prandial glucose as well as compared to the basal insulin. So it is the advantage when you take the glargine, which is basal insulin, and one short-acting aspart, then you have a combination performs better than a separate using in terms of prandial glucose as well as the hypoglycemia is concerned. Next, please. Next slide, please. After that, we should randomize trial. We could move towards a real-world evidence. And when real-world evidence, the insulin initiation in a secondary OH failure with type 2 diabetes. So how does it, two formulation, if you start, it helps it. So change in A1C reductions, percent of change in A1C reduction is compared with the glargine alone, when compared with the glargine alone with U300, and two formulation together. With that, the A1C reduction is better in percentage as compared to the two other formulations. So iodine aspart caused statistically significant greater reduction in A1C as compared to the basal formulation of U100 and U300 of glargine. This is the presentation which was done in a poster presentation in IDF 2019. Next, please. In the same poster, when he compared, that is change in a fasting, and if you look at the prandial change, the significantly better fasting reduction with these two formulation than the basal IGLAR U100 or basal IGLAR 300. Of course, the better prandial control is with the two formulations, which is short and long acting as compared to the basal U100 and U300 glargine. So change as well as fasting and prandial is better with the two formulations than the basal formulation of either 100 or 300 glargine. Next, please. So when we compare the insulin dose total requirement, the proportion of patients reporting hypos in these two populations, the significant increase in insulin dose is requirement in a glargine U100 arm, non-significant increase in the glargine U300 and the two formulation IDEC aspartame. There is no significant difference in hypo occurrence between these three groups in this particular study about. Next, please. When we talk about the intensification, then if you compare these two formulation versus the basal glargine U100, and that is the time to treatment intensifications in both the arms is 11.98% versus 6.71% in a IGLAR group. So the significantly fewer subjects on IDEC aspart required dose intensification, and additional time to treatment intensification was significantly longer in subject with the two formulations, like IDEC aspart, when compared to the basal insulin glargine U100. And that is the intensification has a upper hand with the two formulations than a single UGLAR U100 basal part of it. Next, please. And the next real world evidence of switching from two formulation from U100 or U300, and it's how do we go about the insulin doses? The significant reduction in the basal as well as total daily insulin dose was with the two formulation after 26 weeks. We look at the diabetes therapeutic quality of life, the significant improvement in a total the quality of life when score with IDEF aspart. There is dual formulation in terms with patients with HbA1c reduction more than 7% as such. 74.2% of the population is preferred to stick to the two formulation than a single formulation. So switching to the two formulation associated with the lower total and basal insulin dose requirement and a significant improvement of quality of life with better glycemia and comparable fasting hypoglycemia and better prandial glucose control, better prandial glucose control, and thereby A1C as well. Next, please. So if you look at the impact on quality control and the treatment preferences, this was a single center survey. Adult type 2 diabetes treated with a two formulation, 26 questionnaires, 245 were enrolled. 94% managed to their day-to-day activities better with these formulations. 89% had improved quality of life with reduction of number of breaks, and 86% found comfortable to inject two formulation in a different social situations. So reduction in number of injection pricks, flexibility, simplicity of dosing with two formulation translates into a better quality of life. That's what this study tells us with to us. This is single center survey. Next, please. So reduction in pill burden, when we talk about it's a IDEC aspart as a better cost effectiveness in terms of number of pills and be reduced, and better control, so less drug required, and with least hypo. So yearly total cost is, if you look at this cost as compared to the all treatment cost, and then with IDEC as part, and total daily cost, which is that is almost saving more than 3,000 per month cost. So this IDEC aspart is more cost effective for people with type 2 diabetes, not achieving target glycemic control on other therapies in routine clinical practice. So this formulation has better glycemic control, better prandial control, comparable hypoglycemia, even least chance of hypoglycemia, and with on the top of which is more cost effective. These are the few studies, either randomized trial with poster presentation in IDF, real world evidence, which tells us when we compare to the basal only euglargine 100 or 300. Next, please. Next slide. So with this, we are just looked upon the randomized trial and some real world evidence. Now some we move towards and the guidelines. What the guidelines says, the RSSDI 2022 clinical practice guideline recommendations. So it is these two formulation IDEC aspart is recommended as a choice of insulin initiation, and it does not produce shoulder effect 4 to 6 hours post injections. It causes least hypoglycemia, requires fewer doses, causes least weight gain, and has the flexibility of administration before any large meal of the day, and can be given with different meals on different days. So it is one of the recommendation from the clinical guideline. Important, that is RSSDI is a nationalized diabetes guideline forming, and it has weightage. Many clinicians do follow, and it does recommend. It's a drug of choice for initiation of when insulin is required in type 2 diabetes, when the secondary OH failure, the oral hypoglycemia does not work properly. So it's preferred because the lower chance of hypoglycemia, fewer dose of requirement, and the flexibility of administration. It can be given at any major meal before in a daytime, and that's how it's a one of the recommendation. It is also recommended with an Endocrine Society of India. It is a common guideline now, which has been formed by the Indian Society of Endocrinology as well as the Diabetes Research Study Group of Diabetes, RSSDI 2022. And friends, that's how we learned today these two formulations like IDEC aspart 70/30. The two insulin analogs, ultra long acting, short acting, can be mixed together in a solution which is stable in a cartridge. It means it's taken a prick in a subcutaneous and it still remains stable, and separate, release separately, and that's how it control immediate control with prandial control with aspart, and basal insulin, peakless insulin, IDEC 70% over a period of 24 to 36 hours is a better control of that, and which is actually help in a reduction of the daily dose requirement. Flexibility can be taken before major meal, and on top of which it is less hypoglycemia, better A1C control, and it saves some amount of money in a long-term duration as far as the prick is required. Less insulin, the oral hypoglycemic agent also been need to cut down, and being a better control is a lesser chance of diabetic comorbidities, and is thereby saving some amount of money. So long term, long run, it is helpful. The clinical guidelines says in such fashion as well. Next, please. So there are some practical considerations. So initiate with, and this is what largest meal of day. They initiate with 10 units of these formulations once daily with any major meal. So This is once daily with most carb heavy meal of the day should be preferred. And once it is over a period of time, this your glycemia worsens, A1C worsens. This can be given twice in a day with two major carb meals, and that's how we can able to control the fasting, pre-meal and the post-meal sugars with and grace of less hypoglycemia, better A1C control. So it can be used in a twice in a day with two major meals before heavy meals of carbohydrate meals. Next, please. So weekly titration using a simple algorithm, like if your fasting is above target, you can choose to increase the dose by 2 units, maybe and before dinner. If fasting is control, maintain the night dose. If, if fasting is low, then you can cut down the 2 units before dinner as such. Next, please. And if you look at that, if your prandial glucose is high in the afternoon time, maybe you can increase the morning dose. In the evening time, it is high. You can add and short acting at the before uh, uh, major meal in the afternoon. But by and large, if you're concentrating in a fasting control, you can tackle the doses at the night doses. If you have prandial glucose in the afternoon, we need to act on the morning doses of these two formulations, and that's how it is a better control in this fashion. These 2 units is arbitrary. It can be changed from the patient to patient. It can be to begin with 2 units, but you can titrate up titrate or under titrate depending upon the patient's response from time to time. And we all know the responses varies with the same patients, maybe at the same dose, maybe at different because of activity, because of the food choices, because of the eating pattern behaviors, maybe stress, and a lot many factors which comes in. But this is how we can act. We should have fasting. It should be fasting to be you need to act at the before dinner. If you took to prandial afternoon, you have to act in the morning doses. Next, please. When you try to switch from other insulin formulation to iodine aspirate 2 formulations, then when if you're using basal insulin or premix insulin once daily, you can begin with an 2 formulation once daily, and if required, can be add on to another one that is twice daily. If you have the basal premix already in twice daily, then you have to begin with twice daily, and we may land up with an either once daily or may require continuing a basal bolus. But you have a basal bolus, you need to be has to be individualized depending upon the patient's carb content, major meals, and of the patient eating behavior patterns. That's how your patient's eating behavior, your exercise behavior, and the stress which patient have is, and his daily routine, sedentary lifestyles or not, and that's how you and the patient response of glycemia in terms of your treatment. That will guide you the further modification of the insulin, and in terms of intensification, glycemic control to avoid hypos, and all that is required to keep your. What is more important to achieve target A1C of 7%? With least glycemic variability, with least chance of hypoglycemia. If at all hypoglycemia, we have to make them aware that patient on insulin, how to recognize it, hypos, and tackle it early, and then what steps to avoid further hypoglycemia. That all we need comes in the patient educations. We all are quite aware of that. We all are practicing about that, and we're going to practice that as well. So next slide. And so that's all, friends. And this insulin 2 formulation, which is actually introduced in the market almost a decade back, and these get to each other it is always associated with a better control. Along with that, the control is equivalent to the basal insulin, glargine 100 or 300. And having said all this, is diabetes management is the lifestyle patients, that there I have seen patients with taking hundreds of insulin morning and evening come with the sugars of 400 and 500, which is not acceptable. This is a disease of lifestyle disorder. Unless you change your lifestyle, this is not going to improve. The pharmacotherapy, how costly or how effective it is will not be effective unless and until you change your lifestyles. So change yourself first. You are the driver of your life. Unless you change, these things will not change. This is to be important part of communication with the patients, and the patient should be sit on the driver's seat of management of diabetes, where the doctor only guide and the patient should drive. That's what the motto. Over to you back. Any questions? I'm happy to answer.
Thank you, Dr. Hemant. That was a wonderful explanation about insulin co-formulation. But your closing remarks was the most important of all, that lifestyle modification scores over all the pharmacotherapy. And I congratulate ma'am also on this conference, which is one of a kind, Synapse 2023, which actually focuses on holistic approach rather than pharmacological approach. So one question on this co-formulation. In many forums, when I've spoken about co-formulation, many clinicians, even diabetos, think that it is a OD dose. They do not understand that it can be given at a BD dose. So any inputs on that, sir?
See, if you look at the combination, that is short acting and a long acting.
Yes.
So we are taking a meal maybe in a daytime 1, 2, 3. And so we need each meal, we need a bolus.
Yes.
Each meal is, and we are not eating, we need a basal. So if this understanding is there, there should not be confusion occur, should not occur confusion. So taking 2 meals, major meals, we need 2 doses of these 2 formulations.
Dr. Indumati, I had just a comment to make on what you said. So I feel that all these techniques of insulinization will work better when you think of other aspects also, like you think of diet, you think of monitoring, you think of exercise, you think of mind health, and all this put together is going to help the patient take the insulin properly and compliantly. So I think holistic management is not only a need of insulinization, of all therapies for that matter. And when we are talking of long-term non-communicable disease, I think our job as doctors is to help them get better through drugs and through non-drugs, and everything put together from our side. We are healers finally. So we need to help for the betterment of the patient. And I think insulin now, what I can see with the symposium giving the overview of all the 3 molecules, I think semaglutide, degludec and Ryzodec, that is the co-formulation, all have added a better quality of life to the people. So I've seen a lot of semaglutide patients lose good amount of weight, get fertile, get pregnant, and it was impossible till we had such drugs in the market. Similarly, we have degludec now in pregnancy, and that's become a ease of treating gestational diabetes. And Ryzodec as a co-formulation has eased out the OPD management of diabetes. So I think Dr. Fatale has done a wonderful job of putting this in perspective and explaining it to the audience. So you can go ahead with the questions if there are any.
There are no questions in the chat box, ma'am.
Yeah. So if you have any for Dr. Fatale.
No, ma'am.
Thank you, Vaishali, for the opportunity and invitations and for the communications. Wonderful, hectic job you have done. And I congratulate you.
Thank you, sir. And thank you for doing an excellent deliberation. Even in the hall A, your talk was highly appreciated. And I think this talk was also very elaborate. So I'm glad you could make both the talks at the spur of the moment. And thank you so much for being here. And it's always a pleasure to listen to you, sir.
It's always pleasure to be with you, all the synapses.
Thank you, sir. Thanks a lot.
Thank you, ma'am.
Indumati madam, it was pleasure to have you, and very nice moderation done by you. I would have loved to be with the other guests also, but I think there were some technical issues, so we could not meet them. But nevertheless, the symposium, I think, had a good feedback, and I'm sure the audience will have a lot of learning points from the same.
Thank you, ma'am, and thank you for the opportunity. And it was wonderful.
Thank you so much. And over to you. I think this is the last talk, no?
Yes.
Yes. So I think then now we can leave this hall and join together at Hall A for the valedictory then.
Yes, ma'am. Thank you.
Thank you. Thanks a lot.